start from the top. L is Metcalfe-Perthes. I, limping child is a very challenging sort of thing to work up. Why? When a child is limping, one, A, they're not going to be able to tell you exactly where it's come from, say they're a toddler or whatnot. But the other reason that it's a little bit difficult is that when a child is limping, the pain, the etiology of that limp could be anywhere from the low back to the hip, to the knee, all the way down to the toe. So it's imperative that we do a full physical exam all the way from the toe, all the way up to the hip. The other reason that it can become a little bit challenging, as you'll see as we start to talk about some of these diagnoses, is that children sometimes will complain of knee pain when the etiology is really the hip. This has to do with the afferent and efferent nerves in the hip sort of leg distribution, but a kid could be primarily telling you, like, this is my knee, but it's actually the hip. Pediatric hip anatomy. This is really critical in sort of understanding why some of the pathologies exist the way they do. Kids have ossification centers. So from birth all the way up until early to late childhood, kids will not have a fully formed hip. Compared to adults that have big, strong, sort of like articulation sites with all the ligaments and muscles well formed, children, it takes some time for the femoral head and the acetabulum to kind of lay down bone and grind and become that strong architecture that we're looking for. And so, as in the early days of childhood, the hip joint isn't as strong as it will be later on in life. One of the reasons this becomes challenging is, has anyone ever looked at a hip film in a young child, an infant baby? Those are not easy to read. It looks like a kind of this free-floating femoral head, almost doesn't even look articulated with the acetabulum. So it makes some of the interpretation of the pathologies a little bit challenging. And then the last important concept here with the pediatric hip anatomy is, on the growth plate, there is a continuity between the bone, the growth plate, and the joint. This is not true of adults once everything is fully formed. So in an adult, if you get osteomyelitis of the leg or the distal femur, you typically won't develop a septic joint. But that's not true in kids. In children, you could get a septic joint that is contiguous with the infection in the bone, like an osteomyelitis. So we'll start with the earliest stage of childhood, the neonatal stage. So we'll start with neonatal congenital hip dysplasias. Hip dysplasias are generally diagnosed, or developmental diseases like this where you get a congenital hip dislocation are generally diagnosed in the hospital by a pediatrician or as an outpatient. However, these can be missed, and I think it's imperative that we think about this when you get a neonate in the ED and you do the sort of like the exam that would check for what a hip dysplasia would be. So hip dysplasia, basically, if you're looking at the illustrations here, if you look at the illustration on your left, you can see that the femoral head, as it's trying to insert into the acetabulum isn't totally well formed. It's sort of shallow, and so it becomes prone to constant dislocation. This tends to happen in firstborns. This is a small percentage of deliveries, about 0.4%. It can happen in breech deliveries where some of the anatomy gets distorted. And the way that we check for this is there are two tests that you may have heard of before, the Barlow and the Ortolani's, which I constantly forget, but I'm going to give you some tips to try to remember exactly what these two tests are. You can see the first slide is actually Ortolani. I'm going to skip forward to Barlow, because actually in the order that we should be doing these tests is Barlow and then Ortolani, B before O. And so what the Barlow test does and what the Ortolani test does is, it's kind of cruel. You're actually forcefully trying to dislocate the neonate's hip, and then the other maneuver is bringing it back, relocating it. So what the Barlow test is, the way I remember Barlow is back. You're pushing the hip back. The first thing we do is we flex the hip and flex the knee, both at 90 degrees, and you do one hip at a time, and you push back on one hip, and you listen or feel for a clunk. And if you feel that clunk, that's an easily dislocation. You're not looking for like little clicks. You'll actually feel a clunk as the femoral head pops back behind the acetabulum. And then I'm going to go back to the Ortolani. So the second test, Ortolani, I remember as O, out. So the Ortolani test, you also flex the hip and the knee to 90 degrees, except this time you abduct their hip, and that will get the hip back into its original position. Or if it's not getting it back into the original position because it wasn't dislocated in the first place, you'll get some resistance as you're trying to bring the leg all the way down to the bed. Now, if this becomes positive, the diagnosis that you then would pursue is an ultrasound to look for this dysplasia. And then you would refer to a primary doctor and an orthopedist. Has anybody ever seen sort of like the Pavlik harness that these kids go into? It almost looks like a lederhosen for little babies going to their first Oktoberfest or something. But a lot of times they get better just with the harness. And if the harness doesn't work, then they'll consider operative repair. Let's go forward. So that is hip dysplasias, Barlow, Ortolani, and refer. Here's a nice slide for reference. I'm not going to go through this entire slide, but it basically takes that limp differential that we talked about and groups everything by age. And so that you'll know what probability that you'll have at various age groups of having certain pathologies. And so I'll highlight a couple things in this chart, but the first thing that I'm going to highlight is on the very top line where you see infectious, you'll see septic arthritis and transient synovitis. These are two diagnoses that are really important to distinguish from one another. And as you can see, it's difficult because the age ranges actually add up. They tend to happen in toddlers and children. So we'll talk about some tips, tricks in terms of distinguishing those two diagnoses. And then if you jump down to the bottom line and you look at the degenerative, you can see in sort of the children, the pre-adolescent age group, 4 to 11, you see leg calf perthes. And in the adolescents, you see the SCFE. So that is important too in terms of distinguishing those two entities, and we're going to talk about those two actually right now. So leg calf perthes. Leg calf perthes is a idiopathic avascular necrosis that occurs in pre-adolescent children. And this can mostly happen unilateral in the majority of cases, but 1 in 6, 1 in 7 kids will actually lose the lottery and get this in both legs. And it can be associated with a variety of conditions like sickle cell, steroids, that kind of thing. And the way the child will typically present, this pre-adolescent child, will likely be just a limp. Maybe some hip pain, maybe some knee pain, but they won't look very toxic. And what we would do in terms of pursuing a diagnosis is to get a radiograph. Now the radiograph, when you look at the radiograph here, which side looks abnormal? It's great when you have both sides to compare. On the child's right side, that hip looks fairly normal. Not normal compared to an adult, but that's with all the growth plates. The left side looks totally eroded. You'll often hear this referred to as sort of a moth-eaten appearance of the left femoral head. And so this is a pretty easy case to pick up because it's so eroded. But oftentimes when a kid comes in, it might be earlier on in the course of the disease, and the only finding, it may be normal, like that right leg, because they're susceptible to bilateral disease, may actually have early leg calf perthes that we're not picking up on the x-ray. The very first sign that you might see is something called a crescent sign. It's sort of a cortical lucency that denotes a fracture in the subcortical part of the femoral head. And then it can progress to something like this. So what do we do with patients with left calf perthes? Actually, the younger the kid is, the better prognosis they have. So you can discharge these patients, for the most part, and refer to a pediatric orthopedic, and then they'll get ice, NSAIDs, some therapy, and a lot of them will avoid surgery. The earlier you get it, the more likely actually it is that you're going to recover. In contrast to slipped capital femoral epiphysis, SCFE, if leg calf perthes is the more benign diagnosis, this is the one that you definitely don't want to miss. So SCFE occurs in more the adolescent age children, and more in sort of like overweight adolescents is the typical child sort of profile that you'll see. And a lot of times these can be bilateral, up to kind of a third of these will be bilateral. And the way that these kids will present is they may complain of hip pain, they may complain of knee pain, they may also have a little bit of external rotation in their natural position. You can see here sort of the Charlie Chaplin stance. They may present in a little bit of external rotation, which would be of concern. And then on the radiograph, the way that we diagnose it, much like the left calf perthes, is we pursue the radiograph. On the radiograph, what do we expect to see? We expect to see not just total erosion, but they actually get a slippage of the femoral head. Sort of medially. Oftentimes it'll be compared to an ice cream falling off of an ice cream cone, and that's what you'll see, popped out a little bit medially. Now here's a x-ray here that shows the arrow cluing into exactly where the problem is, but you can see on the patient's right hip, everything looks pretty good. On the left hip, Not so good, the ice cream has fallen off. This is a problem, likely needs to be admitted or very urgent ortho follow-up. Now, again, just like Lekavs-Perthes, there's subtle presentations of the radiograph, and then there's very obvious ones like this. So are there lines, radiographic lines, that can help us diagnose this in somebody in which we have suspicions? And the answer is, there's always a line. There's always some radiographic line that's going to be there. And for SCFE, the line that we're often taught about is the Klein's line. And the Klein's line is a line that we basically draw from the femoral neck, and you just draw it straight, the superior aspect of the femoral neck, and you draw it straight up toward the femoral head. Now, a normal Klein line will bisect some component of the femoral head. And when you get that bisection, that is good. If you, like on the right-hand side of this X-ray, you can see that that Klein line doesn't hit any of the femoral head. That means that there's some early slippage that isn't as obvious on the other X-ray. That's abnormal. That's concerning for SCFE. Now, the Klein's line, how good is it? It misses more than half of some of these early cases. So it's not the best radiographic test. And here's another example of an abnormal Klein line. For those of you who are interested, there's a sort of a more recently described finding, the S sign, that sort of outlines the contour of the femoral head all the way through the neck. And if you get a good S shape, that's good. If there's a disruption in the S, that's a problem. It's not outlined here, but if anybody wants to look it up, that tends to be more sensitive actually than the Klein's line. These patients should be, like I said, referred for early, oftentimes operative fixation. All they get is a single percutaneous screw, and they can still even develop AVN, avascular necrosis, despite that. So the earlier we get them referred, the better. Okay. So Lekavs-Perthes, pre-adolescent, a little bit more benign, can be sent outpatient. SCFE, adolescent, more urgent, referral needs to be taken with a little bit more urgency, generally in more overweight adolescents. Both are diagnosed with X-ray. All right, so we talked about SCFE being a shouldn't miss diagnosis. Here is your shouldn't miss, can't miss, always think about diagnosis, is the septic hip. This is a diagnosis that we never ever want to miss in a limping child. Why? These kids can get really sick, not just in the hip and lose complete function of the hip, but also systemically can get very ill. Now, the good thing is, in terms of diagnostic challenges, these kids tend to come in looking pretty sick. And as you can see here, a bunch of clinical predictors. There's actually a clinical decision rule that was developed by a guy named Dr. Kocher, Kocher. So if you want to look up Kocher's criteria, they basically are all outlined for you right here. In the original sort of derivation and validation studies of the Kocher criteria, having 0 Kocher criteria basically had 0% chance of you having a septic joint. And then if you had all 4, it was almost 100% in the original studies. Now, of course, like no clinical decision rule is actually that good. And if you're really, really suspicious, then you should still pursue a workup. But here are the criteria. Fever greater than 38.5. What if it's 38.3? They don't meet the criteria. I'm still worried. White count of 12. What if it's 11.5? Still worried. Non-weight bearing. This is probably the most important thing, that these kids really don't tolerate any even micro movement of their hip oftentimes, especially when it's a little bit more advanced. And then the CRPs and ESRs have been pretty well described as being positive markers in these kids. Of course, these are sort of non-specific lab tests. I wouldn't rely on any of these lab tests, but when they're positive, it should increase your pretest probability that this is septic joint. And then the blood cultures are often negative in these kids because it's localized to the joint. They can have hematogenic spread, so they may be positive, but they can also be negative. And then the next step, if you are concerned about this, you get this ill-appearing child that's coming in with a limp, they have a fever, they have this white count and all this stuff, the next test would be an ultrasound. And if you catch an effusion on that ultrasound, that is septic hip until proven otherwise. That hip needs to be tapped, admitted to ortho, urgent, and if you're in a place where you don't have pediatric services, then this would be an immediate transfer to a facility that could take care of this and help the child. So, like I said, the Kocher's criteria, say you got a kid that you're worried about. I'll give an example. You have a kid that's coming in and they're a little diaphoretic and they've been complaining of chills, but they're not febrile in the ED. Right? They're complaining of pain in their hip, but they're not totally non-weight bearing. They don't meet any of these Kocher's criteria. Say the CRP is 15. Is that a kid I'm not going to be worried about and pursue ultrasound? No, these are all sort of like increasing and decreasing your pretest probabilities. If you're concerned about septic hip and there are features that make you concerned, we keep going with the ultrasound and treat these with a little bit more urgency. How do septic hips happen? Well, we talked about in the pediatric anatomy, hip anatomy, that there's a contiguous sort of nature between the joint and the bone. So if they get osteomyelitis, they can also develop a septic joint. They can also get it in other ways, hematogenous spread. In adults, it's a lot of times it's IV drug use or some other sort of systemic illness, surgery. But in kids, it can happen just sort of de novo with osteo. And in terms of bugs, if you're interested in what bugs, in babies, what do we always screen for? It's strep B. They can get E. coli as a cause, but the majority of these are staph. And again, true emergency needs to be taken with urgency. Now, say you're worried about a septic hip in a kid. This kid's limping, they look a little bit toxic. You don't think it's skiffy, you don't think it's Lekhalf-Perthes, but there's just something off. Like they look a little febrile, they're toxic. There are several mimics that can occur here in the sort of pelvic region in the hip that can also be concerning and won't be picked up by x-ray, won't be necessarily picked up by ultrasound. And so look at all these diseases, appendicitis, SI infections, pelvic abscess, iliopsoas abscess. So if you're very concerned about the child, then the next step would be, if they are still toxic appearing, you could get an MRI and pick up some of these other causes. So now, the less wicked stepbrother of septic joint, the one that always confuses us and gives us these sort of diagnostic conundrums, is this entity called toxic synovitis. Has anyone seen a case of toxic synovitis? Okay, how toxic does a toxic synovitis typically look? Not very toxic. This is a misnomer. The toxic synovitis, the other name you'll hear for it, which I think is more apropos, is transient synovitis. You'll also hear it referred to as transient toxic synovitis or irritable hip, all the same thing. We're all referring to the same thing. But basically what a toxic or transient synovitis is an inflammatory process in the hip where the kid won't be able to walk or won't want to walk. And you might be worried about a septic hip, but they just don't look as bad. They don't look systemically ill or febrile and stuff. Like, they could get low-grade fevers, but they're just not as sick as a septic joint would be. Now, you can imagine that anytime you see a kid like this, that you're gonna be like, well, how do I distinguish this between a septic hip and a toxic synovitis? Well, you could get labs, the CBC, like we said, the SED rate. If those are negative, then it might decrease your pretest probability. The other thing that oftentimes will happen with these kids is you give them a dose of Motrin, they're not walking at all, and they feel miserable in the ED and just not themselves. And then you give them a dose of Motrin, and 10 minutes later they're playing. That's a good sign. And that could be toxic synovitis. If there's sort of an in-between case that you're not exactly sure, the tincture of time. You can always either OBS them, or have them come back in 24 hours, and if they start to develop maybe some of the more systemic signs, then get more serious and get booking with all the workup for septic joint. But like we said, skiffy and Lekhalf-Perthes are sort of a pair, septic joint and toxic or non-toxic transient synovitis sort of pair up. One is sicker than the other. All right, we're going to shift gears to avulsion fractures. We were talking more about younger kids. We're going to talk a little bit about adolescents right now. This is avulsion fractures. If you've seen these tend to be sort of like flecks that get pulled off from the muscle, like strong muscle in a kid in puberty, adolescent that is either playing soccer or track or doing ballet or making sudden movements, and their muscles are strong, but their bones aren't fully strong yet. And what you'll see is like this pulling off of the tendon of the bone. And there's various places where it can happen. If you look at this x-ray is kind of a nice reference to go back to. If you're ever looking at a plain film and you have an older kid with what they're describing pelvic pain or that kind of thing, these are all the different points where it's common to have avulsion fractures. NSAIDs, ICE, outpatient follow-up for these kids. Sometimes they need operative in severe cases, but depending on displacement and whatnot. But a lot of them will heal with physical therapy. All right, we're going to move on from kids to adults. We talked about kid anatomy, the bone still not being laying down, the architecture is getting stronger, but it's not quite there. The adult hip anatomy is strong architecture. This is a strong, resilient joint now. In fact, it's so strong that for any of you, as we sort of age, I love running. And I used to do, 3 minutes of stretching, and I would run for an hour and a half. Now, I do an hour of stretching to run like 5 minutes or 10 minutes. Why? Because like these hip joints get tight, and you have to foam roll 100 times and do 100 weird stretches just to get this thing loosened up. But the good part of that is that it's very resistant to injury, and so it takes a lot of high energy mechanisms usually to get injuries in the adult hip. But it does happen, so let's chat about some of them. So hip dislocations. The vast majority of hip dislocations in adults happen posteriorly. Why? Because the mechanism is usually from an MVA or a big height, and it happens when the leg is flexed like this, and then you get a posterior vector force kicking the femoral head back, and it usually pops the femoral head out posteriorly and just a little bit lateral. Okay? And so the way that this will present in the ED, has anyone ever seen a posterior hip? Yeah, and when you can diagnose those from the door a lot of times, it looks like somebody who's internally rotated and just a little bit adducted. It looks like they're trying to roll their entire body over, but the rest of the body hasn't caught up. It's just that one leg that's popping over. So you can a lot of times see that shortened, internally rotated, adducted. And so when you see one of these, is this a little bit urgent, very urgent, emergent? We need to get these back in right away. And the reason for that is the femoral, the neurovascular bundle along the proximal femur, it gets tethered and pulled, and that can lead to rapid avascular necrosis in these patients. In fact, there's descriptions of every minute that we delay that you increase the incidence by about a percentage point. You'll often hear the time of like, don't delay past 6 hours. Why do we not delay past 6 hours? Because the risk of AVN goes up precipitously. There's nothing magical about the 6 hour mark, right? If you did it at 5 hours and 50 minutes versus 6 hours, there's a higher risk of AVN the longer we leave these things out. So these are patients where you want to prioritize them, get them to radiology right away. Don't have them languishing around the ED for long periods of time. Get their pain under control, get them to radiology, get them back, and pop this thing back in ASAP. Here's some images of what you might see. This is what I was trying to describe in a not so elegant way up here. But this is on a bed, internally rotated, adducted, and shortened. And then on the radiograph here, you can see it sort of posteriorly and laterally superiorly dislocated. Oftentimes there will be small like acetabular fractures associated with it. That should not preclude you from popping this thing back in. If you see a big femoral neck fracture associated with it from the high energy mechanism, you don't want to be yanking on that thing. If the femoral neck is fractured, you could make things a lot worse. So most of these can get popped back in, but the femoral necks, be very, very careful. This is a radiograph. Again, you can see it sort of displaced, the right side displaced posteriorly, laterally, and a little bit superiorly. And there are various hip reduction techniques. The one that is most often described is here called the Alice method. You see the black and white picture? Hopefully that was the last time somebody did the Alice method. We shouldn't be doing this Alice method anymore. I've seen so many of these go wrong for both the provider and for the patient. Why? Getting up on a gurney, those gurneys are, how sturdy are those freaking things? Sometimes they're locked, sometimes they're not, sometimes they're locked and they're actually like still move. I've seen providers get up and sort of like, you don't have the best sort of balance on those things. You smack your head against that stupid ED light thing. I mean, you see all sorts of follies happening with this Alice method where you get up on the bed and you basically just like try to yank this thing back out. I don't recommend it. There are sort of cleaner, nicer, just easier techniques to do that just don't take as much force. I've also seen people using the Alice technique and kind of cracking a femur just from like a lot of force. You'll see people just like muscling that thing all the way out. So I'll talk about the Whistler method, which I think is nice. And then there's another method that's very similar to the Whistler method, a modification of that, called the Captain Morgan. Have you guys heard of the Captain Morgan? So I'll describe the Captain Morgan and the Whistler. Both of them sort of depend on using the other leg sort of stays down and can be a fulcrum. So the Whistler method, you basically take your left arm, if it's the right leg, and you put it under their dislocated hip, and you use their good leg as a fulcrum. And then you take your other arm and you push down on the ankle as you elevate up on the posterior, on the dislocated hip, and that can, like without a lot of force, you can really get these things back. The method I actually like a little bit more is instead of using the arm, because you don't get that as good of a lever arm with your arm as you do with your leg, you take your, in this case, it would be my right leg. I would put the right leg up on the gurney, and you would bring the gurney down. Of course, this is predicated on you, on like height of the gurney and your height. But get it up on the bed and use that as the fulcrum underneath the leg. And then you take your right arm and put it on the ankle. And you do a little bit of pushing down on the ankle, but really you want to just like push your toes up and use your calf to just pop that hip back in. You'll see people really trying to muscle these things, but just a little bit of sort of leverage will get these things back in. The key thing for all of these hip relocations, for shoulder reductions, we're going to talk about later, sometimes you can get away with just some massage or getting the person into a happy place or an intra-articular injection. These patients, the pelvic architecture that we talked about that's so strong, that needs real muscle relaxation. So these things really need to be done under propofol sedation, real sedatives to be able to get these things back. So even if you're talking the patient through, they'll get all kinds of spasms and whatnot. If the patient's unstable, hypotensive, you can try ketamine, but ketamine's not my preferred just because you get a little bit of, you don't get as good of muscle relaxation with it. Anterior hip dislocations, far more rare. These patients actually come out more externally rotated and abducted. This is the far minority of cases. So you'll see the hip kind of, the femoral head popped out this way. And same kind of thing, you got to get it back in soon. Actually, the Captain Morgan is also a good technique for anterior hips as well, so you can do that. This is another image of the anterior hip right here, very different than the posterior hip, again, the minority. And then finally, the dislocated prosthetic hip. What do we do with these? This is a person that just had surgery, has a titanium or plastic sort of socket and a femoral head. These patients, it always sucks. It's like somebody is saying, hey, I was just trying to go to the bathroom, and I just kind of like took a squat and pop. It's like whenever you try to cross a leg or do any sort of like crossing movement or hyper abduct your hip, like those kinds of things can pop it right out. Now, in terms of reduction of these are actually far easier than a native hip. The only problem is if things are sort of stuck or malaligned and we don't do the reduction properly, you can pop that sort of socket, the cup out of its place. I've never had it happen. I've actually never seen that happen. So what I recommend for these is, they are pretty easy to pop back in. I always call ortho, especially if it's like the operation has been done fairly recently. I call them, say, hey, I have your patient here. Do you want us to do the reduction? Do you not? Most of the times they'll say, please go for it. But if you start noticing a lot of resistance and it's hard, I wouldn't mess around. Just then I would call the orthopedic back and just say, hey, I'm a little concerned about this hip. Can you do it? And they'll often have to revise these and whatnot. Hip fractures. We're moving away from hip dislocations. We're talking about fractures. There's two sort of general categories of fractures. High energy mechanisms in sort of younger patients, and then sort of the lower energy, like you'll see in a lot of skilled nursing facilities, people falling off the gurney and coming in with a hip fracture. So the key to these, so we were talking about in hip dislocations, should we be doing regional nerve blocks in those patients? Maybe it helps with pain. There have been some small case series in terms of pain control, but really the treatment for those is getting it back in place and using general sedation to get them back, like procedural sedation, excuse me. But for hip fractures, regional blocks tend to work really, really well for pain and avoid giving sort of elderly patients IV narcotics. So I love these femoral blocks, and there's a robust amount of literature coming out about like how patients do better, improve morbidity, decrease hospital time, and all that kind of stuff. So another few points about elderly hip fractures. One really, really important point. Do you guys at your hospitals admit to medicine or to ortho when you admit elderly hip fractures? Medicine, yeah. I'm hearing more and more medicine. That wasn't always the case. And the protocols have changed in our hospitals as well, but there's more and more evidence coming out demonstrating that because of all the multiple comorbidities that these patients have, pre-clearance to surgery and everything else that happens as a result of that, admitting to a medical service where all those comorbidities can be concomitantly addressed is far better for the patient. Here's a photo of the different places where you can get hip fractures. Generally, there's two sort of locations. There's the intracapsular and the extracapsular locations. Intracapsular refers to the femoral head and the femoral neck, closer to the hip joint. That tends to have higher risk of AVN. Extracapsular tends to be the intertrochanteric or subtrochanteric fractures that are more common in the elderly, IT fractures and stuff that have less risk for necrosis, but just to kind of give you a little geographical space of what the hip fractures are. And then finally, a word on occult hip fractures. Everybody in their ED career will likely see something like this. There are about 4% of these, this is about 1 in 20 patients, will not have anything on their x-ray. Yet, when you do an ambulation trial, which we always should anytime anybody has a hip or pelvic complaint, if you get the ambulation trial and there's just still something wrong, they're not totally walking, we have to be considering occult hip fractures. That involves a CT and MRI if we're not finding the exact source. Why? Because if it's an occult hip fracture that needs to be operated on, it can either be non-operative or a quick screw. If that thing just totally falls off, then it becomes a whole mess of a surgery. So the earlier we can catch these, the better. So just being really, really cognizant. Non-ambulatory patient, negative x-rays, please continue to pursue your workup. This is a hip fracture algorithm up there for your own perusal from a local hospital, but basically x-rays, if x-ray is negative, then pursue further imaging. Do not send non-ambulatory patients home thinking that everything is okay. A few images here of MRIs versus x-ray. Look how subtle things are in this sort of ratty osteoporotic bone on the x-ray, but then it's pretty well apparent on the MRI. And then we're going to finish off here with greater trochanteric bursitis. Bonus slide. This is what is often referred to as a hip pointer. If anybody's had a hip pointer before, playing football, soccer, you fall directly sort of on that greater trochanter where you have the bursa. That can get inflamed, be really painful. It can also happen over time. Oftentimes in middle-aged women, it's described. Poor posture that can put excessive strain on that bursa. And the treatment here is NSAIDs, and sometimes they can get injections to help with the bursitis, but that's greater trochanteric bursitis. And that's all we got for the hip. We'll be talking about a few more orthopedic topics. And next up, we have the one and only Jess Mason. Thank you.
Hey, Raman, it's good to see you. Thank you. Good morning once again. Acute coronary syndromes. This is going to be the last talk that I give for you during this course, so I have to start out by thanking you for your time. And once again, I look out, I see colleagues in emergency medicine. I see the future of emergency medicine, and it's been a pleasure to be part of your educational journey, and hopefully more so down the road. This is a big topic to cover in 30 minutes, so I can't possibly cover all of it. But we're going to touch on some of the major concepts. And our job, this is a key part of our job, we see so many people who come in with chest pain. So many people. And we have to put together a lot of different things, the history, the exam, and we have to think about the heart in terms of the anatomy of the heart, the territories, which coronary arteries supply which geographic territories of the heart, and how does that correspond to the squigglies? The ECG, right? The ECG is going to be your clue of what's going on and which geographic territories it corresponds to. So we're going to try to put all of that together and start here with some definitions. Working our way from the bottom up. STEMI, ST elevation myocardial infarction, a STEMI. What does that mean? It means we're seeing ST elevation, and there's some specific numbers here that we're going to try to remember, right? We're looking for at least 1 millimeter and 2 or more contiguous leads in general. There's some special caveats for V2 and V3 where you have to get a little bit higher than that. And that's going to indicate that not only is this patient having an ischemic event, but it could be a full wall thickness, full wall of the myocardium. Okay, so that's a STEMI. Then we have NSTEMI, a non-ST elevation myocardial infarction. What does that mean? It means you look at the ECG and you don't see a STEMI pattern. but the patient's giving you that great story for ischemic chest pain, and you get the troponin back and it's elevated, and there's definitely some badness going on here, but it's not a true STEMI because of the lack of ST elevations. So this generally, the classic teaching here is this is going to indicate that there's partial wall thickness involved instead of full wall thickness, okay? This is not necessarily true. This is just sort of the classic teaching, right? More modern thinking, modern paradigms are shifting away from this, but you got to know the ground rules here before we start changing it up on you. And then there's unstable angina. We have angina, which isn't even listed on this slide, and then unstable angina. So angina, what is that? That's your classic chest pain patient who every time they go up some stairs, they're huffing and puffing a little bit, they get some chest pain, they pop a nitro and they feel a little bit better, okay? That's angina. Unstable angina is now we take out that little exercise component, and now they're just getting that ischemic chest pain just at rest. You get the EKG, no ST elevations, maybe sort of normal looking, maybe non-specific, maybe some T-wave inversions, but it's not a STEMI. You get a troponin and it comes back negative. But they have that story, that really classic story, and they're getting that pain just at rest. That's unstable angina. So let's talk about that classic presentation. We know this, we learn this in school, and this is what we hope to see, but I will tell you, and you know, this rule gets broken all the time. No one follows the textbook. It's exciting when someone comes in and they're like, I got sudden onset of this substernal, pressure-like squeezing sensation. People even sometimes say, it's like an elephant sat on my chest. Anyone ever heard someone actually say that before? I've actually heard people describe it that way before, that pressure pain. Does it radiate? Yes, it radiates. Where? Anywhere. It doesn't matter. It could radiate anywhere. That's concerning. But that textbook patient is going to say, it radiates down my arm. Is it the left arm? It can only be the left arm, right? Wrong. Any radiation anywhere is very concerning. It goes down the right arm, the left arm, whatever, your shoulder, your jaw. Any radiation is a bad sign. Some patients will say it makes them short of breath, sweaty. Are you seeing the patient sweat? That's never a good sign. But diaphoresis, that's a very concerning finding in patients with chest pain. Nausea and vomiting, these are also very concerning. And fatigue. Fatigue just by itself, you have the older female patient who comes in, and her only symptom maybe is that she's feeling a little more tired than normal. Maybe you gotta push it a little bit. Any chest pain? No chest pain. How about chest discomfort? Oh yeah, I'm having some discomfort in my chest. Have you ever tried asking it that way? A lot of people won't call this chest pain. But if you say, okay, what about just some discomfort? You might pick up on some subtleties there. So someone comes in with any or a combination of these symptoms. What are our goals? Well, we need to find the patients who are having ACS. In particular, we need to identify the STEMI patients and get them to the cath lab because the clock starts ticking right away. And so we want that ECG done as soon as possible, ideally within 10 minutes, and then brought to someone who can interpret it. It's no good if it just sits there on a counter. Recently worked a shift, walked into my triage area, sat down at a computer. ECG is sitting there on the desk. I take a look at it. Oh, shoot. Who is this patient? Where did this come from? We need to get this patient to the high acuity zone right away. So it's no good if someone isn't looking at that ECG promptly. So what are we going to do for these patients? The ones that we're worried about, the right answer is almost always IV O2 monitor. In emergency medicine, you could say that. It's almost always right. There's two answers, actually, that I love when my residents say. I will tell them they are never wrong. I could ask them anything, and if they say IV O2 monitor, you're right. And if they say frequent serial reassessments, I would say, you're right. So those are the right answers every single time. So these are the patients we're getting on the cardiac monitor. We're getting their labs drawn. We're getting that stat chest x-ray. Why? You don't diagnose a heart attack with a chest x-ray, but you're looking for all the other things that could be going on with the patient. You're looking for signs of dissection. Last thing we want to do, give a big heparin bolus to someone who's actually having a dissection, right? So you want to look for signs of dissection, you want to look for signs of CHF, other clues of what could be going on causing their chest pain. So that stat chest x-ray is an important component here. Aspirin. Yes, we're going to give aspirin. Aspirin has been shown to save lives. If the story is consistent with ACS, then we're going to give them aspirin. It's 162 to 325 milligrams, and it's chewed so you get that really fast absorption. What about oxygen? Did anyone, when I was in medical school, I was taught this mnemonic, Mona B. Did you guys learn that? Okay, like half of it's true anymore. It's like not even that many years later, and it's like only half true. So Mona B stood for morphine, oxygen, nitrate, aspirin, and beta blocker. We only do half of that anymore. So what about oxygen? That used to be the classic teaching. Someone comes in, the chest pain, you're worried about STEMI, you're worried about ACS, get them on some oxygen. Nope, not necessarily true anymore. Only put them on oxygen if they're hypoxic. Otherwise, it can actually be very harmful. Here's some studies if you want to take a little deeper dive into it. 2 well-designed, large, randomized controlled trials that looked at this question: should we put oxygen on everyone, or should we just save it for patients who are truly hypoxic? Actually, in this AVOID trial, published in Circulation, they found an increase in the size of the infarct, increase in frequency of arrhythmias, and recurrent MIs in the oxygen patients. Okay, so the other studies and meta-analyses support this. It's either no difference or worse outcomes. So we're not routinely putting oxygen on our ACS patients anymore, only if they are hypoxic, 90% or lower. So what are we doing for them? Okay, well, if you learn Mona B, the N was for nitroglycerin. What about that? Can we still give nitroglycerin? Generally, yes. You generally can. There are some important caveats here. If the patient has recently taken sildenafil, so Viagra, nope, risk of shock, refractory hypotension. So that patient should not be getting any nitro. And then the other big red flags here are concern for an inferior or posterior pattern of an MI on the ECG, because that's going to make your patient hypotensive. You've probably seen this before. A patient comes in, brought in by EMS, good, concern. They did their 12 lead in the field, and there's a concern that this is a STEMI. Brings them in, and by the time they get to you, the patient looks pretty bad. They're diaphoretic. They're having severe chest pain, and they're hypotensive. You undress the patient, and what do you find on their chest? You find nitro ointment. You pull off the paper and quickly wipe that stuff off, right? Give the patient some fluids. If they have an inferior MI and they're getting nitro and they're getting hypotensive, you're going to give them fluids and wipe off the ointment. I don't know if this is in your EMS protocols, but there's been a number of times for me where I've staffed a patient, say with a resident, oh yeah, they had chest pain, they feel all better now, they're low risk, I'm going to send them home. And I go to see the patient, talk to the patient, hey, what's this on your chest here? Oh, you've been sitting here for a few hours with nitro ointment. Let's wipe that off before we decide whether or not we're sending you home. So watch out for that hidden nitro ointment under the gown. Okay, what about morphine? That's the M in Mona B. What about morphine? Can we give morphine still? There's a lot of nuance to this. If the patient, here's the summary, okay? If the patient has a STEMI and is going to the cath lab and is in pain and you gave nitro and they're still in pain, give them some morphine. The concern about some studies showing worse outcomes in patients who receive opioids is when the patient's not necessarily going to the cath lab right now, okay? So they have chest pain, maybe it's an NSTEMI, we're still working it out, we're not sure, and then they're getting opioids. The concern there is that their pain is being masked, because one of the reasons why a patient who, let's say they have an NSTEMI, cardiologist is aware the patient's being admitted, they're probably going to go to the cath lab, maybe tomorrow. They've got 24 to 48 hours to try to get that done. But what if the patient starts developing worsening chest pain, more severe chest pain, okay? Normally, we would want to know that. We'd want to get a repeat ECG. We'd want to be at the bedside, take a look at the patient. Maybe they need to go to the cath lab now because something's changing. So the concern is, are opioids sort of masking that progression of symptoms in those patients? So just to keep it simple, if the patient's going to the cath lab and their pain's not well controlled, morphine's probably just fine, but used with caution in other situations. What about heparin? Heparin, it says somewhat controversial on this slide. Okay, so if the patient's going to the cath lab, you're going to start the heparin, right? You're going to give them the bolus, you're going to start the drip. In general, this should be done either part of your protocol for STEMI patients or in consultation with your cardiologist. For your NSTEMI patients, I don't usually start heparin. When I get on the phone to admit the patient for the NSTEMI, this is one of the things that I ask the cardiologist. Do you want me to start the heparin? And some of them say yes, some of them say no. There's really no benefit to starting it immediately. There's only a benefit in getting it on board when they go for their catheterization. What is the heparin actually doing? Well, it's preventing thrombosis during that procedure and after that procedure. Okay, so you're not doing much good by giving them heparin right now. Okay, it's when they're going to go to the cath lab. So for STEMIs, you're activating the cath lab, yes, you can start the heparin. For NSTEMIs, make it part of your conversation when you consult cardiology. Other medications, okay, clopidogrel, and other things that fall into these dual antiplatelet category. Anything, so clopidogrel, ticagrelor, these are the PY2 something inhibitors. And these are generally going to be part of that bundle, that protocol when you have a STEMI patient. Generally, you're going to be starting one of these, and whichever one it is sort of up to your hospital protocols in working with your cardiologist. If it's an NSTEMI, don't worry about starting this in the emergency department. It can be started at some point during the patient's admission, usually within the first 24 hours. Same is true for a statin. You are not going to save anyone's life by promptly starting a statin in the emergency department, okay? The statin is going to help maybe reduce the risk of a future MI, but it's not going to help the patient in front of you right now. And beta blockers as well, you don't need to worry about starting those right now. You can have that discussion with your cardiologist. Troponins. Troponin I and T, these come from the myocardial cells. But troponin does not equal MI. Okay? We still have to put on our thinking caps and look at the patient in front of us and get the history and the exam, and does this all fit? Because a lot of things can cause a rise in a troponin. Now, in the setting of cardiac ischemia, fortunately, it does follow a predictable pattern. It's not, if someone comes in with 10 minutes of chest pain, a troponin is not going to help you make this diagnosis, okay? It's going to take a little bit of time to rise. It takes 3 to 6 hours. And then it's going to peak around 12 to 24 hours. And then it's going to come back down gradually and finally normalize. So it's important to remember that pattern and that trend, right? And that's why trending is very important. Is it going up? Is it going down? What is the troponin doing? There are these now ultra-sensitive troponins, third-generation troponins. It's important to know which ones you have at your hospital. I think most people in the US still have second generation, but third generation are becoming more and more common. And you need to know what is just the normal range in where you work. Look at this list of all the things that can cause a rise in troponin. So many things, right? It's not just cardiac ischemia is the bottom line here. And so an elevated troponin does not equal ACS necessarily. So, like I said, the clock is ticking. The patient has arrived. The clock has started. The goal here is PCI, which is percutaneous cardiac intervention, aka going to the cath lab. These are the same things. We want that done within 90 minutes of arrival. That's what's called the door to balloon time. If you work at a facility where you don't have a cath lab, then it should be within 120 minutes for non-PCI facilities. Thrombolytics. So some of us are going to work in places where you have to give lytics. You don't have the option. You're going to be transferring the patient, for example, or maybe you work somewhere that it depends on the weather or the traffic patterns. You have to figure out, oh, shoot, what time is it? Or is it snowing outside? And am I going to have to give lytics to this patient? So if you work in that type of situation, then you want to be able to start those lytics within 30 minutes. So that's your door-to-needle time for thrombolytics for ACS. All right, we're going to take a look at ECG patterns, and I know Diane did a pretty quick but thorough review here and touched on some of this. So just to remind ourselves, when we're looking at the ECG, some basics here. P wave, you see the P wave, that's atrial depolarization. QRS complex, that's your ventricular depolarization, and then your T wave is the recovery wave, repolarization. All right, and so that's starting the P wave, the SA node, and then it's coming down to the ventricles, and you get your QRS complex, and then the T wave is that resolution. Here's an example of a normal ECG, just to have one, so you can compare. When we look at some of the abnormal ones, you can flip back to this one for comparison. This is an interesting example of an ischemic ECG. The reason why it's interesting is that this is actually not following, if you strictly use STEMI criteria, this is not meeting that criteria, but it looks bad, right? You can see that there actually is ST elevation in AVR, and there's all this diffuse ST depressions elsewhere. So this is one of those like technically non-STEMI, but STEMI equivalent ECGs. You have ST depression in 7 or more leads with ST elevation in AVR. There's a list of those STEMI equivalent ECGs that are very concerning, and that's just one. Okay, here you can see the sequence of how this evolves on your ECG, starting with, and this is important, that hyperacute T wave. Do you see the hyperacute T wave? You get that before you even get the ST elevation. So someone who comes in and the pain just started, you might not even see an ST elevation. You're going to see this weird-looking tall T wave, that hyperacute T wave. Looks sort of like a hyperkalemic EKG. Looks similar. Then it's going to progress to the ST elevation. Then you're going to get that Q wave. Then you're going to get that T wave inversion, and then things are going to start to resolve back to normal. So you can refer back to this for that pattern of how this is going to progress over time. Remember that the ECG, these are vectors, and they're giving us a clue of you can see how this corresponds to the anatomy. The heart sits in the chest, and it sort of points down and to the left, right? So we're following vectors here. That's what you're seeing on your ECG, and it corresponds to these vectors three-dimensionally, as you can see in this drawing here. Now we're going to compare this to the next slide. This is the one to circle and to highlight for reference that you're going to want to come back to every time. It's showing you on the ECG which geographic territories of the heart it corresponds to. So leads 2, 3, and AVF, these are your inferior leads. V2, 3, and 4 are your anterior leads, and then your lateral leads sort of streak down the side there. It's lead 1, AVL, V5, and V6. And you could see if I go back, you could see how this corresponds to the direction of the vectors drawn here. Okay, so it's good to see these side by side and how they correspond to each other. Now the next set of slides, we're going to look at a drawing of the heart showing the coronary arteries, and then how that corresponds to ECG findings. So this one is the anterior MI pattern. So looking at the first diagonal, you're looking at the LAD, and how does that look if you have a blockage there? On the ECG, do you see this? You see some ST elevations. I'm seeing them in V2 and V3 and V4. You might see some ST depressions in 2, 3 AVF. You might see in some cases, although I don't really see it here, an ST elevation in 1 or AVL. And you can have an anterolateral MI where it's going all the way from, V2 all the way to V6. It's just that whole large territory. Lateral MI. So now you're talking about the LAD, you're talking about the circumflex. How does that look on the ECG? Well, if we go back to that slide, you can expect which leads are going to show ST elevation, and it's right where you would expect, V4, 5, and 6. And that, to me, almost looks like hyperacute T waves. There's some elevation going on, but those are some tall T waves. Look at lead 1. That one's a clear ST elevation pattern. And another key finding here is the reciprocal depression. It's good to remember, okay, I have a lateral MI. What's the reciprocal area? What's sort of the opposite area of the heart? Where am I looking for that ST depression? And in this case, you can see it really clearly here in lead 3 and in AVF. Okay, inferior MIs. Now we're looking at the posterior descending artery, the right ventricular marginal branch. And on the ECG, if we remember our territories, where should it be? Okay, we're going to see the ST elevations right where we would expect them, leads 2, 3, and AVF. And here you might see some reciprocal depressions in AVL. You can see that here. All right, this is the tough one, posterior MI. If you're looking at this and going, huh? Well, then you're kind of like me, because you might be looking at this and saying, I don't know if I see it. What am I looking for on this ECG? I'm not sure if I see it. It's very subtle on this one. You kind of have to have a little bit of a spidey sense, like, the patient gave me a good story for ischemic chest pain, and what's going on here? Okay, so there is an R wave in V1 and V2, that usually it's like there's no R wave, there are very, very tiny. Here we have a taller R wave, and you can sometimes see an ST depression in V1 through V4. You don't really see, it's very subtle here, you don't really see too much. And so on this patient, we said, you know what? We need to get some posterior leads on this patient and repeat the ECG. So the next slide, that's what's happened here. And it's very subtle, but you can see a little bit of elevation in V7, 8, and 9. Again, this is a very subtle ECG. The next one, which I'm not sure if it got printed in your book because it got added kind of late, but here is a good example of a more classic example of the posterior MI. Do you see those deep ST depressions? V2 and V3. Deep ST depressions there. That's a red flag. Okay, one trick that you can do, if it helps you to just get back to that familiar pattern of a STEMI, is you can do a vertical flip. Okay, so turn that ECG upside down and now look, and it looks like a STEMI. Okay, so this is someone who you would add the posterior leads, you'd be activating the cath lab. This is one of those like a STEMI equivalent. Special considerations. Okay, so let's remember, when we think of the classic patient with ACS, you might not be thinking about a younger patient, but it can happen in younger patients, and so we don't want to be dismissive. We want to treat chest pain seriously regardless of age. And sometimes patients may say they have some epigastric pain. When you hear epigastric pain, just in your mind, cross out the word epigastric and replace it with chest. Like, treat them as a potential ACS patient. Because a lot of patients with actual ACS are going to describe it as epigastric pain and not even chest pain. So sometimes you say, okay, well, we'll do a little workup for them, but I'll give them a little GI cocktail or a PPI and see how they feel. And many times people will feel better after that. But that does not rule out ACS. So don't be falsely reassured that they feel better after getting a little GI cocktail or PPI. Remember the risk factors. So there's so many risk factors, and these are a key component, but they're not the whole story. Someone can develop an acute coronary syndrome without any risk factors. And here's a good list of some of the classic risk factors that we think about. These are important for many reasons. And one thing I have to say that this lecture doesn't touch on very much is risk stratification, right? This sort of focuses on STEMI and STEMIs. Doesn't really focus on risk stratification, and that is a huge part of what we do. There is a lecture on that in the advanced boot camp course. And of course, it's an area that you want to spend some more time reading about and learning about. If you're using something like the HEART score, I think a lot of us are using the HEART score as a risk stratification tool. This is for someone who, it's not a slam dunk that they're having a STEMI, but you're like, I don't know, do I need to admit them to get more testing done in serial labs, or can I send them home safely? For those patients where you're not quite sure, that's when you're going to bring in these risk stratification tools, and the HEART score is one that's commonly used. It's an acronym, and the H in HEART score is for history, and it's going to include many of these risk factors that you see listed here. Okay, remember that STEMI or NSTEMI can take some time to declare. And that's why serial ECGs and troponins are very often important. If you're ever looking at an ECG and you're just not quite sure what's going on, it's not a STEMI, but you're like, there's something a little funky, or that T wave looks kind of flat, or there's an inversion here, and I'm kind of worried about the patient. The right answer, almost always, is just get a second EKG. Just wait, 10, 15 minutes and just repeat it. Because that's what we're looking for, is evolving. We're looking for changes on that ECG. So we're going to repeat our ECGs. We're going to put the patient on a cardiac monitor as well, and then repeat troponins as needed. Okay, so this is again an area where you're going to think about, where do you work? Are there protocols that you follow? Do you use something called a delta troponin, a fancy way of just saying, get a second one? Maybe a few hours later, depending on the onset of the patient's symptoms. A lot of nuance there. And then remember that with unstable angina, you're not going to see a change in troponin, and the ECG doesn't exclude it. So those patients you might have to be particularly worried about. Okay, other special considerations. In anterior MIs, you can get LV dysfunction And this can cause a sudden onset of CHF. Okay, the patient was like fine 2 days ago, and all of a sudden they have CHF, and they have this like crushing chest pain. So that's sort of one of the more interesting and unusual presentations of MI, where you get a sudden onset of CHF, and that can happen in patients with anterior MIs. Inferior, that inferior pattern that can often be associated with nausea, vomiting, bradycardia, increase in vagal tone, and again, patients can get hypotensive very easily, especially if they're given nitro, and if that happens, what do you give? Fluids. Posterior MIs, often associated with inferior MIs, and can also show RV dysfunction. All right, thrombolytic therapy indications. Many of you are going to be working in areas where you don't have quick, easy access to a cath lab and an interventional cardiologist, and you may have to be giving these lytics. So who should get them? Well, there's very specific guidelines and recommendations on this. The chest pain should be greater than 30 minutes but less than 12 hours and not relieved by nitrates. Once they're past the 12 hours and we start worrying like, okay, perhaps they've completed their infarction, are they really going to benefit from lytics at that point, or are we just subjecting them to all the risks of lytics? Okay, so in addition to that, PCI is going to be delayed it's going to take more than 90 minutes to get the patient to a center where they can do PCI. And then you're looking for those acute ECG changes. And again, here, this is where it's defined here. It's a new ST elevation in 2 or more contiguous leads. All right, and now there's some special things to look at with leads V2 and V3 that are listed here. Okay, we give a little bit more amplitude there. So for men, it's 2 millimeters. For women, it's 1.5 millimeters. Okay, everywhere else, it's just 1 millimeter in 2 or more contiguous leads. And then what about this phenomenon of the new left bundle branch block? This one's a little bit tricky. It's tricky to interpret because someone who comes in with a new left bundle branch block, we're going to assume that's a STEMI equivalent. Well, that sounds easy, doesn't it? But in reality, how the heck do you know if it's a new left bundle branch block or not? I mean, how many patients were you like, oh, well, luckily, Mrs. Jones was here 3 days ago and didn't have a left bundle branch block on her ECG at that time. Yeah, that's not happening. So most of the time, it's very unclear if that left bundle branch block is truly new or not, and there's something called the Scarbosa criteria that you can look up. I have to say I don't have these memorized. I have to look them up every single time, and so that's okay. So look them up, and that's going to help you figure out if that left bundle branch block is actually indicating that there's some sort of acute process going on, like a STEMI equivalent, or this is just their underlying, left bundle branch block that they may have been having for months or years. If you're going to give lytics, every single time you should look up the contraindications to giving lytics. They are listed here for you. Some of them are very obvious, like they've recently had a head bleed. Yeah, you're not going to give them lytics. But some of them are more subtle, and so I just recommend that every single time before you give lytics, you always look up the absolute and the relative contraindications, and they're listed here. So finally, in conclusion, this is a very nuanced subject. You could spend many hours learning more and more about this and what you do, and it seems to be a moving target. So it's an area I think that we all need to do our due diligence for ongoing education in. Once again, thank you so much for letting me be part of this course and be part of your education.
You want to come up here, Rick? Rick's coming up. I'll wait. I'll hold. Is that me? That's me.
Here, you start. I'll work on him.
I think it's my jacket. Oh, it's hitting the... Perfect. Thank you, sir.
Sorry for the delay there.
No, not at all. You were gambling, I understand.
This is Dr. Rick Pescatore. Rick is from South Jersey area. He is on the leadership team of the Department of Health of the state of Delaware, which is kind of neat for an emergency physician to be able to do. Do you get to talk to Mr. Biden very often? No, okay. But in any case, Rick is dealing with this upsurge that is occurring around the country and is dealing with it in his state. Those of you who get emergency medicine news, Rick writes a column in that, writes articles in that newspaper every month, but he also does an audio summary of all of the key papers and articles in that month with a colleague, which has been going on for a good number of years, does an excellent job at that. Works in emergency departments in South Jersey and Philadelphia area as well. And it's kind of unique in that he independently had a headache clinic as an emergency physician, so he is particularly interested in headaches. He's got a great deal of experience treating headaches, and I think that this is a great talk for him to start off on. So,
Test, 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 test. Excellent. Perfect
Rick,
timing.
take it away.
Thank you, sir. I appreciate it. Hi, everybody. It's so nice to be here, and I'm so excited to talk about headaches. As Rick said, I am passionate about headaches. I have opened a headache clinic since 2019, and that followed some advanced training in interventional headache medicine, which was really foundational to my career. And the question became, why did I become so interested in headaches? Where did that possibly come from? I was a headache sufferer myself for an extremely long period of time following an injury I suffered while in the military. And every day I would have sort of debilitating, terrible posterior headaches until I was able to be seen by an interventional headache physician and undergo ablation of my greater occipital nerve and had no headache following. And so that really drove a lot of interest in headache for me and headaches in the emergency department, a condition that we encounter on an absolutely regular basis, between the third and fifth most common presentation to the emergency department, depending on who you read. But we do a pretty good job when it comes to management of headaches from the emergency department. Some recent publications from the Annals of Emergency Medicine demonstrating that about 2%, 1 to 2% of patients discharged from the emergency department with complaints of back pain or headache present within 30 days with a bad outcome. And that's higher than we want it to be, but it does speak to that we do a fairly good job of assessing these patients. But it drives home how important it is to do a good job assessing these patients. And then what's perhaps most important, foundational, exciting, and rewarding to me is looking into the analgesic options we have for patients who present to our emergency departments with benign primary headache. So when we talk about headache, let's talk about what we have to do. We have to evaluate these patients and elicit from their history those suggestive signs or features which may demonstrate a more serious sign of an underlying cause of their headache. We want to know when it starts, how it starts. Does it begin suddenly, or does it sort of creep up on you over a course of minutes to days to hours to weeks? We want to know if this is something that happens on a regular basis to you. We have to have a detailed and a thorough physical exam that incorporates a full and complete neurologic exam, including ambulation of the patient if possible, and of course something that we miss all too often, a detailed and complete fundoscopic exam. When we talk about neurologic exams and examination of the patient with a headache, documentation is critical here. We have to be sure a complete and comprehensive neurologic exam is documented and that fundoscopy is completed as well. You know, I hear lots of complaints about fundoscopy. I can't see the back of the eye. There's no benefit to this if I'm simply holding this thing up to the patient's eye and pretending that I saw something ever since I was told I was supposed to see something back there. We have to get better at fundoscopy in the emergency department, whether that means using a dilating eye drop so that you can get better look at the posterior eye, or whether that means using one of the new panoptic ophthalmoscopes that allow you to get better visualization of the fundoscopic exam. Fundoscopic exams so often can be the game changer when it comes to making a difficult diagnosis to the emergency department, and what's more, accurate documentation of the fundoscopic exam can be a lifesaver when it comes to the medical legal considerations of evaluating a patient with primary headache in the emergency department. When a patient comes in, we begin to elicit that history, there's always going to be those signs, those frequent things that we may hear, which elicit something in our mind that I have to be concerned about a particular clinical syndrome. And when we evaluate patients with headache in the emergency department, very frequently we return to our script. We look for those concerning red flags of headache. A patient who presents, for example, with rapid onset, worst headache of their life, well, that's sort of almost pathognomonic for a patient presenting with a subarachnoid hemorrhage. But there's many more buzzwords when it comes to a patient who who presents with a headache in the emergency department. If they have a fever, we of course have to think about meningitis or encephalitis. If it's worse when they're supine, when they lie down, or it's worse when they wake up in the morning, we want to begin to think of mass lesions or space-occupying lesions within the skull. Nausea and vomiting are two signs that speak quite frequently to patients with increased intracranial pressure and the numerous diagnoses that come with that. And then, of course, our detailed neurologic exam, if it's ever off, we begin to significantly increase our suspicion for mass lesions or intracranial hemorrhage. And all of these will help drive our decision of how we need to work up these patients. Patients presenting with headache in the emergency department often need to undergo advanced radiological imaging, but not everybody all the time. Patients presenting with headache in the emergency department may need to undergo lumbar puncture to search for serious causes of headache, but not all that time. And the mark of an astute emergency clinician is knowing how to accurately apply both your need for diagnostic imaging or laboratory workup, or none of the above in a patient who presents with headache. And that so often is the crux and the difficulty of when we're evaluating a patient who presents with headache. But let's start where it really all begins. The sort of the home run, the game, and when it comes to headaches, is the first thing that we need to be concerned about when a patient presents to the emergency department complaining of headache is, are they suffering from a subarachnoid hemorrhage? A subarachnoid hemorrhage is a bleed. It's an acute large bleed, typically accompanied with a patient complaining of sudden onset worst headache of their life. Often these patients will present with abnormal mental status, vomiting, hypertension. Stiff neck is so often a sign of patients who are presenting with subarachnoid hemorrhage. In fact, I would say to you that if you have a patient who presents with a headache and at any point gives you a sign concerning for a stiff neck, in my experience, it is always concerning for a secondary cause of their headache. It is not a benign primary headache, and that further intervention and investigation is warranted. Subarachnoid hemorrhages generally are due to a ruptured aneurysm, and this is familial. It runs in families, and about 1 to 2% of the population has aneurysms that can burst and cause a subarachnoid hemorrhage. Now, not all subarachnoid hemorrhages are arterial, however. There are venous subarachnoid hemorrhages. These are called perimesencephalic hemorrhages. These are concerning and they're painful, but ultimately require no intervention, and the patient is simply observed and sent on their way. When we talk about subarachnoid hemorrhages, we grade these on what's called the Hunt-Hess scale. The Hunt-Hess scale ranges from 1 to 5, 1 being mild, 5 being severe, and that helps us with our neuroprognostication. And I would encourage you, when a patient presents with a subarachnoid hemorrhage, for you to be able to speak more authoritatively and informed on their prognosis, to grade them on that Hunt-Hess scale to give you a better idea of their mortality and prognosis moving forward. Subarachnoid hemorrhages can be difficult to diagnose, but what's more difficult to diagnose is the sentinel bleed, the warning leak of the subarachnoid hemorrhage. These are patients who again present with their worst headache ever, but undergo imaging and no blood is identified on CT. This is a leak from an aneurysm that is bound to rupture at any point, and it may resolve with simple pain medication and the patient can go on their way. And the sentinel bleed and the warning leak of subarachnoid hemorrhage is one of the most important components that drives so much of our diagnostic milieu in patients presenting with headache. And so I want to talk a little bit about how we diagnose this, because how we diagnose it fascinatingly changes with the time course of how a patient presents to our emergency department. This is a group of CTs of patients presenting with subarachnoid hemorrhage, and there's obvious blood throughout the basal cisterns and throughout the brain. And that's an easy diagnosis to make of a patient who presents with subarachnoid hemorrhage. But in some patients who present with a simple warning leak, the subarachnoid hemorrhage and that subarachnoid blood may not be visible on CT. Particularly if it's been greater than 6 hours of onset from the beginning of their headache. And this is the Perry study, a famous study in emergency medicine, where Perry et al., a group of researchers, looked at patients presenting with subarachnoid hemorrhage and their findings on CT, and found that if a patient was presenting and had a CT performed within 6 hours after onset, and it was read negative significantly here by a neuroradiologist, then that effectively ruled out subarachnoid hemorrhage, a greater than 99.9% sensitivity for the diagnosis of subarachnoid hemorrhage. Now, this has changed over the years since the publication of the Perry study. There's been extrapolation of this greater than 6 hour and less than 6 hour dichotomy into the community, where we've said, well, a neuroradiologist is not particularly universally available to me. In fact, I worked a shift last week and the Nighthawk missed the large subdural and skull fracture on the CT. Neuroradiologists are not typically available to us 24/7, so this study was then extrapolated into community centers and largely verified that a CT performed within 6 hours of presentation of a patient presenting with headache can effectively rule out subarachnoid hemorrhage or sentinel bleed. And that's really important. Now, has this found its way into every emergency center across the country yet? No. Is a CT 100% sensitive for diagnosis of subarachnoid hemorrhage if obtained within 6 hours? No. And of course, it's going to be operator and radiologist dependent to some degree. But a good rule of thumb, and what we now know, is that there's a greater than 99% sensitivity if a CT, a modern CT, is obtained within 6 hours of a patient presenting with headache in order to rule out subarachnoid hemorrhage. And that's important because it helps limit our progression to the next step of the diagnostic workup when it comes to subarachnoid hemorrhage. So if that CT is negative and it's been greater than more than 6 hours since the patient presenting with their headache, more diagnostics are warranted to determine if that patient has a sentinel bleed and has the possibility of a devastating subarachnoid hemorrhage within the coming days to weeks. Now this is, and I want to put it right on the table here, a point of contention in emergency medicine right now. If you were to poll 10, 20, 30 emergency physicians, you would see a 50-50 split right down the middle as to the argument as what's the next best progression when evaluating a patient with primary headache in the emergency department and you're concerned for subarachnoid hemorrhage. The classic next step in this workup is lumbar puncture. Lumbar puncture able to evaluate for the presence of xanthochromia or blood in the CSF, and also importantly, lumbar puncture, an incredibly important tool for us to be able to diagnose litany other important causes of headache. I'm going to be the first person to admit that I have accidentally backed into a diagnosis of meningitis because I was doing a lumbar puncture for subarachnoid hemorrhage. Now, that's one side of this issue, but that does come with cons. Lumbar puncture is not a benign procedure. It can be painful, discomforting for the patient, and it takes a lot of the ED clinician's time. That's the one side of things. The other side of the camp of emergency medicine argues for the next step of the evaluation of a patient with a subarachnoid hemorrhage to be CT angiography, to look for the presence of an aneurysm. If you do a CTA, the sensitivity of it being good enough, the absence of an aneurysm effectively rules out the possibility of subarachnoid hemorrhage leading to the patient's bleed. It's a good argument to make because the possibility of persistent blood, the possibility of subarachnoid hemorrhage in the setting of a negative CT is pretty low. And the possibility of diagnosing a subarachnoid hemorrhage using lumbar puncture is pretty low. And the possibility of missing anything further with an additional CTA is pretty low. And it's not as invasive, and et cetera, et cetera. So what's the next best step to take? Well, I want to be forward with you, and I want to be honest that this is a point of contention and a point of division in emergency medicine. But certainly the point is the same, that additional diagnostics are needed. I'll put my bias on the table and say that lumbar puncture provides you with additional information regarding the patient's infectious status, their CSF pressure. It gives you the ability to observe the patient for longer, and it helps avoid additional ionizing radiation for a patient to undergo additional CT angiography. What's more, we know that there are patients who will present with headache and will have aneurysms, but that aneurysm is true, but unrelated. It is not the cause of their headache. And intervention upon asymptomatic aneurysms has been well demonstrated to be not without its risks. Rupture of that aneurysm when it goes for coil or clipping, or simple the weight that weighs with you. Imagine if you were told that you have a 3 millimeter aneurysm in your brain, and then you were sent on your way because there was no indication for intervention at that time. Every single time you have a pain in your head, every single time you have a slight headache, you begin to think, is this the big one rupturing? So this is, of course, a point of division in emergency medicine, but we need to know that there are the ability to select additional diagnostic workup for patients presenting. And the reminder is important here that subarachnoid hemorrhage is the ball game and the most important thing to rule out in a patient presenting to the emergency department with headache. Here's a great example of why lumbar puncture helps us diagnose patients presenting with subarachnoid hemorrhage. We see in the first picture here a comparison of xanthochromia versus water. Lysis of red blood cells and the development of xanthochromia is diagnostic for subarachnoid hemorrhage. And you see in the next 3-4 tubes there some bloody CSF. Unfortunately, getting back to the cons of lumbar puncture, it can be for many a debate: is that a bloody, a traumatic test tap, or is that true blood in the CSF? Sometimes that can be difficult, particularly if your lumbar puncture skills aren't up to snuff. There is another component to introduce into the diagnostic workup of a patient presenting with headache concerning for subarachnoid hemorrhage, and that is the Canadian subarachnoid hemorrhage rule, which looked at patients presenting with headache and provided this clinical decision algorithm that if patients presented with none of the above, that is symptoms of neck pain or stiffness, age greater than 40 years old, witness loss of consciousness, etc., then you could forgo any imaging in those patients. Unfortunately, the specificity of this rule is quite low, and many patients who otherwise could go without diagnostic imaging may be suggested to undergo that imaging using the Canadian rule. What does it lead to? In the end, it can be difficult examining a patient presenting with headache, and it's upon the clinician to make that determination as to how likely they are to have subarachnoid hemorrhage and make decisions about diagnostic imaging from there. But there are other causes of serious headache. There are other things that we need to investigate. A good example here of idiopathic intracranial hypertension, once upon a time called pseudotumor cerebri, classically associated with the young obese female with irregular menstruation or amenorrhea. These patients will often present with odd headaches. They've had headache going on for some time, which right off the bat, we tend to minimize those presentations. But eventually these patients may complain, and this is always an alarm bell for me, of a change in their visual acuity. Classically, the patients will complain of change in their visual acuity from the periphery. It is almost always described to me as and I have never been able to understand what this means, but it's always explained to me like this: a bending in their periphery, a waviness of their vision of the periphery. This really should drive consideration for the diagnosis of idiopathic intracranial hypertension, a diagnosis that's going to be made by lumbar puncture, diagnosing that CSF pressure is higher than it should be. Now, treatment of idiopathic intracranial hypertension really begins with that large volume lumbar puncture. When you note that a patient has a CSF pressure that's greater than 20, greater than 30, greater than 40, or almost always coming out the top of the manometer, you simply want to do high volume lumbar puncture, bring them back down to a normal CSF pressure, and then they're initiated on carbonic anhydrase inhibitors, so classically acetazolamide, but more commonly now topiramate, because topiramate has some analgesic properties as well as itself being a carbonic anhydrase inhibitor. A diagnosis you don't want to miss, and classically something you're going to associate with an obese female patient complaining of headache, and then I really want you to have alarm bells to go off in your mind whenever you hear of visual complaints associated with headache, particularly in that patient population. Lumbar puncture, diagnosis made, patient can go home with acetazolamide or topiramate. Post-concussive headache, important and near to dear to me because one I suffered for quite some time. We talk a lot about post-concussive headache and the evaluation of concussion in the advanced EM course, but suffice to say that concussion has undergone a fantastic evolution in how we understand it in emergency medicine and medicine as a whole. Once sort of marginalized and thought to be relatively minor, we now know that concussion, particularly repeated concussion, can have severe, significant, and long-standing damage on a patient. You know, one of the things that's been fantastic and stunning to me is that we have seen an evolution in our understanding of concussion from a simple interruption of cortical processing to true damage to the underlying infrastructure of the brain. And there's fantastic research into things like particularly inflammatory neuropeptides, which are able to be detected following concussion and are suggestive that this is true structural damage to the brain that we simply can't appreciate with our current neuroimaging methods. But concussion is important, and it can be very difficult to treat post-concussive headache. It does extremely well with regional anesthesia, and we'll talk about that in just a few minutes here. A post-lumbar puncture headache, I want to talk about it because I want to encourage you to do more lumbar punctures. What we've identified here is that lumbar puncture is useful for assistance in diagnosis in subarachnoid hemorrhage, but also obviously important for diagnosis of meningitis, encephalitis, of idiopathic intracranial hypertension, or a number of other diagnoses. But post-lumbar puncture headache is a complication of that, seen in really up to 30% of patients who undergo lumbar puncture in the emergency department. A lot of myths surround this. And I remember growing growing up in residency being taught, give them fluids and lay them flat, that's the best thing to do. Neither of those things have been proven effective. In fact, they've been proven ineffective for the treatment of patients presenting with post-lumbar puncture headache. What we have found to be effective in the treatment of post-lumbar puncture headache, standard analgesics, a blood patch, of course, consult anesthesia for placement of blood patch, caffeine, get the patient a Coke or a cup of coffee from the physician lounge. And then finally, and interestingly, a neat little study published a few years ago in the American Journal of Emergency Medicine, which compared a blood patch to sphenopalatine ganglion block. And we'll talk a little bit about sphenopalatine ganglion block, and found them to be of similar efficacy for the treatment of post-lumbar puncture headache. So it is now my routine practice to do a sphenopalatine ganglion block prior to consulting anesthesia for placement of a blood patch, and most of the time I no longer have any need of anesthesia for blood patch placement. Ventricular shunt headaches. Patients with VP shunts are important patients to remember. They have a lot of significant complications from their VP shunt. They can have blockage of that drainage system leading to an increase in CSF pressure. They can have infection, and all of these patients deserve detailed evaluation. Almost always are going to need a shunt series and evaluation of their shunt. Almost always are going to need evaluation not only of their shunt but of their CSF, particularly if they present toxic or of any other signs of infection on their workup. A picture of a VP shunt. Mass lesion headaches, this is something we never want to miss, of course. These are brain tumor headaches, patients who present complaining of headache because they have increased CSF pressure. Often this will be a new headache, patients presenting of pain in the morning or following laying flat, often associated with nausea and vomiting, and one of the key reasons why we need to do our fundoscopic exam, because this will be a giveaway every single time when we identify AV nicking or any changes in that fundoscopic exam which may be suggestive of a mass lesion headache. Toxoplasmosis, the most common CNS mass lesion in HIV patients, I want to bring that up because it is not uncommon at all, and something that has happened more than once in my career, where the diagnosis of HIV or AIDS is backed into because a patient presents with headache, a non-specific or odd headache, and imaging is undertaken which diagnoses that ring-enhancing lesion, and you diagnose toxoplasmosis and actually back into that HIV/AIDS diagnosis. Important to remember toxoplasmosis, particularly in patients presenting with HIV/AIDS or any other immunocompromised patients, and think of that ring-enhancing mass lesion as the underlying cause for the patient's headache. But overwhelmingly, when patients come into the emergency department or when you see your family members or yourself, you don't have toxoplasmosis, you don't have subarachnoid hemorrhage, you don't have any of those serious underlying causes of headache. We'll see those patients, we'll see plenty of them, and we need to do a good job of diagnosing and getting them to specialist care, whether it be surgical or medical. But more often than not, what we're experiencing and encountering in the emergency department is patients presenting with migraine or tension headache. Overwhelmingly, migraine headache outperforms presentation of tension headache to the emergency department. And while we classically talk of about an 80-20 split, over the years this has actually evolved more as we've seen more routine utilization of the emergency department. That evolution has gone more toward about 60-40. About 60% of patients who present with benign primary headache to the emergency department have a migraine headache, and about 40% have a tension headache. And then there's a small component that have cluster headache as well. And cluster headache is staggering. Once you see one cluster headache, you'll never forget the diagnosis of cluster headache. Classically, the patient will present of severe unilateral pain, often around the eye. These patients are moving. They're in extreme pain. It is a sudden onset of their headache. Often it is not the first presentation that they have with cluster headache. Suicide is an incredibly high occurrence in patients with cluster headache because of how severe and recalcitrant this pain can be. And unfortunately, in my headache clinic, I encountered many patients with cluster headache who had contemplated suicide because of the seriousness and frequency of their headaches. And these patients will absolutely do better from some of the medications that we're going to talk about in just a few seconds here. Migraines classically more often affect the female gender. I want to talk about that really briefly because if you remember the beginning of my slides here, it was a picture of a woman with holding her head and she had a headache, and there is ample evidence that teaching and understanding, intervention upon, and research for migraine has been vastly underfunded and underapproached in emergency medicine and medicine as a whole, and there is good literature to support that is likely because of the significant female predominance of the disease. And it's a good reminder for us in emergency medicine to treat everybody as they come, and the importance of us redoubling our efforts on the treatment of headache because of how classically it has been short-shrifted over the years. These patients very often will present with pounding unilateral headache, refractory to over-the-counter medications. These patients do, unfortunately, have a higher risk of subarachnoid hemorrhage, and that's what so often can make the diagnosis difficult. Classically, we look for a patient who presents with a headache, describes it as similar to previous headaches, provides a migraine history, often will be on underlying migraine controlling medications, and then we need to intervene and, of course, make their headache better. Cluster headaches, we're going to talk a little bit about the treatment of all headaches, but when we talk about cluster headaches, the application of 100% oxygen is always the first intervention there. So why do people get headaches, and how then do we fix them? I remember in medical school learning about cortical spreading depression. I remember learning about vasospasm as the different underlying pathophysiology for why patients were presenting with headache. And it turns out it's all wrong. None of that's true. And we've learned so much more about headache in the past 10 years. And one of the most interesting things we've discovered is that the underlying sort of foundational pathophysiology for most patients presenting to the emergency department with migraine headache is not that cortical spreading depression or vasospasm, but an underlying increase in inflammatory neuropeptides, specifically a peptide called CGRP, or calcitonin gene-related peptide. And we now know that so many of our interventions, which have worked for a long time without a great functional reason why, they work because they decrease CNS concentrations of CGRP. And what are those treatments? What are those medications? Well, we'll get to that in just a second, but the other underlying cause is cervical neuropathies. Patients most classically presenting with tension headache but just not getting better have developed a cervical neuropathy because of that tension or torsion within their head and neck muscles. And so those cervical neuropathies and disruptions in inflammatory neuropeptides, that's what drives disruption in thalamocortical sensory processing and upregulation in further inflammatory neuropeptides. And so our treatment then is driven at intervening upon those cervical neuropathies and those inflammatory neuropeptides. Many of you, I believe, are likely well acquainted with the use of neuroleptics for the treatment of patients with primary headache, whether this be prochlorperazine, compazine, metoclopramide, Reglan. Some people will more frequently use droperidol or Haldol or any of the first or even second generation neuroleptics, which have now been demonstrated to be the best single interventions, the best first-line interventions in the headache for patients presenting in the emergency department for patients presenting with primary headache. And the reason they are so successful is because they rapidly decrease CGRP in the CNS. And this underscores why what you don't see on this slide is opioids. Opioids are the wrong choice in patients presenting with primary headache to the emergency department. And in fact, if you are using opioids for the treatment of primary headache, it should be a huge alarm bell, a huge sign that you are missing something. One of the things that I do in my practice is I do a lot of expert consultation for patients who have bad outcomes from the emergency department, particularly from headache. And one of the things that I see again and again and again is patients who were discharged from the emergency department from headache, but only after they had their pain controlled with multiple doses of morphine, fentanyl, or Dilaudid. This, after study after study, guideline after guideline, which says do not use opioids for the treatment of primary headache because it does not address the underlying cause of pain in these patients. The pain center of the brain is the insular cortex, right? That insular cortex is where these pain signals go to, and that's why I get pain when I stab myself in the leg, or that's why I have pain when I have a broken arm. But why I have pain when I have a migraine is fundamentally different from that. It's not that I need mu receptor agonism from an opioid. What I need is intervention upon calcitonin gene-related peptide, something that opioids simply don't do at all. In fact, there's even a little early evidence to suggest that opioids may increase the concentration of CGRP within the CNS. Take opioids completely out of your analgesic armamentarium for the treatment of primary headache and incorporate, obviously, as your first-line neuroleptics. There are additional abortive therapies. There are triptans, there's DHE, there's Depakote, a number of other medications that are routinely used for the treatment of primary headache, but often don't need to get there. but you gotta stay away from opioids in the treatment of primary headache. And I wanna give you a few additional tools for your armamentarium in the treatment of patients presenting with primary headache, because this is something we see so often, something that can be a difficult analgesic presentation, but additional analgesic techniques are extremely effective in the treatment of primary headache. And I want to begin with paraspinous cervical nerve block. It doesn't get much easier than this procedure. Paraspinous cervical nerve block was best described by Larry Melick et al. A few years ago in a small prospective trial where they administered paraspinous cervical nerve blocks on patients presenting to the emergency department with primary headache. And what they found was remarkable. More than 60% of these patients had complete resolution of their headache within 10 minutes of the cervical nerve block. And that's amazing, and it shows us two things. One, that we can have a lot of effect with a little intervention, and two, even if it doesn't work, it's only been 10 minutes, we can move on to our next line in our analgesic armamentarium. This is done very simply by taking 1 to 2 cc's of lidocaine and injecting it 1 to 2 finger breaths lateral to the C7 process, right into the musculature, injection of a wheel of lidocaine. Think of it as a trigger point within the cervical spine. It works extremely well and is extremely easy. We're running out of time. I want to get to sphenopalatine ganglion block. Sphenopalatine ganglion block is classically done under fluoroscopic guidance. You take a needle, you shove it in through the mandibular condyle here, or maxillary condyle here. You find the sphenopalatine ganglion within the sinus. You ablate it or spray some lidocaine on it. But you don't need to do all that in the emergency department. In fact, what you can do is simply take one of those long Q-tips that's sitting in the gyne cart over there or sitting in the cart in the emergency department, cover it with lidocaine, and shove it in the nose. When you shove it in the nose, that lidocaine that's on the end of that Q-tip, and you will do this bilaterally, will find its way through the pterygopalatine fossa and find its way to the sphenopalatine ganglion, and it will cause anesthesia of the sphenopalatine ganglia, which will numb all head and facial pain and is extremely effective in the treatment of primary headache. There's been a number of ED investigations on this which have fallen short, and when we get to the Q&A session, we could talk a little bit more about how to be successful with sphenopalatine ganglion block. And then lastly, I want to talk about propofol. I use propofol routinely in the treatment of primary headache, both in the outpatient environment as well as the emergency department. What we have found is that propofol is extremely effective in rapidly lowering CGRP concentrations within the CNS. And propofol microdosed, much like we do microdose ketamine or low-dose opioids for the treatment of other painful processes, microdose propofol is extremely effective in a number of randomized controlled clinical trials, as well as a number of prospective observational data sets. Microdose propofol, about 0.1 mg per kg, or round up to 10 milligrams, given every 1 to 2 minutes up until cessation of pain, works phenomenally well for the patients who have headache refractory to first, second, or even third line interventions. And we can certainly talk about that more offline. And that's what I have about headache. It's such an important thing to be good at. It's such an important thing to make good diagnostic choices for, but it's such a rewarding way to have effective analgesic intervention for our patients, and I really hope that you enjoyed it. Thanks, guys. Break. Oh, and you have a break. Thank you.
All right, folks, welcome back from break. We are going to move ahead with a few more ortho talks today and tomorrow. So I'm going to talk with you right now about shoulder disorders. And we're going to start by talking a little bit about anatomy. And I want to do a little compare-contrast to the hip, because these two joints, although they're both ball and socket joints, boy, are they different. The hip, we talked about being a really resilient, strong, architecturally sound joint. The shoulder is basically the polar opposite. There is a ton of bony instability. The great thing about the shoulder is no matter what direction you want to pick apples, you want to play craps, you want to dig, whatever you want to do, this thing goes in all hemispheres and can do all kinds of things. The downside of that is there's not a lot of bony stability around the shoulder. So unlike the hip, it doesn't take a tremendous amount of force to dislocate the shoulder. Just a poorly timed high five with a friend in the wrong position could get you there. So let's chat a little bit about why that is and a little bit about shoulder anatomy. So I had a mentor of mine once describe the shoulder sort of like our families, just a little unstable. And the reason for that is that when you look at the shoulder blade, the scapula, it's sort of a free-floating bone without a whole lot of articulation points, right? This big thing that is the shoulder girdle, it's connected to the axial skeleton only by the sternoclavicular joint. And then the other points of articulation are your glenohumeral joint, and then you also have your AC joint. But other than that, there's not too much. A lot of mobility, but a lot of instability. And if we're looking at the bones here, some of the key players, you have the sternum, you have the clavicle. The clavicle then articulates with the acromion, which is a part of the scapula. Below that, you have the coracoid process, and then all the way laterally, you have your humeral head. In terms of muscular anatomy, the big muscular players here, the rotator cuff that you often hear about, the subscapularis on the front side and anteriorly, and then on the back side you have the supraspinatus, infraspinatus, teres minor, and then you have your the bicep, which the tendon, the long head of the bicep tendon goes through the bicipital groove up there. And last thing that I want you to take notice of is just below the acromion, you see that little blue thing? That's the subacromial bursa. And that is going to be a key player as well when we talk about some causes of shoulder pain and some of the pathologies. This is just another anatomical photo with some of the first photos, some of those layers peeled back. Some important concepts. So we've already talked about the bony instability. We've already talked about how a lot of the shoulder is connected by the soft tissues, the muscles, the tendons, the ligaments, and less so by the bones. The last really important concept here is that when you injure the shoulder, that it doesn't tend to happen in isolation. The shoulder doesn't tend to have, you get a dislocated shoulder, you tend to also get rotator cuff injuries. Or you get a fracture and you also can get a dislocation. So that's pretty common with the shoulder. In terms of the shoulder exam, if you've ever looked up how to do a proper shoulder exam, man, it takes like 10 minutes to do this thing comprehensively and the right way. But I want to give you guys sort of an approach that's something that we can do quick, easy in the emergency department that gets us through most of it without having to spend an exhaustive amount of time, like more than you would for a stroke evaluation. So as with all physical exam things, we start with inspection. So the first thing I urge everybody to do when somebody has a shoulder complaint is don't let them sit there with their shirt on and the sweater and their starter jacket and just pull that thing off. Like get everything off, put them in a gown so that we can kind of take a real good look for bruising, ecchymosis, any deformities. You might even pick up a case of zoster as for shoulder pain, and we do a good inspection. Palpation. The way I like to palpate the shoulder is to start medially at that sternoclavicular joint, at the axial skeleton, and work my way out to the humeral head. So I'll often start with the sternoclavicular joint. If you have, sometimes you can get clavicular dislocations over there in high energy mechanisms. Start there, see if there's any pain, move along the clavicle, palpate where the AC joint is, see if that's a source of pain. And then you can move down into the humeral head, into the bicipital groove. And then finally, you're going to want to get to all the range of motion exercises. And so what are the range of motions? So the ways that I think of it is you have flexion, which you can go pretty high, extension, which can get you back about 40 degrees, abduction, sort of snow angel, adduction, and then you want internal and external rotation. Those are sort of the cardinal movements that you're going to want to go through. And we'll talk about how that relates with rotator cuff injuries and specific injury patterns as we move through the talk. Strength testing is going to be important. Sensory testing, you'll often hear about the axillary nerve. There is actually, it says good video, so it is pretty good video. It's a YouTube video if you want to see the comprehensive exam. There are just so many special tests that you've probably heard about in your, in your training or reading about the shoulders, the Jurgensen's, the NIRS test, and all this kind of stuff. I don't want you guys to memorize all those, but it is good one time to kind of go through this and see what the spectrum of physical exam is for the shoulder. So we'll start off with AC separations. AC separations tend to occur, you guys have probably all seen these, tend to occur in people that they fall off a bike or something, or fall off one of these Lime scooters where people are getting injured all the time. They fall off and they just didn't have time to get that hand out. They otherwise would have had a foosh or something like that, but they go and you get a direct blow to the AC joint, and that can pop your AC joint out of place where it articulates, the acromion articulates with the clavicle. Now there's different gradations that you can see here on the illustrations. Grade 1s, grades 2s, not so big of a deal. Grades 3s also sometimes can be non-operative, and then as you go up in your grading system, it can get worse. So what really distinguishes these grades? Let's kind of focus in here where you see a normal AC joint. There is the articulation between the acromion and the clavicle. That's your AC joint. And then from the clavicle to the coracoid, there's another big ligament there, the coracoclavicular ligament. And those are stabilizing. So in a grade 1, grade 2, you only have the actual AC joint. You won't see this disarticulation. But if you get a grade 3 and that CC ligament also gets affected, look down there, you can actually see the AC stepping up. And then grades 4s through 6s have to do with, is there skin tenting? If there's skin tenting and it's puncturing through the skin, that is when we call ortho. We typically don't need to call orthopedics. This is usually a sling and refer type of injury. But if you start getting skin tenting and that is a problem, or it's like badly comminuted and not just tenting but poking through the skin, those are the kinds of things that you would want to call ortho for right away, but that's very, very rare. Shoulder impingement syndrome. This is another entity that you're going to probably hear about. How do we diagnose it? How do these patients present? So, and why do they present like this? So shoulder impingement syndrome, we talked about the acromion, we talked about the humeral head and the subacromial bursa. That space, there's a lot of anatomical variation amongst everybody here, sitting here today, and myself. Everybody's going to have a little bit of a different space in there. It tends to be sort of only millimeters big, and when you have a tighter space between your acromion and your humeral head, that space can get irritated. So a lot of structures go through there. Your supraspinatus tendon goes through there, your biceps tendon goes through there, you have your subacromial bursa. Any of those structures, once they start getting inflamed and irritated, especially in people that have anatomically tighter spaces, they can get something called shoulder impingement syndrome. The way you're going to look for this on exam, we talked about sort of doing abduction. They call it the painful arc syndrome. You start ranging them all the way through, and they're going to get points of impingement here, and they're going to be uncomfortable, whether you do it passively or actively. And it's a little bit unfortunate with shoulder impingement syndromes. A lot of times you can just give them like NSAIDs, you give them ice and physical therapy, but it can resolve with rest and exercise, but sometimes it can take 6 months or so to resolve. But again, this is an outpatient diagnosis. The way that outpatient referral, you won't see much in the way of X-ray. You'll just have to understand that, like when you're starting to get pain in that subacromial bursa region and pain in that region, this is a potential diagnosis. Again, you're just seeing the anatomy that's coursing through that subacromial space right there. A variant, so a different entity here, which is calcific tendinitis. Calcific tendinitis, the way that this sort of presents is also they get this painful arc syndrome. The only difference is the X-ray is negative for the shoulder impingement syndrome. In calcific tendinitis, you're fortunate enough, how many shoulders do we image and we just get nothing? We don't see anything, and you have to tell the poor patient, rest, ice, we don't know. There's some soft tissue problem over there. But calcific tendinitis, you can actually show them where the problem is. And so you can see here the supraspinatus tendon, or like the distal part of the tendon of the long head of the bicep. Those things can get calcified, and you can actually show the patient. So the good news is you can tell them what they have. The bad news is this one can take sometimes, it can go away. Even you get this in like a 35-year-old, 40-year-old, we don't really know why it happens, why this calcifying process happens. But after you tell them, hey, good news, we know what you got, bad news, it may take 3 to 5 years for this thing to disappear. So sometimes patients live with this thing for long, long periods of time. What can you do for it? Again, physical therapy, NSAIDs, ice. If that doesn't work as an outpatient, a lot of these can get injections. I know some ED docs that like to do the injections themselves. There's some variability in practice there. And then, if they fail all those things, there's interesting things that they do. They can do these like needling procedures where they lavage and all kinds of weird stuff they can do in there to help these patients because they will have it potentially for a long time. Biceps tendon rupture. A biceps tendon rupture, these are pretty readily apparent. Usually the mechanism here is somebody who is carrying, trying to flex a lot of weight against resistance, and then you hear the sudden pop. And the tendon, where it tends to rupture, if you remember, you have a proximal insertion, so you have the distal insertion at the elbow, you have the proximal insertion where we saw at the bicipital groove. The far more likely place for it to rupture is up here at the bicipital groove. What do we do for these? Big deal. They can develop these like Popeye arms and real deformities, and you think, my gosh, we got to get this thing fixed right away, refer it right away. Actually, these patients tend to do pretty well. They don't need really urgent referrals. There's not much to do. Most people actually preserve a lot of their strength from the short head of the bicep, especially when it happens proximally. The people that you do want to refer is if you get, like, if Devin Booker or Giannis, like one of these famous basketball players, they get an athlete, a high-functioning athlete, and they need to preserve every little bit of strength that they have. Those are the patients typically that get referred for repair. If you get a distal rupture, those need to be a little bit more urgently referred. The reasons that people can get these: fluoroquinolone use, steroid use, especially if you have the combination of fluoroquinolone and steroid use. So you have a COPDer who just had an exacerbation, they're on steroids, you've given them a dose of, you shouldn't, but you give them fluoroquinolones on top of the steroids. Those are people that are at really high risk for rupture. The interesting thing about fluoroquinolones, if you give somebody a course of fluoroquinolones, how long after you give them the fluoroquinolones are they at risk for rupture? Is it just while they're on the course? Yeah, right. So they are at highest risk during the course and a little bit after the course, but up to a year after, they can still be at risk for these types of things. So something to consider. Thoracic outlet syndrome. If anybody's ever diagnosed thoracic outlet syndrome, you get the Diagnosis of the Year award. These are tough to diagnose, tough to pick up. But really, the way that patients will present here is sort of like arm heaviness. They'll have a extracervical rib sometimes, or some tightening in that space in the thoracic outlet where the arteries, nerves, and veins course through. And there's 3 different types of thoracic outlet syndromes. What are they? They're arterial, venous, and neurologic. And they all present a little bit differently. You could imagine somebody with an arterial thoracic outlet where the primary problem is the artery being compressed. Those patients might have some pallor, heaviness, almost like when you get claudication of your leg, you hear that kind of story. It'd be sort of claudication of the hands and arms. In the venous types, I don't know if anybody's ever seen this, a case of like Paget-Schrader. They might be thrombosing because of this. You get that compression of the vein, and then they can start getting swollen. I've seen a few of these where you get a young guy playing basketball, and all of a sudden he's coming in with this big thrombosed arm. He doesn't have a PICC line in there. There's no other real reason for it. It's just an overexertion type of injury, and they'll just come in with a big swollen arm compared to the other one. Those need to get referred, and then the neurologic type where they get numbness, tingling, and all that kind of stuff. So how do we test for these? There's 2 tests that are often described. There's the Adson's test and the East test. It's really important to know the Adson's test, you're having them sort of like twist their neck over toward the affected side, and you're feeling for the radial pulse, and they start losing that radial pulse. That's concerning for an arterial thoracic outlet syndrome. But you're not testing for the other types, but using the Adson's test. The other thing that you can do is the East test. You have them do this, sort of the funky chicken type of thing, and you have them do this for about 3 minutes, and if they start getting numb, like pain, heaviness, tingling, that could be neurologic, arterial, or sort of a combination of those. So you get somebody with unilateral arm pain, heaviness, those kinds of things, thoracic outlet syndrome is the thing to consider. Clavicular fractures. So we see a ton of these. These are unfortunately very common. And these are a result of falls to the shoulder. We just had a resident that we had, at a retreat, fell by the poolside and had a pretty well-displaced fracture of his clavicle. Fortunately, it's unfortunate that they're commonly fractured, but fortunate in that most of the times these things do well with just a sling. Now, there are certain times where you need more than a sling and that we're a little bit more concerned. Where are the majority of these clavicular fractures? Are they medial, middle, lateral? Yeah, the mid. So the majority of clavicular fractures are right there in the middle of the clavicle and don't need too much intervention other than sling and referral. But if you get tremendous amount of displacement, even in the middle, and again, skin tenting is the thing that you're going to be wanting to look for, that needs to be an ortho call. The problems with medial fractures you can have sternoclavicular involvement. There are great arteries and things over there. So if you get a high energy mechanism and you see a clavicular fracture over medially near the sternum, I'd have a very low threshold to do some more advanced imaging and make sure there's not other big injuries there. And then in terms of function, when it gets out closer to your shoulder, closer to the AC joint, and that's disrupted, and you have a clavicular fracture there, that can destroy the integrity of the shoulder girdle. Those also need to be evaluated, not emergently, but need to be evaluated by ortho. So do you guys remember these figure of 8 splints? We used to put all these clavicular fractures in this very complicated figure of 8 splint that would fix your posture and help with your clavicle fracture. And we found out actually that a simple sling is much better. These figure of 8 splints actually will cause more skin breakdown. They have poorer healing. So please don't, if you have them in your ED, please don't use them. A simple splint is much better. We talked about both AC separations and we've talked about clavicular fractures. You'll often see people put them in slings. The sling, where you really want the majority of that pressure, you'll see them kind of slung down here, which is fine when you have like wrist problems and that kind of thing. But really where the point of comfort is, you want to raise that sling up so their shoulder isn't like really moving around. So if you can get it up and make the point of pressure at the elbow, it helps with patient comfort. Rotator cuff syndrome. So everybody's probably heard about the rotator cuff. The rotator cuff is a very well-known player in the shoulder. Baseball players, you'll often hear like overuse injuries and whatnot. On the way here on the plane, I actually had these slides pulled up, just kind of doing a final review of the shoulder talk. And the guy next to me, he looked at me, he's like, I don't mean to be nosy, but I have this thing in my shoulder. I felt a little pop, and you think it's a rotator cuff? And so actually on the plane, there was nobody between us. We went through and did all the maneuvers and everything. And I was like, it's fine. It didn't feel like it. He was a little tender going up on abduction. He might have a little bit of impingement. I told him, he was like, I'm so sorry to bother you. And I'm like, I'm just happy it's the shoulder and I'm not, looking at an anorectal lecture or something like that. So I was just fine with doing the shoulder exam on the plane. So how do these present? So there's 4 different, we talked about the different rotator cuff muscles, and the different rotator cuff muscles are, you have your subscapularis, supraspinatus, infraspinatus, teres minor. Each of them can be tested in isolation. We often think about rotator cuff injuries as being limited in abduction, and that is true, and that will happen when you have a supraspinatus issue, which is up top, just above your scapular spine. But there are some other provocative maneuvers that are really good to know, and basically the 3 provocative maneuvers that are simple tests to do. Abduction, looking for supraspinatus, and then all you got to do is get them internally and externally rotated against resistance. If they're limited in external rotation, then that's concerning for your teres minor infraspinatus. If they're having difficulty against resistance internally rotated, that's concerning for a subscapularis on the anterior side. So not too many maneuvers, but some special maneuvers to help you with diagnosis of this. Why does this happen? The rotator cuff is in its most vulnerable position when you're up here, sort of in the high five or baseball throwing position. And so any kind of repetitive stress in these positions can cause stress, where you can see all the tendons are inserting there on the humerus. And the humerus is, like I said, at its weakest point in this position. You can see these vector diagrams. We're not going to go through physics, but... And one of the things that is a related topic to a rotator cuff injury is this shoulder dislocation. So how many hip dislocations have you seen in the past year? Maybe 1, maybe. How many shoulder dislocations have you seen in the past year? A lot. So shoulder dislocations are far more common than hip dislocations. We talked about hip dislocations being very commonly pushed back through a vector posteriorly. Anterior shoulder dislocations are the opposite. The anterior is far more common, the posterior far less common. And then you can get these inferior dislocations as well. And when you see somebody with an anterior dislocation, you get this squared off shoulder appearance. You guys are probably familiar with this. Somebody just holding their shoulder and not wanting to move it at all. On the x-rays on an anterior, you'll see the anterior sort of pushed in more medially, depending on the view that you're getting. But you can see that, that anterior dislocation, a little bit medial and anterior. So how do we evaluate these? The really important for all of these injuries is distal neurovascular exam. Where you definitely want to focus is making sure that they don't have any numbness around their deltoid where the axillary nerve is. And then in terms of relocation and getting them prepped for reduction, hips, we need to knock them out. We need to knock them out and get all those like muscles relaxed and whatnot. But because of the lack of stability in the shoulder, if you get them, I don't know if anybody's ever had somebody, pop a shoulder out skiing or snowboarding or something like that. I mean, that's the moment to get them back. If you can get them back right then and there, the muscle spasms hasn't really set in, and you can do a pretty quick, easy maneuvers and pop them back in. The longer they wait, the harder it is to get that thing back in. But the really beautiful thing about getting these shoulders back is we don't need to put them under propofol sedation every time or procedural sedation. Sometimes just an intra-articular thing, or hopefully a little later we can show you this Cunningham technique, which is, has anyone done the Cunningham technique? You sit, you kind of stare into the patient's eyes and you relax and they get a free massage and also their shoulder tends to pop back in. So there's some cool low stress maneuvers that don't take a lot of resources with nursing and pharmacy to be able to do. And then an interesting point about whether or not we need to get pre-reduction films. If you've seen enough shoulder reductions and you see somebody and they have the squared off shoulder and it sounds like a shoulder dislocation, smells like a shoulder dislocation, you've seen 100 of these, do we really need to get shoulder films? So definitely with the people that have chronic dislocations, they've dislocated their shoulders multiple times, I think that you are just fine not getting films on those. For a first-time shoulder dislocator, it's sort of, again, some variability in practice, but there is, there's experience and evidence to suggest that it's probably okay to not have to get the film, unless you are concerned about a really high energy mechanism or a concomitant fracture or something like that. One downside of getting pre-reduction films is if you have a really busy radiology department, the longer we're sitting there waiting for these pre-films, the more that they can spasm up. But it's not totally unacceptable to get the pre-reduction films. Post-reduction films, I get every single time just to make sure that I've gotten everything back into place. So older patients, I actually get films every single time. Sometimes you think it's a shoulder and it's actually their proximal humerus and there's all these associated fractures and things, so I don't mess around. But younger patients, it looks and smells like a dislocation, then we're fine. So I'm gonna give a brief overview of some anterior shoulder techniques. There's sort of the paradox of choice. There's almost too many choices when it comes to anterior shoulder reduction techniques. So I'm going to kind of pair them up like 3 general categories that you can use. There's no one technique that works best for everybody, just because the way that the shoulder dislocates usually goes to like the inferior rim of the glenoid fossa and anterior. So, and depending on what position it's in, different techniques could work better. So let's talk through a few of the different techniques, and they're all sort of listed here for your for reference, but we'll go through them individually. Stimson and scapular rotation. This is nice when you have a super busy emergency department that's just bumping and you don't have time to do the whole evaluation. If you have weights in your emergency department, you can have them sit prone, lie down prone, attach the weights and just have them hang for a little while and let them sort of relax their muscles on their own. You don't even need a tremendous amount of sedation, or you can give them some Versed beforehand and just kind of let them sit and relax. And then you can kind of combine that or separately just do a scapular rotation. I have intermittent success with scapular rotation, but the way it tends to work is if you can feel the inferior tip of the scapular spine, you want to really move that medially the way that it's shown in this photograph. So the Stimson and scapular rotation are a couple potential techniques. Fairs and Spaso. We're going to talk about the Hennepin and Milch, which is far like my preferred starting reduction technique, but the Fairs and Spaso are also totally reasonable. The Fairs technique stands for fast, reliable, and safe. So hopefully it's fast, reliable, and safe for you. The way that this works is you get them out into sort of external rotation, abduction, and then you waggle them. You get them up and down like this, and you kind of like try to loosen the humeral head off the glenoid fossa and get that back into place. Spazo is sort of a variant of that. You have them laying supine. You get them up into this sort of like vertical position, and you give gentle traction, and you just internally, externally rotate them and hope that the humeral head pops back in. I don't use these too often. Amongst yourselves, I would talk and see if people have used these things. They're worth trying, and they're well described and have pretty good efficacy. Hennepin and Milch. The Hennepin and Milch techniques, I like this a lot. This is something that I've been using since residency, and it tends to work pretty well. You get the patient out into external rotation. This is the Hennepin, and you start them in abduction, and that tends to work a lot of times. If that doesn't work, then you can get them into this Milch position, which is often described again as like sort of the apple picking position. So you get them into a Hennepin, and if that's not working, then get them all the way up into this Milch position. The last technique that's not featured on these slides is this Cunningham technique, where you sit on a chair, you have the other person sort of like eye to eye with you. You have them put their hand on your shoulder, you put your hand on their sort of scapular spine, and you have them relax. And basically what you do is you start massaging these muscles that are starting to spasm. You massage their sits muscles, their supraspinatus, like the trapezius muscles, the bicipital groove, deltoid, going down to the bicipital groove. And just doing that for a few minutes and having conversation with a patient can sometimes pop it in. So it's not featured here, but I'd encourage everybody to take a look at it and try it. That's like a really nice sort of initial technique as well, the Cunningham technique. Things not to do. So all of these positions, anything that you look at in a book, you open up Roberts and Hedges or any book, and you see somebody sticking a foot in somebody's axilla, don't do those things. Those are high risk for axillary nerve damage, and just in general, just not favorably looked upon when you're like shoving your foot in someone's armpit in the emergency department. The Coker technique, which used to be done fairly frequently, external rotation, you bring them back out into internal, that's also higher risk of axillary damage, so try not to do that as well. The posterior shoulder, we're gonna move on from anterior to posterior. The far less common version, how does this one happen? Posterior shoulders tend to need more high energy force to dislocate and are often missed on x-rays. Why? Look at that. The glenoid and the humeral head actually look like they're pretty well aligned. The problem is just the morphology of the shoulder is not the way it's supposed to be. It looks more like a light bulb in this photo, or a drumstick, like a chicken drumstick, sometimes they'll describe it as that. But if you see that, and typically the patients that get this are somebody who's been having status epilepticus or seizures, convulsions, and then they'll come in and you're working on the convulsions and you get you get an x-ray for whatever reason. Sometimes these are missed. The other way that you hear it described is sort of like lightning injuries or really bad car accidents. This is the last one, luxatio erecta. Has anyone seen this? This is pretty interesting pattern. It's an inferior dislocation that's like a variant of anterior. The patient actually looks like they're coming in this very dramatic pose. It's like the back of the hand, the palm to the forehead sign, so luxatio erecta. And it's fairly easy to put back in. You just take them in the position they're in, and you do inline traction, and that'll get them back to where they need to be. These ones are unique in that they have a lot of associated rotator cuff injuries. Finally, we got some adhesive capsulitis and frozen shoulder, and patients who get dislocations, if you throw them in a sling and tell them to be like not do anything with their shoulder for the next 6 weeks, this is something that can develop. This is why when we have people leave the emergency department, you put them in a sling 1 to 3 weeks and you start having them do range of motion exercises, because if you don't, it can start to prolong the mobilization, can lead to this adhesive capsulitis. That capsule around the humeral head gets stuck. And then when you do that painful arc, they actually they can't. They can't passively or actively range their shoulder. It's a frozen shoulder, and that's not a good place for patients to be. So often we'll send people home with these Codman's exercises. You'll see people like, you'll put a hand on the wall with one hand, and with the other hand, you're sort of stirring the pot and doing these different kinds of exercises. Really easy to do, but all my shoulder dislocations, I print these, any kind of shoulder injuries you want the people to be doing the Codman's. Last topic, proximal humerus fractures. We see a ton of these. These are more typical in elderly patients. The forces tend to get transmitted all the way up to the proximal humerus when they fall. Instead of getting Fuchs injuries in the wrist, they'll tend to get these proximal humerus fractures. that can be comminuted. The majority of these, unless it's big time displacement or big time angulation, most of these can go home in a sling as well. The only exceptions to that is if you have a fracture and a dislocation, they can be unstable. I would call ortho because you don't want to be pulling on those shoulders, getting it back into place if they have a concomitant proximal humerus fracture. And then the last kind of humerus fracture that's important to know, tends to happen in younger patients, is a midshaft. You have to do a really good, on the proximal ones, you want to do a really good axillary nerve exam. On these midshaft ones, the radial nerve, they can get wrist drop. You really want to be checking for wrist extension, and these can go at home and coapt splints and those kinds of things. Okay, so that wraps things up for the shoulder. We're moving on to our next topic.
Thank you. All right, well, good morning again. So let's kind of talk about some more of these things with trauma and talk about head trauma itself. And kind of one of my favorite topics, especially working in flight. We do a lot of these, which usually means procedures for those of us that enjoy those. But trauma, for the most part, is pretty simple. It's ABCs, but then sometimes it's those minor patients we have to think about that really make us work for that money to figure out, hey, is this patient something we need to do more with, or is this something we can just watch and wait? So definitely we know we unfortunately live in a litigious society. We do have some really good clinical decision tools out there to help us in deciding what patient needs what. Especially when we talk about pediatrics. Should we be getting imaging of their head, or should we just do observation, or just good education? So definitely we know that our patients with head injuries can present with various things. They may be the typical, straightforward, obvious head trauma. They're altered, they're confused. But it may be something more subtle, like just they're amnestic to the event. Or maybe they have other type of neurological deficit or sensory loss that we have to kind of identify and tease out. A patient I had just the other day had a head injury, pretty minor, but it was amnestic as ever. And totally, that patient that we love so much that every 5 seconds asking me the same question over and over again. What happened? Where am I at? Who are you? And just kept going. And that sometimes is challenging because now I've got to figure out, is this truly just a mild TBI or does he have something else going on? So just kind of keep that wide range of suspicion out there that if they had this head injury, maybe it is minor, but maybe it's major, and let's rely upon our physical exam findings and even the history of the event to kind of help guide us in what we need to do with this patient. So very common in our young male population, especially in the Caucasian males, and usually involves the, hey, y'all, watch this, hold my beer. Those are famous last words for a lot of the patients I see, especially this time of the year. But what do we see? Is it major trauma? Is it minor trauma? Major's pretty easy. And then thinking again about those minor things to make sure we don't overlook something. I don't want to kind of get anchored down. Oh, hey, it's just a minor head injury. Let's not miss something. We know that scalp lacerations can bleed a whole lot, very vascular, and sometimes just that smallest little nick can make it look like they've got a very large laceration. And especially in our older patients who are probably anticoagulated or antiplatelet agent, that tends to make it even more difficult to control. But direct pressure should always be our first intervention. If I can, go ahead and throw in a stitch or a staple, or if you have some of those cool little devices that can crimp the tips of the wound edges. Go ahead and start anesthetizing those with lidocaine or Marcaine with epi, and that can sometimes really help. We've got combat gauze that we can use now, some of those thrombin-impregnated pads that can work, but definitely we know that patients can sometimes lose a lot of blood and become hypovolemic just from that head injury. Always a good idea when they're moving them over from the EMS stretcher to your bed, what does it look like? And tons of these have that little center groove down the middle, and it's full of blood. Patients bleed out all kinds of places, and one of those is on the floor or on the stretcher. So get an idea, how much they lose, is it significant or not? If they're closed head injury and they're hypotensive, look for other things as well. Most of our patients with head trauma have multi-system trauma. So maybe it's chest, maybe it's pelvis, but definitely always have that suspicion if they already are hypotensive, where is that blood at? Is it somewhere else? And we know that one single episode of hypotension, one single episode of hypoxia can be detrimental to the head patient. That's one of the first two questions we usually want to know. Is there any history of either one of those? Because that definitely increases their chance for having some complications and increases their mortality. So the Glasgow Coma Scale is an old tool. It's been around for quite a while. It was originally developed for EMS to kind of triage those patients and get an idea about how severe this injury was. But it definitely has some benefits for us as well. We know if that patient comes in, their GCS is 14 or 15, they're early from their trauma, that's a pretty good indication of a good neurological outcome. And some of our clinical decision tools will look at this as well. But if they have a GCS less than 14, then this patient may have some type of moderate or mild brain injury. And the lower that number gets, the more severe that brain injury is. Now, to take into consideration that the GCS does have some limitations, I'm looking at their best eye movement, their best motor response, their best verbal. But obviously, if they're intubated, I just lost all their verbal. Or if they have some mid-face trauma, they have a lot of periorbital edema, I may lose the ability to assess that as well. So it does have some limitations, but we can definitely use it to trend and to quantify that. Hey, this patient that came in with a GCS initially of 15, and 2 hours later their GCS is still 15, that's a pretty good indication of probably not a significant neurological injury. But that GCS initially of 9 or 10, and it's still 9 or 10, or it's decreased even more, that really makes me concerned about something else that's going on. I need to look further and anticipate this patient may require a lot of interventions. The adage of GCS less than 8 we intubate is still pretty accurate. Again, take every patient into consideration. What's going on? Why is their GCS less than 8? Maybe it's because they have facial edema and I can't see their eyes. But probably if they've got a GCS less than 8, that's significant of a severe brain injury, and that patient likely cannot control their airway, cannot protect their airway, and we should look at controlling it earlier versus later. Skull fracture we run into frequently. Typically, luckily, most of these are usually linear. They're usually not depressed. They don't require anything else than observation. But definitely if those patients have a high-risk fracture, a depressed skull fracture, or a Bayesian skull fracture, then those are likely to need more intervention and have a higher risk for having underlying trauma, laceration of the dura, risk for infection, risk for hemorrhage. If I have a patient with a temporal bone fracture, those patients have a higher incidence of having an underlying injury to that middle meningeal artery, and that's almost a common site of an epidural bleed. So that soccer player, that player who complies with someone else, you get imaging, they've got a temporal bone fracture. That patient definitely has that higher incidence. And if they already have an epidural bleed, this is probably your number one site for that. So just have that index of suspicion for those patients. Definitely if it is open, if it is depressed, then that definitely is going to be a neurosurgical consult. Most will go ahead and recommend prophylactically treating them with antibiotics, especially if there's a significant laceration there for that risk of developing some type of infection of the meninges. Temporal bone fractures sometimes be kind of subtle. Definitely our CTs are much better than they were 20 years ago. We don't have to use plain films like we used to, but definitely if that patient has that, have that high index of suspicion, getting neurosurgery involved, definitely considering this person over somewhere else for observation if I don't have those resources there at my facility. And that classic Bayesian skull fracture, which looks like we don't see as much as we read about, but those classic findings that we'll run into, the battle sign, the raccoon eyes, looking for that drainage from the eyes or the ears or the nose, make us very concerned for problems that we'll see there. If they have that concern for Bayesian skull fracture, have risk for cranial nerve involvement. They may have some hearing deficit or may have some facial numbness or may have some of the other cranial nerves that are involved also. Most will go ahead and recommend prophylaxis for antimicrobial therapy. There's not really good evidence supporting that, but one of those things that's kind of kept going on for the years. But definitely we know that they do have a CSF leak. That patient is higher risk for meningitis. So probably go ahead and cover them with some higher generation cephalosporin or maybe even vancomycin if we're worried about community-acquired MRSA being risk, to go ahead and cover those for that. Luckily, most of these CSF leaks resolve in about a week, but luckily if they don't resolve, then those do have a higher risk for complications. If they've got that clear drainage from their nose or their ear, and I am worried about CSF, go ahead and check it for glucose. Have them get it on your glucometer strip, check it to see if there's glucose there. And if there's more than 30 milligrams per deciliter on that clear drainage, that is cerebral spinal fluid. If I got that nice blood-tinged fluid, then we can do the halo test or the ring test as you see here. And if I get that nice separation out and I have that little halo appearance outside that blood, that is cerebral spinal fluid. This patient likely does have that Bayesian skull fracture, so an increased risk for infection, increased incidence of seizures, and they need closer observation. And actually, if we're not really certain, we actually can send that fluid off. They'll do a beta transferrin, a test analysis, and that will truly confirm if this truly is cerebral spinal fluid or not. But just have that index of suspicion. If that patient's like, I just feel like I got postnasal drip, they're just constantly clearing their nose, like they're swallowing stuff, that probably is CSF and need further evaluation. The raccoon eyes, the battle signs, classic textbook things that we sometimes see Raccoon eyes are pretty common. We'll see those frequently from assault victims, from other types of trauma, and raccoon eyes usually show up pretty quickly. They're not always going to tell us they have a basilar skull fracture. It may just simply be from localized trauma, but they have a higher incidence. The battle sign, though, doesn't show up very quickly. So for most of us in the ED, we rarely see these. These are what we see, hospital day 2, hospital day 1, when they've been admitted for this. But where I have to be concerned here is that patient comes in, trauma, and I already have bruising behind their ears. What's the story? When did this trauma happen? That kid that just fell off the bed won't have bruising behind his ears that soon. This takes 12, 24 hours for the mastoid process to absorb that blood and for us to see that bruising. So just be kind of concerned that if your story doesn't match the presentation, we have to worry about things of non-accidental trauma, unfortunately. Battle signs, those take a little while. Raccoon eyes, usually within the first couple hours, we'll see those more frequently. Do I see that hemotympanum? It's really important for me to document the presence or the absence of that when I'm worried about these head injury patients. Get a good look in their ear. What do I see? Very common, we'll see blood coming out of the canal, but where's it coming from? Is it truly coming into the canal, or is it just blood from something else that's leaked in the canal? So clean that area out and then document, hey, hemotympanum was present or it was absent. And definitely if I'm seeing truly blood behind that membrane, that is an increased instance of having that basilar skull fracture also. So what was the mechanism? Was it blunt trauma, which is one we see the most? Penetrating trauma, definitely usually more obvious. But if they've got that GCS less than 8, think about this is a significant injury. This patient probably does need to have their airway controlled. That way we can maximize their oxygenation, give them good gas exchange, and hopefully prevent complications. Our goal there is to keep them normoxic. As was talked about earlier in the ACS lecture, we shouldn't be giving everyone oxygen just because they need it, because they don't always need it. We know that O2 is really good, but hyperoxia causes vasoconstriction, and that can worsen neurological outcomes. See that a lot with stroke patients, the same with ACS patients for the heart. Our other goal is also to regulate their CO2, and we want to keep maintaining normocarbia there. We used to years ago, we'd intubate them and we'd bag their CO2 down to nothing, trying to protect the brain. And really that's not very helpful. If we need to do a hyperventilation, we can do it, but it should be a controlled hyperventilation, probably keeping their end-tidal CO2 or their PCO2 somewhere between 30 and 35. Normal 35 to 45, let's keep it just a little bit low. That'll have some cerebral protection to it, but not be detrimental. If we need to secure their airway, rapid sequence is still our best tool. It definitely improves our first attempt success rate. For induction, probably most of us are going to either use etomidate or ketamine. Ketamine, for years we were told, don't use it with head injury, it increases ICP. That evidence has been disproven, and probably for most of us, ketamine is our first-line agent now for rapid sequence intubation. The nice thing about ketamine is it gives us analgesia and sedation, which none of our other agents do that. Etomidate is also a good option. The big thing about etomidate is that it's intended for one-time use. Etomidate may cause some adrenal suppression, so if I give it once, I shouldn't use it again for 24, 48 hours. But ketamine definitely is a good option. We know that using short-acting paralytics can also improve our first attempt success rate as well. We get our imaging, get neurosurgery involved as soon as possible. But think about the need for medical decompression. For years, mannitol was a great drug. We used it a lot. Good osmotic diuretic, would help pull out fluid, reduce ICP, but then it caused that significant diuresis. And especially for isolated head patients, that may be okay. But in multi-system trauma patients, that could be detrimental. So a lot of us have kind of gone away from mannitol and more toward hypertonic saline. And there's been several studies that compared both. Probably hypertonic is a little bit better and probably has a longer effect on reducing ICP compared to mannitol. And I don't have to worry about that diuresis and that hypovolemic risk. And there actually was one study that looked at doing either mannitol, hypertonic, or a combination of the both, and actually found that using a combination of both actually was better. But then it gets really difficult in trying to figure out how much of each one to give. But either are effective, but probably hypertonic is a little bit better, especially in those patients with multi-system trauma, so we don't cause that hypovolemia. We probably go ahead and treat them prophylactically for seizures. There's not really good evidence for that, and some places have gone away from that, but probably things like phentoin or phosphentone or levetiracetam are just as effective as anything else. One of the nice things about all three of those, they tend not to be sedating, so that tends to be our first goal, and usually that's for a 7-day course. And then what really makes it fun and challenging is when they're anticoagulated or when they're on antiplatelet agents. And we'll come back to that shortly. So epidural bleeds, one of our common bleeds that we run into. This usually is arterial in nature. Classic one is those two players that collide. They get that temporal bone injury. They get that injury of the middle meningeal. Since this is arterial in nature, it's usually a very rapid change in mental status. For years, we were talking about that classic concussive event that we would see, and this person would have that classic lucid interval where they would get knocked unconscious, they would wake up, they would be lucid, but then they would rapidly go out again. That's not always there. Sometimes they get knocked out and they're totally out for the whole period. But either one of those can be presentation. But just keep in mind, this is usually that very rapid change in mental status. And that's the ones I'm really concerned about. They have about a 50% mortality rate. Because if we don't recognize and intervene early, they're definitely going to cause significant shift and potential herniation syndrome. What we'll see on the CT, as you see here, is that classic biconcave look. Looks like you're kind of looking at the contact lens of an eye. And this definitely can cause rapid accumulation and rapid shift. Where our subdural is venous in nature almost always. It's one of those bridging veins that tears. So usually their presentation is a little bit more gradual, a little bit more subtle. This is your usually older patient, your alcoholic patient, but definitely could be any patient depending on the mechanism. But they have a head injury, a little headache, maybe a little dizziness. But as the day progresses, so does their complaint. The headache gets worse. Their mental status changes even more. Their dizziness gets worse. Definitely our older patients, our alcoholic patients, our malnourished patients, they're at higher risk because of brain atrophy. As we get older, our brain gets a little smaller. If we drink a lot, our brain gets a little smaller, and it tends to be more mobile. And during that head trauma, it tears one of those bridging veins. And with these patients, we'll sometimes see them in different phases, that acute phase versus that subacute or even chronic phase. And for patients that fall a lot, it's common to see kind of a mixture of all three of them, or sometimes two of them. And you get the report back, or you look at it like there's old blood, new blood. So patients that fall a lot, our Parkinson's patients, our alcoholics, those that fall a lot tend to have a higher incidence of having these. And on that CT, it has that crescent shaped. So why does our subdural versus our epidural look so differently? Where's the bleed at? On top of the dura gives us that very convex look because the dura attaches the skull. And it's attached at points here. And when that blood collects, it can't go anywhere else. And it gets confined to that space, and that usually causes that significant buildup of ICP. Where our subdurals underneath the dura, there's no connections there. And the blood just kind of goes across the surface and gives us more of that crescent look. And usually it's a slower onset of symptomology. But it can be pretty significant. It's common that patients may have both. But as a good rule of thumb, subdurals and epidurals are traumatic to proven otherwise. People don't just walk around and get a spontaneous subdural or a spontaneous epidural. Those are trauma to proven otherwise. They're usually not medical. And even that subdural, even though it's more gradual, even though it's slower, can definitely have a significant buildup and start causing that midline shift. And that definitely increases their risk for herniation. But these also have a higher mortality because they're more slow and more gradual. That person falls, has a head injury, and it's 12, 24 hours, sometimes 36, 48 hours before they seek medical care, and by then they've already had such significant shift, that's caused a herniation syndrome. So both can have that high mortality. We need to be suspicious for them and definitely consider getting these imaging, especially if our clinical decision tools kind of guide us in that direction. And then occasionally we'll see people that have those intracranial hemorrhages, and it's just intracerebral there somewhere in the brain parenchyma. These could be traumatic or medical. Here we're talking about the trauma ones. But definitely this here also can cause problems because it builds up and causes ICP. Just like all these others, it's going to decrease blood supply to certain areas. So we're at risk for ischemic injury as well. And our big concern anytime we're talking about this increased intracranial pressure is the risk for herniation syndrome. That is a very tight, closed box. Inside the skull, finite amount of space. We've got our brain tissue, we've got our blood, we've got our CSF. And if we change any one of those three, we're going to affect the others as well. And our two big ones we usually have to worry about are going to be our uncal herniations and our central herniations. So that classic uncal herniations, they herniate there on one side as you see, indicated by number 1. That's your classic patient who blows a pupil. You're evaluating and all of a sudden, pop, they blow a pupil. That's a classic uncal herniation. They may blow both pupils, and they've had now bilateral uncal herniations. Where your central herniation, that's right down the center, as you see there, illustrated by number 2, and that's your classic pinpoint pupils. Both pupils are very constricted, they become non-reactive. Our treatment for us is pretty much the same. We've got to reduce their ICP. Think about simple things like getting the head of the bed up is really important. Just getting the head of the bed up, keeping that neck in neutral inline position is really important for helping prevent but also treat intracranial pressure. If they're in a C collar, trying to keep them in neutral inline position. If they're immobilized and you can't get the head of the bed up, reverse from Dellenberg the bed. Just getting their head up a little bit improves CSF drainage, improves venous drainage down, so that we can hopefully prevent this syndrome from happening. But these patients are going to require medical decompression and likely going to require surgical intervention as well. So our concussion, and nowadays a lot of texts are going to refer to this as a mild TBI and not a concussion. And that's kind of the shift because it truly is a mild traumatic brain injury. And that kind of emphasizes to the patient, family, whomever, that this is not just getting their bell rung, as we used to say. It truly is a mild traumatic brain injury, and we know that recognition of this risk and hopefully prevention of these risks that we can see with a TBI are really important. So that classic concussive syndrome, the person comes in, they had a head injury, like my guy the other day, concussive, amnestic as can be. Every freaking 2 or 3 minutes he was asking the same questions over and over again. That's your classic concussive syndrome. But nausea and vomiting is also common. They may have some dizziness with it. They're going to have that amnestic property. They don't recall what happened, and they have those repetitive questioning. They have a normal CT scan of the head. An MRI might show some subtle changes, but the CT doesn't. This is a non-focal injury. It is getting their head wrong, but we know that it's more important than that because it is truly a mild TBI. Luckily, most people with a mild TBI, their symptoms fully resolve in about 24 to 48 hours. But what some people may develop is this post-concussive syndrome, and their symptoms may last for up to 3 weeks. So for the next 3 weeks, they have a headache, dizziness, nausea, vomiting, sometimes some vision changes, and that can be reproduced by other events as well. But luckily, after about 3 weeks, it goes away. But our big concern is this secondary impact syndrome. So we know that getting the head injury increases the risk for other problems. And that's when we really want to focus on education of these patients, their parents, if it involves sports, those that it's really important for them to get good rest. So until this person is symptom-free, they should not go back to contact sports. They need cognitive rest. Yeah, we want them to rest, but they need a cognitive rest as well. No video games, no computers. Let your brain rest. It needs to. That we know that people that have a traumatic brain injury, and if they have another traumatic brain injury before their symptoms are resolved, that's when we get this secondary impact syndrome. And what happens now is they develop cognitive defects. Their attention span drops. Their IQ actually gets less. And the more head injuries they have, the worse this gets. And we end up seeing is the development of traumatic encephalomalacia. And the only true way to diagnose it is by autopsy. But we definitely see that with some of our really professional sports activities. There are athletes that are high risk for this, and some of them have donated their body to science for studying this and find they have significant brain atrophy from these repetitive head injuries. And there's some pro sports people out there that aren't right anymore. It's because of this repetitive head injury. And so it's really important we get them to understand they need that rest. It is not just a concussion anymore. It is truly a mild TBI. And these patients need rest, they need cognitive rest, and they need to be cleared by someone else before they go back to contact sports, before they go back to activities that has the risk of getting another head injury. We have neurologists and neurosurgeons that focus just on this, ophthalmologists that are involved just in this. In my institution, we have a concussion clinic, and that's where we refer all them to for all this evaluation so that we hopefully reduce this risk of that secondary impact syndrome. Education is really important. And luckily now, most of our schools, sport agencies, they're really on board with this because it's made a lot of national news. But a concussion is a traumatic brain injury. Hopefully it's a mild one and one that we can limit those risks for complications down the road. So our clinical decision tools, I like to call them, there's several out there, and these can be really helpful in helping us determine who needs imaging and who doesn't. So this is the Canadian Head CT rules. Here are the inclusion criteria. So who wasn't included in the study? So if your patient fits one of these, I cannot use this clinical decision tool to make that decision whether I obtain a CT or not. And there are several studies that have demonstrated that Gestalt is as good as these clinical decision tools, but use these. I use this a lot to explain to patients why or why not we need something. But for this tool, they can't be less than 16. They can't meet any of these other criteria. But what these clinical decisions tools do is help us identify those who have the risk for a clinically significant injury. It may miss minor things. It may miss people that don't need neurosurgical intervention. Our goal here is to identify those who do. So the high-risk patients, those people that we should get CTs on, if their GCS is less than 2 hours after the injury, they're not back to baseline, we suspect they have an open or depressed skull fracture, if there's any obvious signs of a basal skull fracture, if they've vomited 2 or more times, or if they're over the age of 65. Those people need imaging, unless it's been minimal trauma. Those people, and this was 100% sensitive for identifying those that have a significant brain injury that needs intervention. We also have some medium criteria here. So amnesia, what was the mechanism? Use your Gestalt, use your clinical decision-making skills with your patient or your family, and discuss those. Hey, and most of the people, I'm not worried about getting a CT and risk for cancer in their 65 years already. It's the younger people I'm worried about. But using this clinically significant tool can help us determine, yes, I need to get imaging, or no, I don't. And then include that in medical decision-making. So there's just a nice little picture for you. If you don't use any of these clinical calculators like MD Calc, it's simple. There on your phone, or go to your favorite search engine and search for it, and it'll go step by step looking for different things to go, yes. And they kind of give you the risk. This person has a less than 0.9% risk of a significant brain injury. This person has a 5 or a 4. And you can use that in your decision making and that shared decision making with your patient. We also have the New Orleans criteria. So here are the inclusion criteria. So who we can use this tool to determine. And if this person has no headache, no vomiting, they're not 60 or older, no seizure, no intoxication, no retrograde amnesia, no trauma above the clavicles, that patient likely will not need a CT of the head. Again, we're looking for those clinically significant injuries. It might miss something, but it's probably something that will not need intervention. Go with your Gestalt. Discuss this with the patient. So I mentioned these earlier, but definitely we know that our anticoagulants can be very problematic in trauma. We deal with them a lot, and definitely with head trauma and our older patients, this definitely can be problematic. For years, all we had was warfarin. That was easy. I can reverse it pretty quickly. But now that we have a lot of our factor Xa inhibitors, we have our direct thrombin inhibitors, that's become more problematic. Warfarin works at multiple levels. It's going to affect all those vitamin K dependent processes, but I can fix this pretty easily. We can give vitamin K, we can give either a PCC or plasma. And looking at most of the studies, the prothrombin complex concentrates are superior to plasma when reversing a vitamin K antagonist. The nice thing is also a lot less volume. Instead of having given large volumes of fluid, I'm giving a smaller volume. So if you have it available, currently Kcentra is the only one that's FDA approved in the US. There's probably a benefit of using Kcentra over plasma for reversing warfarin. They still need to get the vitamin K. If they have a history of HIT, then you can't give them PCC because it actually contains some heparin. I actually learned that not too long ago with a patient we had that had a history. Didn't know that one. But warfarin's pretty easy. But at our newer ones, those are one more problematic. Now we do luckily have reversal agents for all of those new agents except for edoxaban. If you have them available, they do work, but they're fairly expensive. And they're indicated in patients who have life-threatening hemorrhage associated with the use of that anticoagulant. And probably in our trauma patients, that's one we have to consider. There may be a benefit of giving them something else, like a PCC or plasma, but may not benefit. Use your resources, talk to your pharmacist, talk to your trauma surgeons, and see what's going to be the best for this patient. Minor trauma, minor bleeding may be great for observation, but definitely they're having significant hemorrhage, they're on one of these agents, consider your resources, and do I have access to these to reverse those people. Antiplatelet agents, a little different. There's a mixed evidence out there of actually giving them platelets works or not. And probably most nowadays probably say there's not a benefit unless this person already needs to go to surgery because they're already going to have a low platelet function. But we know that people on anticoagulants and antiplatelets are at risk for bleeding at the trauma, but also risk for subsequent bleeding hours after the trauma. And those are people I might consider observing for longer, or repeating CTs in 12 or 24 hours, looking at the evidence. But definitely they're actively hemorrhaging, it's major, consider your reversal. People on warfarin, it's easy. I can get a PT-INR pretty quickly. Patients that are on other drugs, I might be able to get something from that PT-INR. If I have the ability to do thromboelastometry, I might get a benefit from that as well. One of the nice things about thromboelastometry, Rotem, Roteg are the two big brand ones. It takes all these medications and looks at it and tells us what we need to do with it. And those can be really helpful in some of these trauma patients in determining what I need to give to reverse these. So here's a guideline that was, or actually a summary of some guidelines that was put out a couple years ago by one of my colleagues at Vandy. And this kind of gives you a good summary of what to do with these different agents. And then lastly, our kids. What about our kids? And there's been several clinical decision tools out there. Probably PCARN is the one that's been most studied and most validated. It included over 42,000 kids in that study across multiple institutions. But definitely there should be some shared decision making with the patient, if they're old enough, if the family, discussing that, hey, imaging is great. Luckily our CTs are much better than they were 15, 20 years ago, but I have to worry about the risk this patient may need to require sedation to get a good image. And we know that ionizing radiation was not without risk, and that some young kids will develop cancer from that imaging than we did when they were younger. My older patients, I'm not concerned, but definitely my younger kids, let's look at the risk and benefits. Let's have that shared decision making. If this kid looks okay, maybe observation is the way to go without doing the imaging, especially if this is going to require sedation to get a good image. These tools are out there. They're not as good, but they're better than what we had, which was nothing. And probably PCARN is the one we're going to look at the most. So PCARN, as I mentioned, 42,000 kids were involved in this study. They were only looking at trauma, so that's what we're going to look at here. Their exclusion criteria I've got listed for you here, but those who we cannot use this tool for. If it's not trauma, if they're over the age of 18, if they have penetrating trauma, or they've already been evaluated somewhere else and already had a CT of their head for this trauma, then we can't use these tools. And they break it down based on age. So is this kid less than 2 or is this kid over than 2? And looking at these guidelines, if this kid is under the age of 2 and they're altered, they have a palpable skull fracture, LOC more than 5 seconds, they're not acting right, a non-frontal scalp hematoma, that person probably would benefit from getting an imaging. The top 2 are the most important. If they have either one of those top 2, altered mental status or palpable skull fracture, their risk is about 4 to 5%. If it's one of the others, it's lower, less than 1%, and that might be the patient that I might think more about observation versus imaging if I have a low suspicion. But based on these guidelines, these are pretty good to give us guidance of, yes, this kid needs a CT versus this kid doesn't. And then those are 2 age and older. Again, altered mental status, basal skull fracture, again, those are the 2 most important ones. If they have either one of those, somewhere around 4 to 5% risk of having some intracranial injury. The other one's much lower, but things we should still consider. And if they meet one of these, or they need more than one of these, this is the patient I definitely need to lean towards getting advanced imaging versus observation. But have that discussion with the parents. The kid fell off the couch, they fell off the end table, they're acting normally, they have a little bump here on their forehead and nothing else. That kid probably doesn't need anything but observation. Share the information with them, give them the statistics, give them the percentages. But these can definitely guide us in determining who has the risk for a significantly brain injury that requires intervention. Again, just like adults, these might miss some things, but they're considered to be minor. We're looking for those clinically significant injuries that would benefit from neurosurgical evaluation. Use your clinical judgment, compare it back to what these guidelines tell, have that shared decision making. If parents are really concerned, then let's do what's best for the patient. But share that, document that in your medical decision making. And if all else fails, clinical observation is totally appropriate. Just like for older adults, those on anticoagulants. Hey, let's observe them there in the ER for a couple hours. If we need to, then hopefully an inpatient admission for observation. But these clinical decision tools may be helpful. There's the image there for your PCAR, and again, these are available in a lot of your apps that you can use. MedCalc is just one of those, but use those to kind of help guide your care, but go through your Gestalt as well. If your gut says do it, that's probably a good indication because our gut tends to be right most of the time. All right, thank you very much.
Go ahead.
Is it ready? Okay, I just have a quick announcement about a schedule change. Sorry to do that to you. So at 1:30 today, when we return after lunch, we are going to talk about dermatology and rashes and anaphylaxis, and Randy Danielson's going to be speaking then. And then at 2 o'clock, we're still going to have our sinus, nose, and tooth ailment with Michael Gooch, but at 2:30, we're going to have our cervical spine disorder talk. So we're just kind of flopping those around so that we can move our odds and ends talk till tomorrow. And doesn't change any timing of anything. Still come back at 1:30. We're just letting you know there's a little bit of a schedule change. And Rick is now going to talk to you about pediatric infections.
Pediatric infections, yes. Thank you. Pediatric infections, boy, does that consume a lot of your time. Febrile kids come in, whether you are in an urgent care center or the emergency department, the approach is pretty much the same. We're looking for bacterial infections that we can fix. One of the things that is an issue is here, what is a fever? A fever is officially defined as 100.4 rectal. That's the official definition. Now, one of the issues with temperature is about this anxiety about parents taking temperatures. Well, I think that that's probably long gone because nobody's sticking anything up anybody's butt anymore because they have all kinds of these electronic devices. And I think over the pandemic season, the electronic devices for measuring temperature has probably become state of the art. So I don't know that moms stick up anything, thermometers up the kids' butts anymore. So this anxiety may have gone away. But the thing that we're really looking for is to determine whether the temperature is elevated or not, because it determines the pathway we get down. As soon as the temperature is elevated, we're going down the infection pathway. If the temperature is not elevated, there still may be an infection, but it's certainly less apparent, less obvious, and certainly less in terms of making the child sick. I think that the issue about which thermometers work, which ones don't, in the emergency department in your clinics, you're using electronic thermometers, which seem to have been verified in terms of the quality of the temperature that they measure, because it's so important that we determine the temperature. And frankly, it doesn't matter how high it is, whether it's 105 or 103, that's not going to change a lot about what we do, but we know that fever versus no fever is really the critical decision point here. Mom brings in a kid, and it's maybe like a 4 or 5 month old, and she says the kid felt warm at home, or I took the temperature at home and it was elevated, and bring the kid into the hospital, and there is no fever. Literature says on this, give the parents the benefit of the doubt. Assume that they were correct. Assume that this is what should be done, and especially if anything was given at home, Tylenol, ibuprofen to treat the fever, then you really have a muddled situation. So don't worry about it. Just go say, literature says we're going to assume that this was a fever, whether mother was really got the right temperature or not, we're going to go from that point of view. And I think that's obviously the safest thing to do. One of the things that comes up here is this idea of fever phobia, and we as clinicians are not supposed to give the message to parents that fever is dangerous, fever has to be aggressively treated, and one of the ways we give that message that fever has to be aggressively treated is by this alternating ibuprofen and acetaminophen. That makes it appear to the parents that, well, this must be pretty serious, because now look, we're giving 2 medicines that I got to make sure which one is given here, so I don't give too much. I don't get confused or something like that. So that sends the message that fever is something kind of dangerous. And the American Academy of Pediatrics says, please don't do that. It is no more successful alternating these agents than just giving the proper dose of one agent. 10 milligrams per kilogram of ibuprofen, 15 milligrams per kilogram of acetaminophen. Do it, and that's it. You know, one of the concerns about these fevers is that somebody's going to develop a febrile convulsion, and I think that there are kids who are prone to febrile convulsions. There's no question that I mentioned before that they tend to run in families, and it's one of the reasons not to marry your cousin. However, that being the case, we don't have to get too really upset about this. You know, in the emergency department setting, if a kid came in with 105 fever, it would be like, oh my goodness. And the kid would be rushed back, and it would be, you know, cool towels would be, damp towels would be placed all over the kid. The kid's crying, and the mom's crying, and we making it look like this kid's about to have something bad happen, when in fact, that aggressiveness is not really required at all. Just give the kid a nice slug of antipyretics, and the temperature is almost assuredly likely to come down. And the reason we want to get the temperature down is not so much to prevent the development of a febrile seizure. Why? Because febrile seizures tend to occur from normal temperature to high temperature. It's the slope, it's the change, it's the rapid change of temperature that develops that is considered to be the cause. Once you reach a steady state, that is considered to be, you're now in a safer period. So, and the likelihood of you catching this from zero, normal temperature to high temperature, your kid's going to be at 103 before you know it, and they've already passed the risk area. So there's this issue, Mom, you don't really need to worry about it. Even if they had it, it's a benign condition. Will it lead to epilepsy? Very, very rarely. We're talking about 2% at most. So don't worry so much about that. Don't overreact to it. The primary purpose of this giving of medication for fever is to make the child more comfortable. It's not about, well, if I bring the fever down, in some way the illness will be modified or the outcome will be modified. Here's a clip from the American Academy of Pediatric newspaper where they talked about fever phobia and trying to influence the pediatricians to back off on this idea that this is something that parents ought to really get nervous about. Sure, the vast majority of these fevers are going to be viral, and absolutely, and if the temperature is 105, it's still the vast majority of those are going to be viral. Does the increased risk of bacterial infections go up a little bit at 105 versus 103? Yes, it does. Yes, it does. But still, the majority, by far, are viral. And parents basically need to know that, because then the next step is, Mom, these are viral infections. You've heard of viruses. Antibiotics won't help these. And so, we're not going to do that, because I'm quite confident that your child is having a viral infection. And the law of averages say, these are viral infections. What's the likelihood of finding a bacterial infection that you can treat in the majority of these kids? The answer is most of them are not going to have evidence of a bacterial infection at all. I mentioned before the business about fluid intake. So when these kids are febrile, there's a bit of a hypermetabolic state. The idea is they're burning off some fluids, and maybe they're not eating as much. Maybe they have a sore throat. Maybe it hurts to swallow, or whatever it is. You got to encourage Mom to give baby little Johnny here enough to drink, because I mentioned a 1-year-old generally weighs about 22 pounds, 10 kilograms. A 10-kilogram kid, average amount of fluid it needs in a day is 100 mLs per kilo. So 100 mLs per kilo times 10 is 1 liter. Much more than I think most of us would intuit is what is the necessary amount of fluid that this kid takes in one day. It's 1 liter per day. So don't get behind on the fluids. This idea that brain injury is caused by fever, you got to dispel that too. You got to, one of the ways to dispel that is to say, well, this fever is coming. This is nature's way of trying to fight this infection, and the idea of suppressing fevers may not be a good thing to do. People have talked about that because it's been shown that higher temperatures do something with regard to iron in metabolism, and viruses and bacteria help fight these infections. That's a part of the intrinsic process of dealing with these infections, and that this is not necessarily a bad thing. We're just reducing the temperature to make the child feel better. One of the issues in kids who may be a little dehydrated, you got to remember the vast majority of kids that you see who have any degree of dehydration will be mild to moderate. A mild dehydration is 50 mLs per kilo. 50 mLs per kilo is mild dehydration. Moderate dehydration is 100 mLs per kilo. Severe dehydration is in the neighborhood of 150. So basically, if you assume that every kid that you see who's been sick for a while and is behind on their fluids need 50 mLs per kilo, figure 50 mLs per kilo, and how much time can you give that over? You can give it over about 4 hours. It doesn't have to be drawn out more than that. One of the problems that we do is there's a low threshold in this country, and AAPA has warned us over and over, please don't start IVs in these kids who have mild to moderate dehydration. The treatment of kids who have mild to moderate dehydration is the SIPI diet, where you give them some Pedialyte or Infilite or something like that, and they're getting a couple of, mom gives a couple of teaspoons of this, and then waits a couple of minutes, and that's assuming there's any vomiting, so that it kind of goes in, it gets through the stomach, gets into the small bowel, and away it goes and gets absorbed. So the SIPI diet is what it's about. If the kid's not vomiting, oral fluids are absolutely fine, and by far the safest way to give fluids is to give them orally. So don't start an IV in kids who are mild to moderate dehydration. That means, and we're talking about, you're going to rarely see a severely dehydrated kid in the United States. They still, it still occurs, but rarely. So the vast majority of kids, oral fluids. If they're vomiting, a Dansetron, SIPI diet. If they're not vomiting, let's give Johnny something to drink. Good idea. The starting of an IV basically causes pain, increases charges. Mom's crying, everybody's crying because this IV is being started, and God forbid you don't get it on the first shot, then you try another time, and you're doing something that doesn't need to be done. And on top of that, and I don't know, how many of your ERs are doing this, is, well, once we got the IV in and the kid's got 103, why don't we give him some IV acetaminophen? And it's like compounding one problem with another, because you shouldn't be doing that either, because IV acetaminophen is expensive. It costs the hospital $35 a gram, and by the time the hospital is done with its charges mechanism, who knows, it's going to be $100. And there's oral and IV have been compared, and they, for all practical purposes, for all clinical purposes, there's virtually no difference between oral and IV in the temperature change and how rapidly the temperature will change. So there's no reason for any kind of commando reduction of fever by giving IV acetaminophen. So if your hospital does, that's two sins committed. IV started, IV acetaminophen. That's sin number 2. Oral acetaminophen is what this is about, or ibuprofen. I wanted to, I don't want to spend really any time on this, but I want to read the last sentence. This was a study sponsored by IV acetaminophen people, and they concluded a single dose of IV acetaminophen is as safe and effective in reducing endotoxin-induced fever as PO acetaminophen. That is that is the conclusion of a sponsored study. You could take the whole thing around and say, oral acetaminophen is as safe as and effective as IV acetaminophen. It's like, come on. And here's, just for fun, here's the graphs that they show. And so as the temperature goes up, you want to get the lower line. It's a top graph. The lower line is IV acetaminophen. The top line is PO acetaminophen. You say, oh my goodness, look at the difference in the two of these. The difference is 0.3 degrees centigrade, 0.3 degrees. And this is a great example where you take an axis. The left axis is drawn out so that that huge axis, the change is like 0.1 degree per little line there. So this is, oh my goodness, it's 0.3 degrees. The difference between the top line and the bottom line. 0.3 degrees is no clinical significance whatsoever. This is another one with acetaminophen. This is an IV versus PO. And yes, it was a little bit faster. And yes, it was a little bit more effective. But the difference, the absolute difference, is, again, less than a degree, substantially less than a degree. Immunizations, basically, these immunologists have saved more children than any pediatrician and any doctor, any PA, any nurse practitioner, by far, by the development of these. And I started emergency medicine way before there was a immunization for H influenza and way before strep pneumonia immunizations were out there. So I'm from the generation that saw all of these kids who had bacterial illnesses, who had epiglottitis. There's no epiglottitis now. We had children with epiglottitis. We had children with streptococcal bacteremia, which may have gone to the brain or to a joint or something like that. So our approach was entirely different. We're dealing with kids now who are largely well. And the incidence of bacterial infections in these kids that are occult are really quite small. Look at this, 4,000 cases of bacterial meningitis in the United States, 4,000 cases. There's about 5,400 emergency departments in this country. And if you took on average, that's less than a case a year of meningitis. And this is not just in kids. They're talking about the average age of meningitis now is 42 because all these kids get immunized. This is a little misleading because if the only people who got meningitis were 2 years old and 84 years old, 2 years old and an 84-year-old, well, the average age of meningitis is 42. Well, the fact is nobody at 42 gets meningitis. It's this people and this people. So this is a great example of how numbers can basically be used to fool you. But 4,000 cases a year, meningococcal meningitis, we used to see that stuff. That's the kind of meningitis where you get DIC and people lose limbs because of the clogging of all of their capillaries with these blood clots. Now we're talking about 375 cases a year, and you can't go to college without getting a meningococcal vaccination. It's rare. And this is a great graph showing the importance of pneumococcal vaccinations and the incidence of disease. I began on the far left. Look where there's barely any blue on the right of the thing now. 13-valent pneumococcal vaccine. At first there was like 7-valent, then they have 13-valent. There's at least 20-some valents of this. So it's not like every disease caused by pneumococcus has gone away, but the more virulent strains are these, 13 they're covering. Yes, there are a bunch more, but they're not considered as virulent. However, there is some evidence that some of these strains are becoming more virulent over time, but the majority, we're in good shape. So our job now is to find the source of an occult fever in a child who does not have any obvious source. There's no cellulitis, there's no pharyngitis, there's no otitis doesn't cause a fever. So we can't find it. So where's it likely going to be? Bet your money on the kidneys, and the urine. By far the most common site of a bacterial-caused fever in a kid is going to be a urine infection. And then maybe down the road is going to be a pulmonary infection. I want to go over just briefly the recommendations of the American Academy of Pediatrics regarding, we're going to skip that. I can't even read it, but it's something for you to, I think it's probably blown up in your book so you can read it and see it in large. Here's the issue. This is the issue, getting that urine from a child. There's a really nice algorithm about how to do this. First of all, do you know, when you think of a bladder, a UTI, when I think of a UTI, I think of a bladder infection, UTI bladder infection. Bladder infections don't cause fevers. So what urine infection causes a fever? Pyelonephritis. Nobody calls these infections pyelonephritis. If you read the journals, the articles, and all this stuff, they call it UTI, UTI, UTI. And I think by doing that, it kind of undervalues the significance of this. This is not UTI. This is a pyelonephritis. Pyelonephritis causes fevers and urine infections, not bladder infections. So call it pyelo. And once you call it pyelo, you get a sense that this is actually pretty significant, this kid has. This is the journal article that talks about what the American Academy of Pediatrics thinks about urine. It was published 2011, which is a long time ago. However, recently the conclusions of this paper have been reaffirmed by the American Academy of Pediatrics. So although the original numbers are 2011, it has been reaffirmed much more recently. Here are some of the key points. So they basically say that about 5% of kids who have source unknown fevers will have urinary tract infections. 5%. I think, honestly, I think that's a little high because they don't really address very well the idea of asymptomatic bacteriuria, which is kids, adults, anybody who has bacteria but in their urine, but they're not having an infection with it. So what if we had a 2% asymptomatic bacteriuria rate? Then the true incidence of infection would be 3%, which is 1 in 33 kids now. So I think that this number is higher than it probably really is. Obviously, if a kid's ill-appearing, they get cultured of the urine, the blood. We give the ceftriaxone and admit them to the hospital. And those cultures have to be done first, then you give the ceftriaxone. So the sick kids are easy. And if they need some fluids, they get some fluids, 20 ml per kilo every 15, 20 minutes. So they perk up, that kind of thing. Don't ever think of culturing a bagged urine. That 88% contamination rate. So the idea now is, how do we get urine out of a little kid? Now, some of these places, particularly if you work in a pediatric hospital, they're casting kids right and left to get urine. I think that fundamentally is a mistake, and there's a very clear option on how not to have to do that. So number one, how do we get urine out of a little kid? We're talking about, maybe a 3, 4, 5, 6 month old kid, basically. How do you get that kid to urinate? Because, well, first of all, you grab the kid under the arms like a chicken. I call this the chicken technique. So you grab the kid under the arms, normally under the wings, hold the kid up like that. Then there's the next part is we get a small, gentle, circular rubbing over the lumbar area. And then in the southern hemisphere, it goes the other direction. Then we have somebody tapping over the bladder at a rate of 100 per minute. So we get the metronome, so we get the right tapping rate, 100 per minute. And the fourth person is the catcher. You got the cup, and these kids, 69 of 80 peed within 5 minutes of doing this. 69 of 80 peed within 5 minutes. So you shut down the department because this takes 4 people. You got the chicken holder, you got the chicken rubber, you got the chicken tapper, and the urine catcher. So, but that's how you do this. There's at least 2 papers that discuss this technique of getting urine. And the younger the kid was, the more likely they were likely to pee this. The older ones, it worked less well. Merck Academy of Pediatrics has said, let's look at risk factors. Girls versus boys, age, fever, duration of fever. You're not going to remember all of this. So there's something much better now in terms of ability to risk calculate. And it's called UTI Calc. UTI Calc is developed by the University of Pittsburgh. They had a bunch of kids that they tried it on, a bunch of kids that they validated on. It is much better than the American Academy of Pediatrics value, and you don't have to remember anything except by UTI Calc. So it decreased testing by 8% and decreased cases missed as well. So now that we have something to give us a risk assessment, if a kid's low risk and is otherwise well-looking, the kid can go home with follow-up. You don't need to get any urine in a low-risk kid, none, zero. If the kid is not low risk, that's not the same as saying high risk. If the kid's not low risk, you have two choices. One choice is to cath that kid, do a urine culture and sensitivity, out it goes. That is not a reasonable choice. The reasonable choice is the next choice, which is basically get a urine from that kid. And it doesn't matter how you get it, but don't cath them. You can take a diaper. Can you excuse me, please? I've got an important call here. No. Number two is the way to go here. Get urine out of that kid and test it. And it doesn't matter how you get it. In fact, studies have shown you could take the diaper and wring out the diaper into the cup. We don't care where it comes from. All you have to do is, when you do that, is stick in that dipstick. And if it's negative for leukocyte esterase and negative for nitrates, you're done. You're done. Now that's what you're going to do in a clinic or your office. Well, you can't send it over to the lab to get a stat UA for them to look at stuff. But if we were doing it in the ER, we would send it over to the lab. And we're also looking now, did they see any bacteria? No. Did they see any white cells? No. You're done. White cell differential is 5 or less is okay. More than 5 is suspicious. But that little dipstick, the nitrates, 95% sensitivity, 95% sensitivity for a urine infection. The nitrates is what you're really looking for. Yeah, sure, leukocyte esterase, if it's there, that's great too. One of the reasons that nitrates may not be positive is that the urine is very dilute. So ideally, we'd like the first urine in the morning, but that's not necessarily going to happen when they bring the kid in the afternoon. And the kid's been drinking a lot and may have diluted the urine so that the test is, but in the vast majority of cases, that's not an issue. So after you do that, and the test is negative when you dip it, then you're also done. If it's positive, you do a cath, culture that, and begin treatment of that kid, assuming that the kid has a urinary tract infection while you're waiting for the results of that thing. And what do you need to establish urinary tract infection? You need a colony count of 50,000, and you have to have an abnormal urine. If you don't have an abnormal urine, and you have a colony count of 50,000, you have asymptomatic bacteriuria. And there have been studies that are trying to find this. The most recent study of this said the incidence of asymptomatic bacteriuria is 0.8%. But I found other studies that said it was 2%. But I think, honestly, the most recent one was the most rigorous one, and it said 0.8%. What antibiotics are we going to give? Well, frankly, usually a urine infection, give the shot of ceftriaxone. The department has a 55-gallon drum of ceftriaxone with a lure lock thing on it where you just go over there and suck that out, give a shot here, give a shot there. But the fact of the matter is that you can treat these kids orally. The kidneys concentrate this antibiotic in the urine. So there's no difference between oral and parenteral therapy in non-toxic kids, the kids that you're going to send home. What drug to use? Well, if you're going to give a parenteral shot, it's ceftriaxone. If you're going to give something oral, basically the American Academy of Pediatrics suggests, if your anti-biogram that is not available, they suggest if you want to use something once a day, the choice is Cefixime, which is Suprax. But look at the price of this stuff. It's a couple $100. That's once a day. Next best is twice a day. Look what's the next best. Good old Bactrim is next best. Yeah, there are a number of others that are twice a day, but at the top of the list has got to be Bactrim. It basically costs nothing. We're all concerned about kidney infections that are missed, causing, renal. Everybody's going to be on dialysis. The fact of the matter is these guys looked at 10 studies of UTIs in kids, and all of their own data. This is a large center, and they had some cases where the data was incomplete. And when the data was incomplete, they assumed the kid had renal dysfunction as a result of urinary infection. So they tilted the results in favor of urine infections do cause renal dysfunction, and the fact of the matter is the numbers that they came up with, the incidence of renal dysfunction is going to be in the neighborhood of 0.2% or less, 0.2%. And the fact is that if a kid has a urine infection, the study that they may get thereafter is an ultrasound. They don't do any voiding anything until they do an ultrasound. And if the ultrasound shows that there's no regurgitation, the bladder's fine, the ureters are fine, the kidney's fine, then that's it. It's done. Last thing is pneumonia, for which we have 34 seconds. Clinical infectious disease is the journal article. I got to limit this now to the key points because I just am having too much fun up here. They are big into testing for flu and treating for flu. I think that when they revise this, that's not going to be the case. But the most important bullet here is that regarding testing, a chest X-ray is not necessary for confirmation of suspected community-acquired pneumonia in those treated as outpatients. Can you believe this? The Infectious Disease Society of America and the Pediatric Infectious Disease Group says you don't need to do a chest X-ray to diagnose pneumonia. Is this the most... Have you ever heard that before? You don't need a chest X-ray to diagnose. So you take fever, hair-for-urales, the child seems to be a little bit, O2 sat is like 90% or something like that. I'm making a clinical diagnosis of pneumonia. I think the child is good enough to go home, kind of thing. Say what? Nobody will say you can do that. So, but the Infectious Disease Society of America says you can diagnose pneumonia without a chest X-ray. So there's going to be a lot more pneumonia diagnosed now, I can assure you. The criteria for admission, they're pretty obvious. They don't like blood cultures in people who are non-toxic and fully immunized. They don't like that. They only like sputum gram stains and cultures in people who are admitted to the hospital, and even then, that's a weak recommendation. Urinary tract antigens for bacteria, they don't like that at all. That's a zero kind of thing. Other key points, yeah, they like the flu test. And even if it's more than 48 hours, they like the flu test. I think that is grossly out of whack with what we kind of know about flu and what benefits you're going to get from identifying it and, number one, treating it with any of these anti-flu meds. You pick up 16 or 17 hours, at least in adults. Mycoplasma, they say, if you think that's basically walking pneumonia. That's how we can get around that. That's kind of like a mild pneumonia kind of thing. Doesn't start, low grade temperature has been brewing for a week or two. You had a cold to begin with, and now it's persisting and, walking pneumonia. That's mycoplasma. Here's the difference between mycoplasma and the atypicals and the standard pneumonias. Standard pneumonias, acute onset. It hurts, fever, chills, white count, abnormal sputum, markers of inflammation. The opposite is true with except for Legionella, the opposite is true with mycoplasma and chlamydia. So here's the x-rays, that kind of lobar, that's the picture of a bacterial pneumonia. The fluffy kind of things that are nondescript, those are the viral pneumonias. They tend to be bilateral. Here's more bilaterals. all bilaterals. These are all viral pneumonias, or mycoplasma, the other ones. Treatment options, I'm going to stop here on treatment options because antibiotics are not routinely required for preschool kids because the majority of these pneumonias are viral. That's a pretty aggressive statement. So you have a preschool kid who you think has pneumonia. You even took an x-ray, and there it is up there. And they say, yeah, well, you don't necessarily need to give antibiotics in these kids because statistically they're viral. But if you want to give an antibiotic to a preschool kid, it's amoxicillin. That's it. Plain old, good old amoxicillin. Nothing more sophisticated than that. But they're giving it in high doses. The dose for amoxicillin for everything used to be 40 milligrams per kilogram. They doubled the dose of amoxicillin. For some reason, it's been doubled for the treatment of urinary tract infections. It's been doubled for the treatment of just about everything, from 40 to 90. And basically, what you get at 90 is more diarrhea than you got at 40. But that's the drug of choice. In kids who are in school, they say the drug of choice is a macrolide, or azithromycin, a macrolide. So that's it. That's all you have to remember. Those little kids that before school may need nothing, but if you want to give them something, give them amoxicillin. After school, up to adolescence, they get a macrolide. That's it. Here is the chart. It's really detailed, really good, of the Merck Academy of Pediatrics, and I put it in here. Unfortunately, I had to put it in pieces. So it's in 3 slides, and then at the very end, there's a slide that basically goes through the management of febrile kids. So I'm a little over, I'm sorry. What are we going to do now?
We're going to start our Q&A session.
Oh, Q&A, that's good. It would be hard to imagine that there are any questions left after these very lucid lectures.
If you're not staying for Q&A, come on back at 1:30.
Boy, we have quite a cadre of people here for
It's a party up in
Q&A.
here.
Are you in Texas? Okay.
How does the colorectal surgeon enter the room? From the rear. But of course.
But of course.
Sorry.
We need to kind of be close together for the camera. You can what?
Dismiss myself.
The new social distance.
Use me.
Oh boy.
Does it geometry? A little bit. Makes it a little more wholesome.
Homie?
Oh, there we go.
Okay.
Dave, can I hand you this?
All right, Martha.
Dave,
Let's go.
I'll lose it.
All right.
Okay.
Man, if we can't have the answers with these people here.
Uh-oh.
Boom.
I'm in trouble for that one.
And that's how you get people's attention.
Wake up. Okay,
Okay.
let's start with the first question. If you suspect central cause of vertigo, are you proceeding to CT if you have no MRI?
Yeah, I mean, ideally the best thing here is get the MRI, but if we don't always have that available or it's not an option, then definitely you start with CT and try to get neuro involved as soon as possible.
Okay. ENT once told me to only give meclizine if a patient couldn't walk. Should the threshold be that high?
That's pretty high. I mean, the biggest thing, and I'd put this in there already, that, you know, meclizine, along with most of these others, are anticholinergic and antihistamines. So they're on the Beers list. And, you know, think about how many people we see that are elderly and dizzy, which is a lot of them. So you've got to be really careful with that because of the risk for sedation, falls, further injuries as well. But, I mean, I've never heard that or never been told don't do it unless they can't walk. But just think about your risk and benefits of any of these medicines, whether it's a benzo or antihistamine. They're going to cause some side effects.
That just seems cruel.
I know.
I mean, what are they recommending?
Say you can't walk.
I'm pretty sure benzos are on the Beers list too.
Yes,
So
they are.
I don't. That just sounds like it came from someone who's never experienced vertigo.
There you go.
Yeah, I want to
also point out that we tend to jump to meclizine kind of pretty quickly in emergency medicine for no good reason whatsoever other than really great marketing. Antivert is a hell of a name for vertigo medicine. But the only really good literature I've ever seen on this was like I want to say it was 1983. It was a study they did at NASA, and it's the best kind of study, right? So they strapped a bunch of people into those triple rotating axis crazy ball things that I actually did at Space Camp when I was 13, no big deal. But then they gave them all sorts of different medications and said, like, what works? And the most effective medication was straight amphetamines, right? And we can't do that, unfortunately, most of the time. But when you look at this study, I would encourage everybody to take a look at this study, Antivert meclizine was not very high on that list in terms of success. In fact, 25 milligrams of meclizine outperformed 50 milligrams of meclizine. And then now you have to start asking yourself about dose-dependent effects and all sorts of things. But when you dive into this, there are other medications which are available to us in the emergency department which are probably more effective than meclizine with less adverse events than meclizine that we can use in the emergency department.
Or focusing on the exercises like you had mentioned before. The exercises are free and they're fantastic. The Epleys and the barbecue rolls and all that.
The barbecue rolls?
You know
I don't know that one. I
it's
know
like-
the Epley, but
It's a sushi roll, but it's also a maneuver.
Sounds very appealing. I'm a
It's
fan
good.
of the Epley maneuver, but I tell patients this is not going to work probably on the first try. The second try, you got to keep doing it and coach them through doing it at home. Okay, what's a barbecue roll?
The barbecue, so if the stone is in a different canal, that doesn't, yeah. And if it's in a different canal, there's a different maneuver that you can have them do. You can print out flyers for them.
Yeah, I would say that if people want to jump in more on this, because there's difference between anterior versus medial canal,
Right.
otolith. I think the best voice on this in emergency medicine right now is a guy named Peter Johnston. And you can just Google him, emergency medicine, and some fantastic videos on otolithic control and the differentiation of the three different types of BPPV.
Oh, I don't have it high enough. Oh.
Okay.
All right.
This is for Pesky. For Rick Pescator's lecture, can you please touch more on inflammatory neuropeptides for post-concussion headache?
Great. Yeah, a little bit. So what we're learning more now is that inflammatory neuropeptides have this unifying and universal underlying pathophysiology for brain injury and brain disease. And it gets a little more into what we're treating and what we're going after. But there are astrocyte proteins. The names are escaping me right now. I think it's like GLFP1, a gliofibrillary protein, that are actually detectable in serum following brain injury, following concussion. And it's a lot to talk about whether that's clinically relevant at all, but it's certainly scientifically relevant in the sense that it informs our understanding of the underlying pathophysiology of disease. All of these brain diseases, whether we're talking about migraine, whether we're talking about traumatic brain injury, whether we're talking about things like arachnoiditis, seem to have a unifying inflammatory neuropeptide pathophysiology.
Okay, when you use clean, dirty to describe causes of TM rupture, are you using that as a synonym for internal, external pressure on the TM? You referred to acute otitis media ruptures as clean.
Yeah, the big concern is, did something actually penetrate the tympanic membrane or not? So if it was the stick or it was the dirty water from the lake, sure, that's dirty. But yeah, if it's spontaneous, if it's the lightning strike, those usually don't have any risk for contamination because there's nothing actually penetrating the membrane itself. It's just a change in pressure.
And then also, can you remind our audience what solution is safe for TM rupture?
So if we're worried about TM rupture, we really want to use something that's a suspension. The suspension pH is more closer to normal. The big thing is no acetic acid, and we want to try to use suspensions.
Yeah, the way I was taught it was the solution is never the solution for the treatment of tympanic membrane ruptures. That was a nursery rhyme that I had when I was little. But I would mention that the American Academy of Family Practitioners in 2013 actually pushed us all off of the use of the corticosporin derivatives, which I think a lot of us used all these things for a long time, but now everybody seems to be on the ciprofloxacin dexamethasone train.
And for years we were talking about quinolones and gentamicin all being ototoxic, but actually from the suspension the risk is pretty low and they're safe.
Are there any diagnostic exams to diagnose Meniere's, or is it a clinical diagnosis?
And most will consider it clinical. You actually could do some audiometry testing and actually check to see if there's certain hertz that they're not able to hear, but for the most part, it's your classic triad of the vertigo, the hearing change, and the tinnitus.
any treatment for the remedy of tinnitus?
I think actually Sharma had posted as well. There's a couple of little devices that people can wear, very similar like a hearing aid that will kind of may help with those. For the most part, it's treating the cause. Is it a truly chalothiasis? Is it an aspirin toxicity I mentioned? Look for those differentials. Some people benefit from diuretics, and they'll sometimes put them on diuretics for those as well.
Is it an acoustic neuroma?
Unilateral, yes. In fact, one of our speakers here in this conference developed tinnitus or tinnitus, it depends, either one, and had an acoustic neuroma diagnosed, had 10-hour surgery.
10-hour surgery.
10-hour surgery.
Wow.
Yeah, he said he went in and then he said, yeah, it's going to be like 2 hours, right? Doctor just laughed. It was a 10-hour surgery.
But I think that really gets to an important point of understanding the underlying cause of the symptom, and a good physical exam here is important. What do we see as one of the more common causes of, I always thought it was tinnitus, I do have to agree, I don't know, but what do we see as one of the more common causes? We see this glue ear, this chronic non-suppurative otitis media, which is so incredibly common, and so there's some data that it affects like 20% of the population. And these are people that complain all the time, like, oh yeah, I got this ear infection or whatever weeks ago, and I have chronic ear pain or chronic, I feel like somebody's muffling my ear, and tinnitus is a very common complaint associated with it, and you can see it on physical exam. It's a cloudy TM, and sometimes you can even see the bubbles of the mucoid and serous otitis media with effusion. There is my favorite thing that's ever been invented called the Otovent ear balloon. You can Google it. You can buy it off Amazon. It's a nasal insufflation balloon that stents open the canal and has really good evidence for fast resolution of patients with this chronic non-suppurative otitis media, and it will resolve a lot of tinnitus in a lot of patients. And it's like $20 and it's worth a shot. There's no downside.
Cool. All right, can you
That
give
is
us your,
pretty cool.
your mnemonic?
I can. I think this is the one for the limps. Yeah. This is the limps mnemonic. I can go through it again. It's leg calf perthes is the L. I is inflammation or infection. The M is malignancy, Ewing sarcoma, osteosarcomas. The P is pain from trauma, like a toddler's fracture, those types of things. S is skiffy, and then you could also throw in from somewhere else, systemic type stuff, but that's it.
Okay, and I posted a video in there for Captain Morgan. It was an Al Sacchetti video. And later this afternoon, you're going to be treated with several procedural videos for our last talk today, so you don't want to miss that. I have a ton of really gory, fun, and also interesting videos to play for you guys. And we'll just do a couple more because it is almost 12:30. How many hours after last use of a PDE5 can you choose to give nitro to a patient? I did have to look this up for
I don't know off the top of
each
my head. What'd you
individual
find?
drug.
Yes, it varies.
So it varies, and some of these drugs can be out of your system within a couple of hours. The other ones may take about 12 hours, and then the big one that I noted was Cialis took a full 48 hours. So I listed those there in Slido for you.
I think most will say 24 hours is probably safe unless
Yes.
it's Cialis, because it's the weekend pill.
Right, good call.
Has anybody ever seen an interaction between a PDE5 inhibitor and nitroglycerin? Nobody has, right? And the reason is because this is all based on a case series from like 15 years ago of 3 patients. It's not a common interaction at all, and it's way overblown in emergency medicine, and it's a pet peeve of mine.
Speaking of pet peeves, Jess, I noticed you already answered this question about right-sided posterior EKGs. You like doing those, so why not, right?
I don't do it like every day, but I think that you should have a low threshold for it. And as I wrote, it's a test that's no radiation, it's very cheap, it's very easy to do, and you can get it immediately. So that first example ECG that I showed of the posterior MI, that was so subtle. I mean, you really have to be looking carefully, and then the patient in front of you giving the good story, you have to be looking carefully to be worried about that ECG. It's so subtle. So really putting on those posterior leads was a game changer in that case. So when in doubt, just go ahead and do it. It's cheap, easy, it's just so fast, why not?
And if you're worried about it, just take, especially for the right side, just move V4 over and have V4R, and if I see elevation, it's pretty certain. Doesn't rule it out, but if you see it, it's there.
I also, Jess had put in her lecture the contraindications for lytics for acute MI, so you can take a look at those. They're in your book. And the sequence of evolving MI, When might you see the troponins start to increase?
Yeah, and you wrote in the answer there. So it can take a couple of hours before you see the rise in troponin. And so that's why we're always careful about when we're assessing the onset of the pain. When did the pain start? Because if the patient says, it just started and I came straight in, well, certainly we should not feel comfortable discharging that patient with one normal ECG and one normal troponin, right? That's someone who needs a serial evaluation. If they say, oh, it's been going on already for 5 hours, well, they're sort of in that time window where they should have a troponin elevation by that time. And so the timing is really important in understanding when it rises.
Very, very good information there. Okay. Lastly, we actually just talked about this, Sharma and I on the podcast for subarachnoid hemorrhage on our last episode, but I've heard this question a lot asked, and it's please describe a thunderclap headache. Describe it.
So strictly speaking, I think there are two definitions of thunderclap headache that we can go to. There's the clinical definition, sudden onset, reaching maximum intensity, associated with nausea, vomiting. It's the worst headache of my life. But the one we actually have to apply in the clinical sphere is the one that's been studied in the research sphere, and that's most closely associated with all the tools we're going to use, right? Because if we're going to apply our pretest and post-test probability based on something like a likelihood ratio of a thunderclap headache, that's what matters. All that to say, those studies describe a thunderclap headache as a headache reaching maximal intensity within 1 hour of onset.
Excellent. Okay, it's 12:30. Got an hour for lunch. Come back and meet us. We'll see you then.
Dermatology. This is also something, and this is bread and butter, emergency medicine, bread and butter, urgent care, family medicine as well. My colleague who's going to present this is Randy Daniels, and Randy has been with this program since the day one, which was probably, I think, eight years ago. And at that time, Randy was the dean of 11 professional schools at the A.T. Still University in Phoenix. So he was in charge of the PA program, the respiratory therapy program, every program that you could think of, 11 of them. They also had it there, a dental school and a medical school. And so that was Randy's experience for a long, long time, running and supervising PA programs. Those of you who are PAs may know Randy in that about 3 years ago, maybe 4, Randy was awarded the Eugene Stead Award, which is the highest award that the AAPA can confer on one of its members, which is an extraordinary kind of award. So, Randy, congratulations for that.
Thanks.
A number of years before that, he was the PA of the year, and Randy's been very, very active in terms of moving the PA profession forward. He is now the director. What is your title here, Randy?
Director of the Doctor
okay.
of Medical Science program.
Yeah, the director of medical sciences program. Randy started about 2 years ago.
Right.
I remember Randy was saying, I hope we get some people. Can I set up a table in the back here to see if I can recruit some people? Well, now he has 200 people in this program. It's a combination of live and an internet-based program, which is, I think, the first in the country.
Yeah,
More or less.
More or less.
So now, dermatology, rashes to anaphylaxis.
Thank you, Dr. Bukata. Good afternoon. I know it's the afternoon postprandial dermatology lecture, so I get it. But anyway, I'm excited to be here. I get to spend a number of other times with you this afternoon and tomorrow morning. I'm looking forward to it. Make sure okay, so in the next little while, we're going to talk about some outpatient dermatology. What we're not going to talk about is skin conditions that are very, very serious. I know you've had another lecture on skin infections. We're not going to talk about that. So things, that with bad petechiae, multiple ecchymosis, things like Stevens-Johnson's or TAN, those kind of things we're not going to talk about. So why are we even going to talk about it then? Well, it's because, as you know, that everything comes into the emergency room, whether it's in the main emergency center or in a step-down center. Everything comes in, and there's lots of reasons for that. So the things we're going to talk about today are very, very common dermatology conditions that, just as a reminder when they come in to the emergency center in terms of what to do with them. So we're going to start off with the very common one, atopic dermatitis, eczema, a chronic itchy skin condition. Has the erythema, crusts, fissures, itchiness, excoriations, lichenification. All those things are components of atopic dermatitis. Real common in infants. You see it a lot in the face and the scalp and the extremities. Everywhere from the first couple of months of age on up to about 2 is when you see that. We also see it a lot in adults. Real dryness and thickening in the antecubital and popliteal fossa in the neck. Usually with this, we see a very positive family history of this type of dermatitis and other allergic conditions. Worse in the winter. Why? Because it's dry and it makes it worse. So treatments for atopic dermatitis, usually corticosteroids, obviously starting with over-the-counter versions, particularly in infants. You want to use it sparingly. Antipyretics, things like Benadryl, can be used, especially at night. I'm a little sensitive about using too much Benadryl in infants and young kids in terms of the side effects of that. But again, what we're trying to do is to reduce the amount of itching, and it really depends on how bad it is. And kids don't know how bad it is. All they know is they feel uncomfortable. So here are the common sites of eczema. You can see where it is in kids there and in adults. Very, very common. Like most rashes, most dermatology, there's all kinds of manifestations from it, from very mild to very serious. So look at this one. This image, you can see in this antecubital fossa, you can see the excoriations, a lot of conification in that area there. And I think the picture's pretty good because if you look at it, you can almost feel the dryness and the roughness in that. Very common for atopic dermatitis. Here's another one. You know, what we see a lot in the emergency room is mom brings in the infant and he's crying. He's been crying for 8 hours. And this is the kind of rash that you see, particularly perioral, oral, and around the nose as well. You just look at that and you feel bad for the kid because it just looks so uncomfortable. Here's some more. Again, you can see the dryness, you know, and the rash around there. See it a lot on fingers, and what happens, you get some decay of the first layer of skin there, it comes off there. This can end up being fairly painful as well, and very, very dry. So that was eczema, fairly common, fairly easy to treat, but sometimes it takes a while, you know, for multiple days, sometimes even weeks, you know, for the medication, particularly the topical medication to work. Moving on to allergic contact dermatitis. The thing that's interesting about this is it's a delayed response. It's a hypersensitivity response. The patient comes in contact with something, and there's a delayed response. Most common ones, poison ivy, poison oak. How many people have actually got poison ivy? And you see, look out there. You know, my brother-in-law and his son about a couple of months ago were out working in the backyard. They got into some leaves, and they both broke out. The son did okay after about a week. The dad did terrible for about 6 weeks. So, you know, it all depends on, you know, how much exposure and how much contact. So things like poison sumac, you see the linear lesions. Real common contact with metal jewelry, particularly nickel, and hair dyes and detergents. I should take care of a patient who her job all during the year was as a cosmetologist of taking care of hair, and once a year, for some reason, she would come in with just terrible contact dermatitis of her hands from coming in contact with hair dyes and detergents. Why it happened only one time a year, I don't know. But you see a lot of the redness, the itchiness, and the vesicles, and some bullae sometime. And the blisters, the fluid really contains no antigen. So the treatment for this, we do use oral corticosteroids for severe cases or cases that are widespread, like poison ivy. But usually we try to stick with topical for mild and limited area contact dermatitis. You can see here in this image a linear lesion there and some erythema around that. And, you know, again, this person came in contact with something that had that delayed hypersensitivity reaction to the skin. Here again, you can see the linear vesicles, and again, it could be very limited or it could be really widespread. Obviously, you see something like this, the location of the rash gives you an idea, particularly since, in this case, there's a watch there. So, you know, we look at the rash and we know the guy's wearing his watch there. We can get a pretty good indication that this is related to the contact to that. Particularly if it was a new watch, but doesn't necessarily have to be that. My wife years ago quit wearing earrings because she would get rash on her earlobes, you know, from wearing the earrings. So she didn't wear the earrings for like 20 years. And then she said, I'm going to try it one more time. So she went in and got her ears pierced and no rash. So how that occurs, I don't know. Maybe it's different types of earrings, you know, but it can happen anywhere in any place. Look at this one. I always like this arrow, like we're gonna miss this, you know, but especially when it's the same size as the jewelry there. Very common contact dermatitis to jewelry. Here's a great graph on poison ivy, you know, how to identify poison ivy. It'd be fun to read. The only reason I put it in here is because I like what it says. It says, if butterflies land there, don't put your hand there. I like that. You know, leaves of 3, let it be. You can read these, it's kind of like reading poetry. I like it. But it helps you get an idea when you see particular kinds of shrubbery, whether it's something you have to stay away from or not. The only way of really finding out is jump in and see how it goes. Okay, here we go. You see again the vesicular lesions from the contact. And here again, so once again, figuring out where it is on the body, the type, the vesicular erythemic type of rash, and where it's at, and determine, what the cause of the contact was. I mean, this could be anything from soap to perfume, things like that. Okay, we talked a little bit about poison ivy. The treatment for that really, again, is topical symptomatic therapy. Soothing measures like oatmeal baths and cool, wet compresses have been helpful for decades. Topical treatment with compounds containing menthol and phenol, like calamine, help provide symptomatic relief as well. Other things like Burroughs solution, been around forever, can be very helpful. And soap mixture of various things also can be a benefit. There's a lot. If you go into the drugstore and you ask the pharmacist what to treat poison ivy with, he'll show you a shelf of stuff that's used for treating the topical symptomatic poison ivy. What about antihistamines? Well, topical antihistamines or anesthetics that contain benzocaine or antibiotics that contain neomycin or bacitracin should be really avoided because of their own side effects and potential. And there's really little evidence out there to support even the use of oral antihistamines, particularly because of their sedating effects, and also the whole idea of trying to do this is to reduce the itching. Now, the itching with poison ivy is really not caused by that histamine release, so there's some value or lack of value in actually using it. Not saying you shouldn't use it. If it's good to try and see if it helps the itching. Okay. So, what about corticosteroids for poison ivy? Yep, the topical ones, the high potency topical corticosteroids are most helpful in the early stages. And when I say high potency, everything from 1% to 2.5% of cortisone. Once the vesicles are established, using them really doesn't alter the natural course of the disease, But again, if you're limited to things to do, I would still be doing it to be doing something for the patient. What about systemic? Patients with severe dermatitis, particularly involving the face or the genital region, may require some systemic corticosteroids. Oral prednisone is the most common. There's the dosage there. Maximum initial dose of about 60 milligrams per day. Used early on. These do have some dramatically beneficial results, particularly for the patient that's miserable. I was talking about my brother-in-law. He was miserable for 6 weeks, and they kept giving him oral steroids along that time, and finally it started working. It can be tapered over a couple of weeks, like mentioned here, 60 milligrams a day, then down to 40, and like that. That's a possible way of doing that. There are some studies that show that if you just keep a regular dosage of prednisone, that does just as well as tapering it. We'll talk more about that later when we look at other uses of prednisone. What about antibiotics? Obviously, the only time to use antibiotics in a skin condition is if there's a secondary bacterial infection, if you suspect that. If the patient has a temperature or it depends on the drainage from the site, you have to make a decision whether you think there's a secondary bacterial infection there. This is particularly directed at gram-positive organisms. For instance, most patients with a secondary impetigo will be infected with S. aureus or group A strep. So something to think about. And obviously, given the increasing rates of community-acquired methicillin-resistant S. aureus, performing a skin culture may be a reasonable thing to do, particularly if pus is present. So trying to do that differential to find out what else is going on. All right, pityriasis rosea, also called what? The Christmas rash. Most common in kids, young adults, most often in the spring and the fall. We don't know what the etiology is. What we do know is it's not an epidemic. It's not contagious. Most of the time we see these folks, the best thing we can do for them is to educate them and let them know that it's not a contagion. The rash evolves over weeks, and usually you see a Herald patch. We'll see one in a minute. Sort of a single salmon-colored lesion with kind of raised borders, usually seen on the trunk. And usually about 1 to 2 weeks after that Herald patch comes about, then you start getting this widespread macular oval-shaped lesions, which I'll show you a picture of. Yes, you do need to rule out syphilis if the patient is sexually active, or looking at whether this is a drug reaction. Resolution of this, the literature says 2 to 10 weeks. I've seen it occur a lot longer, but that's the most common time, is that 2 to 10 week period of time. Here's the picture. You can sort of see that Christmas tree pattern that comes down on the trunk there. You have to look closely to determine a Herald patch there, but you can see here, you can probably pick out the Herald patch on the right side, on her right chest. And here, now there are a number of lesions there, but again, if you get to see this early, which usually is not the case, you can usually pick the Herald patch out early, but usually by the time you see them, they've got this widespread rash on their trunk. So there you go again, another picture of that oval-shaped pattern. Okay, so that's pityriasis rosea. We'll talk a little bit about urticaria and anaphylaxis, and realizing I said earlier this is about non-lethal things, and I do know that anaphylaxis can lead, to lethal outcomes. So we had talked about it a little bit. The thing about urticaria, first of all, it's very common. It can be diffuse. It's very itchy. The wheals, these hives. The important thing to know about this is that urticaria occurs in the superficial dermis. And while we don't know what the etiology is, we do suspect things like drugs, food that occurs maybe about a third of the cases, insect stings, things like that. And the physiology, as you remember, is that IgE that moves the mast cells and then has that histamine release, and we end up getting those manifestations. The good news is with most urticaria, now unfortunately, most urticaria that's self-limited, we don't see them because it's self-limited and they get better. But by the time we see them, they've gotten a little bit worse. So in severe cases, we have to be really careful to make particularly if they're wheezing, if they have hypertension, swelling of the lips or mouth or airway or flushing or just extreme itching, we have to make sure that we follow up and figure out what's going on to make sure this doesn't go further down the road that we don't want it to go down. Here's some typical pictures of urticaria, sort of a geographic lesion, raised lesion, usually on the trunk, but you see it a lot on the extremities as well. Actually, you can see it anywhere, as you can see here. Another picture of urticaria. And okay, as I said, urticaria can be really mild. Most of the urticaria I've ever seen is something that's been mild to moderate that, some topical or some oral treatment seems to make it well. And sometimes that might just be some oral antihistamines. And if it's starting to get worse, the use of steroids. Obviously, urticaria that moves to anaphylaxis can be life-threatening. And there's a list here of things that we all do if we start having some issues. I saw a patient once who had been to his allergist's office and gotten his allergy shot that he got every week. And this week they upped the dose a little bit, and they kept him for the 30 minutes that you're supposed to do. And he was driving home, and he started feeling funny in his chest and itching and started coughing a little bit and kind of like that. And he was fortunate enough, he was driving by the hospital, decided to come into the emergency room and brought him in, and he was starting to break out in general urticaria, but the important thing is he was having a little bit of swelling of his lips, and so a little bit of epi, a little bit and he was starting to wheeze a little small volume nebulizer with albuterol, and even some oral steroids at that point was helpful, and then consider using the H1 and H2 antihistamines. In this case, he did fine, but you don't know what would have happened if he hadn't stopped, if the urticaria or the anaphylaxis had gotten worse, and he couldn't breathe, and he was stuck out in his car. Okay, angioedema. Now, I talked a little bit about urticaria occurring in the superficial dermis. The interesting thing about angioedema, besides looking terrible, is it occurs further down in the dermis. Usually edema of the face, the extremities, the bowel wall. Anyway, deeper in the tissue, and usually with angioedema, there's usually no itching. And it's difficult to treat. You see somebody like this coming in, it's scary, we think they may need some airway management, and when do we do that kind of thing? The most common drug cause is ACE inhibitors. And even those who've been taking ACE inhibitors their whole life can end up with angioedema. So it's not something that's just taken recently. They could have been on it for a long time and then developed this. So obviously starting with the usual anaphylaxis treatment, but other therapy may be required. So we need to be thinking about this early on when you see this presentation. Things like fresh frozen plasma or other types of medications may be needed. So it's scary. And on purpose, we need to do something about this to make sure that we maintain a good airway. Here, look at this. I mean, you see this, somebody comes in with this, that's a little scary. If it's scary for us, can you imagine how scary it is for them? Okay, enough of angioedema. Other common things that we see, the tinea, the fungus infections of the skin, and obviously we named it after where it is. For the tinea capus is always on the scalp, or the tinea barbae on the beard, and it causes broken hair, scaly patches, edematous nodules. A lot of mothers and teachers particularly with kids, my kids got ringworm, because it has that circular thing, and they think it's some sort of contagious worm of some kind. So again, we have an opportunity to educate the patients. The tinea pedis on the foot, the tinea cruis in the jock area, or the groin and upper thigh. And with these kind, particularly with adults, it can happen with kids. With adults, consider checking their glucose to see if there's some underlying cause for this. Treatment for these mostly are over the counter, Tinactin, Lotrimin, Mycotin, treating for 1 week after resolution. It's been my experience it takes a little longer, so I always make sure to, after a week, if it's not completely gone away, to go ahead and continue taking that for another week. Okay, so you can see here the circular raised areas there on the scalp, also on the body of the tinea, and there on the foot. And the ones that I've seen on the foot this looks pretty bad, but I've seen probably 10 times this, covering the entire foot. Patient can't even walk on it. It's so dry, it's so excoriated, if you will, and it's painful to walk on. And the reason that they're seeing us is they've been trying to put up with this, for weeks and weeks, maybe even trying some of the over-the-counter medications that hasn't worked. So now we're faced with having to deal with this and take care of it while they're in the emergency room. Picture of the area in the jock area. Okay, tinea versicolor, hypopigmented or hyperpigmented circular scaly patches. You can see right there in the picture. The interesting thing about this is you look at it and you see all of the pale lesions. Actually, those are areas, and the reason they're pale is because of the area over that does not get, when the sun shines on it, it doesn't tan. So it's like putting, a Band-Aid on your chest and going out for a couple hours in the sun, taking the Band-Aid off, and you see that below. So that's an area does not get sun exposure. Usually because of poor hygiene or lots of moisture. The fungus is Malassezia fervor. I like saying that. I don't know what it means, and I like saying it. But the treatment is usually selenium shampoo or Selsun Blue that you buy over the counter, ketoconazole shampoo or cream. Again, it takes weeks and weeks to treat this. It's not serious. It's just people don't like the way it looks. And I've seen it a lot just on arms. And again, you see it during periods of time where the sun's out because the area does not get tanned. You can see the picture there. And okay, talk about Lyme disease. So again, we've all been learning about Lyme disease for a couple of decades now. We know it's transmitted by a tick, and usually we don't know that it's a tick bite, but you look at what the risk factors are, where they were at, although, you know, if somebody came in and they were from the Northeast, you'd say that's a possibility. But we do know people that have come from Hawaii or Seattle or where. Why? Because we can travel now. We can travel all over the world in a fairly rapid period of time. So we have to take the idea of Lyme disease as something that could occur from anywhere. It's called erythema migrans, which is the initial phase. It's sort of an annular, expanding, erythematous lesion with central clearing areas. It usually spares the palm and the soles. We'll see some pictures in a minute. So that's the initial phase. The secondary phase is the neural phase, neurocardiac, musculoskeletal phase, as you see there. The diagnosis for Lyme disease is the ELISA screening test and the confirmatory Western blot test. And the treatment, we'll talk more about that, but are traditionally the doxycyclines or the erythromycins, amoxicillin, trioxone. The real question is, you know, do you test or you treat? And that really depends on what you think the probable risk is in terms of that. So here, this is a great graph that's in your book. Really looks at the manifestations and the differential diagnosis of each stage of Lyme disease. We talked there on the left-hand side are the stages. We talked about the early stage, the early disseminated and the late disseminated, and the manifestations, and also the list of differential diagnoses that you should look at as you're trying to decide, you know, what caused this rash in this patient. Here's a picture, sort of the target lesion, if you will, with the raised sort of macular areas. Again, you know, these are great pictures, but you know, you don't see it this way all the time, and sometimes there's not even a rash. I believe I read some time ago that there's a significant percentage of patients that come in that don't have a rash. So now look at this one. It's a little different than one we just looked at, but we still, you see this, you got to get the appropriate history, travel, risk factors, things like that in trying to decide Lyme disease. Okay. I like this. I like the arrow, just make sure you don't miss this, as well as drawing a circle around it with a pin, but you can see the target lesion there. This is even better. They show up and there's a tick. You know, thank you. And helps us out a great deal, although I would hesitate to say don't take everything for granted. Okay, another great graph to use. This is the treatment graph. There on the left-hand side are the stages that we talked about, manifestations in the first, second, third line of treatment for adults, and then also the treatment for pregnant or lactating women or children thereof in terms of that. And we've talked about those medications earlier, but this is a good resource, you know, for your files in terms of looking at currently the appropriate treatment for that. Okay, quickly on to canker sores. You know, why would you be coming into the emergency center with a canker sore? Well, A, it's painful. You don't know what it is. It's been bothering me. There may be more than one of them. And then on the inside tissue or linings of the mouth, that's concerning. I don't know what it is. So, and it started off as a vesicle and then kind of got, you know, kind of ulcerated a little bit. So we don't know what to do. These usually occur in childhood, and as you know, the recurrences are common. The causes are really speculative, whether it's an immune issue, a nutritional factor, or dietary allergies, we don't know. Treatment for this is the topical steroids like triamcinolone or the Kenalog Orabase or others there. Treating it topically is probably the best thing to do. What about the herpes labialis, HSV1 and 2? And remember, either of these can cause the oral or the anogenital lesions. Although one is usually oral and 2 is usually anogenital, but doesn't always have to be. The initial infection usually involves fever, sore throat, swollen nodes, and the painful vesicles in several days that crust over. In this case, make sure that you look for perhaps a secondary infection, particularly in the mouth. Again, recurrences are common, and the treatment for this is the antivirals like acyclovir. Here's some pictures, and if you've ever had one, you know how you can tell sometimes that it's coming on before the lesion gets there, and then once it gets there, it can be very, very painful. And it does not make your day at all when you get these. Herpetic Whitlow. This is a painful herpes simplex condition. About 60% of these are HSV1, and they occur on the finger. Years ago, I worked in employee health at a large hospital chain, and we kept getting herpetic Whitlow in neonatal nurses that they would come over with a rash on their finger. And of course, this is very contagious, so that would put them out of the neonatal area, for a week or 2 weeks or 3 weeks because of the potential of that passing on. So very common in healthcare workers, very common in dental workers and kids. Just as a point, because they're big vesicular lesions, and we don't do this anyway, there's no reason to IND those. You're just letting, potential contagious material out. So last week's, again, the treatment for that is acyclovir or any of these antivirals that you see there. So look at these pictures, and some of these look like they've been a week or two down the road, and they don't look quite as painful as what you might see the first week. Okay, herpes zoster. How many of you have had herpes zoster? I have. It's not fun. It's the chickenpox virus that's reactivated. It's vesicular, painful lesions in that dermatomal distribution. And it's particularly severe if there's cranial nerve involvement. I'll show you a picture in a minute in terms of herpes zoster ophthalmicus, where the ophthalmic branch of cranial nerve 5, and it's sometimes seen on the tip of the nose, called the Hutchinson sign. And those can be very serious and can actually be vision threatening. So anytime you get this kind of a lesion that comes down to the nose, and then the second one you can see around the eye, those things probably ought to be referred out fairly rapidly. The second one of cranial nerve 7, Ramsay-Hunt syndrome, can present with facial nerve palsy and ear pain. I've seen it where it's gone all over the ear and just made the ear look like a crusty cauliflower ear, if you will. You can get complications from this: pneumonia, meningitis, post-herpetic neuralgia, and things like that. Again, the treatment is acyclovir or some of the analogs, prednisone, things like that. So we can go from herpes zoster, that just a slight rash on the trunk that's kind of bothersome, that hurts when you have your shirt over it, to things that are very bad. I'll show you a couple of pictures. So here's a herpes zoster here. Again, this is probably one that's been a week or two down the road, but can become very, very painful, and people can't sleep with this. Here's one. Here's the Hutchinson sign. Goes to the tip of the nose. The one I've seen actually had come down the nose and around the tip of the nose in this area. It's really terrible. And this person had had it for like 2 weeks and didn't know what to do about it. And here's the Ramsay-Hunt syndrome. Looked at those ears with the just terrible destruction to that area there. Okay, more herpes zoster. Again, remember, painful. All right, that's everything you need to know about dermatology after lunch, and I think we're moving on to Dr. Gooch.
Thank you.
Yeah, thank you.
Good afternoon. So earlier today we started out with some of the ENT stuff and talking about ears, and now we'll kind of finish up the ENT stuff, talking about the sinus, nose, and some of our dental problems as well. Sinusitis is a common complaint that we all see in primary care, urgent care, and even emergency care. We know that probably almost 90% or more of people that have an upper respiratory infection will have some type of sinus involvement. Luckily, only a small portion of those actually develop a true bacterial infection, but it's very common for people to have that congestion, sometimes that pressure that we'll see go along with that typical URI. Most of us have probably all experienced this at least once in our life. The nice thing to keep in mind is that this is usually viral in nature, so usually it's just supportive care. The sinuses themselves are sterile, and then when something gets stuck in there due to congestion, it tends to cause some inflammation, which causes the congestion, the pain they see, but minimally is this actually going to be a bacterial infection. But the classic presentation is the congestion. They may have increased pressure when they bend over. Sometimes that may cause some dizziness, some lightheadedness, with some patient. They may have the runny nose or just the congestion itself. Occasionally a low-grade fever. This usually doesn't cause a lot of systemic symptoms. How long have they had the symptoms for? Most people, less than 10 days. I'm really thinking this is more viral in nature. It could have been allergic that's now led to this congestion. Now, if we're starting to see symptoms over 10 days, 2 weeks, now I'm concerned this might have actually developed into a secondary bacterial infection. And those are the typical pathogens we talked about earlier, like strep or H. flu, M. catarrhalis. That's usually only a very small portion. So what are their symptoms? How long have they had their symptoms? And let's look at our physical exam findings. Do they have pain or pressure over those sinuses? Typically, especially when we do that typical percussion, that usually causes some pain. That's classic for sinusitis. Doesn't help me differentiate if it's bacterial or viral or not, but just tells me those areas are inflamed, and that's what's giving those pressure symptoms. Look in there, see what I see in the nasal area. Do I see a lot of inflammation? Do those turbinates look very boggy or they look red? What does their drainage look like? Is it thick or is it kind of clear and thin? Do I see that postnasal drip that's very common with these patients as well? Look at the back of their throat. And sometimes they come in with that sore throat complaint, and it's simply just because of that sinus drainage running down the back of their throat, which is really irritating. But this is typically usually viral in nature, so it's getting the patient to understand this is going to pass when it's on, usually less than 2 weeks. It's just going to be simply supportive care. There's really no role for imaging in these patients. Now, if I'm talking about like chronic problems, then yes, those patients may benefit from advanced imaging. But for your typical, I've got a sinus infection, I've got the sinus pressure, physical exam is really all we need with these patients. And then looking at the ISDA's guidelines, probably for most of these patients, it's just supportive care. So thinking about the benefit of intranasal steroids, those may have some benefit in some patients. Help reduce the inflammation, help improve drainage of those secretions out of the sinus cavity. There probably is a benefit for some of these people with using a sinus wash. And there's several out there, but just washing away all that mucus and that debris that's in there definitely may bring them some benefit. For some people, they may benefit from even local topical vasoconstrictors like oxymetazoline or neosynephrine. The biggest thing about those two drugs, if we're using those, is they should be used for a short course only, usually no more than about 2 or 3 days. If the patients use those for more than 5 days, that can sometimes cause a rebound effect and actually cause worsening of the edema and worsening pain and pressure. But as you know, we want to recommend 2 or 3 days of those topicals. That's probably beneficial. That may actually help facilitate the sinus washes and may even improve application of the nasal steroids as well. If we're talking about other things like systemic medications, definitely be cautious with decongestants, especially those that have uncontrolled blood pressure or other problems. For most, this is just going to be simply just supportive care and watching and waiting. And as I talked about this morning with watching and waiting, the big thing is, do they have follow-up care? Do they have access to someone? Maybe that's coming back to see us in our clinical practice, or maybe they actually follow up with someone else. And we do want to make sure this is an immunocompetent person. If this person's immune compromised or has a lot of other comorbidities that increase the risk for complications, that's the patient I want to be more cautious about, and maybe I need to consider more close follow-up or actually even treating this if it was a bacterial infection, if those risk factors are there. If we need to treat a bacterial infection, usually now they've got the symptoms more than those 2 weeks, they have a lot of localized symptomology, then probably it's a short course. 5 to 7 days is just as effective as 10 to 15 days or 10 to 14 days. Probably our treatment is going to be those typical bugs we talked about earlier. So amoxicillin's a good agent, though we are seeing increase in resistance. So anything about using high dose. Have they had anything recently? The macrolides for years were really good options, and now in most areas we're seeing at least a 25 to 30% resistance rate in all regions with the macrolides. And once we get over that 25% number, those tend not to be a very reliable agent. So it's going to probably have to be a cephalosporin or maybe a penicillin in those patients as well. So definitely we've seen a lot of stuff come out with a lot of different things about the use of antimicrobials and being good stewards. And same here at the Choosing Wisely campaign. And definitely like most things, we tend to be over-treating these with antimicrobial agents that did not need to be. So really stop and think and ask, is this patient most likely to have a viral, or do we think this is truly a bacterial infection? The number needed the benefit versus the number needed to harm is pretty impressive. Look at some of these studies and the risk of bacterial resistance, the risk of side effects. And we do know that just a single treatment of an antibiotic may change the bio for that patient and may offset their gut biome and may increase the risk for C. diff. We're now even seeing community-acquired C. diff because of so many more people out in the community that have developed this due to that resistance. Use your clinical shared decision making. Discuss with the patient. Here's our options, here's our benefits, here's our risk, and trying to get them to understand that antibiotics are not without risk. Just like any other medication, there's the risk. Here's what they are. There are complications. This is what some people usually ask about. They've gone to their favorite web search engine, and Dr. So-and-so told me this, but what do I see? Yes, there is the risk for orbital cellulitis, but that's when we want to follow up and have them rechecked in a couple of days. Very rare to see osteomyelitis or even intracerebral abscesses, but they do happen. But that's why follow-up is really important. And if this person doesn't have a primary care provider, they can always return to see us, whether we're emergency care or urgent care, and use us if they have to. Or maybe we can get them set up with someone else to do that, to have that follow-up care. So earlier we talked about foreign bodies in the ear, foreign bodies in the nose as well. An important caveat, especially with children, anyone who has mental delay issues, if I check one orifice, make sure you check them all. Because if they put something in one ear, they may have put something in their nose or somewhere else. So definitely be sure that you look at all those orifices that someone may have stuck something in. These can be challenging because I have to worry about airway concerns. Most of these are usually not that big of an object, can cause an airway obstruction, but definitely have to think about, can I get this out safely without pushing it further back or actually making it fall into the oral pharynx. Classic presentation sometimes we see in the ED is mom, dad bring the kid in, they have this horrible smelling just discharge to their nose. It could be infectious, or oftentimes it's also going to be a foreign body. That kid shoved a little bit of a piece of toy up in there. They've shoved up some nerds. The most fun ever was rabbit food. Kids shoved a bunch of rabbit food and nerds up in there. That was a fun mixture coming out. But typically it's that foul-smelling odor that we'll see. If it's a button battery, if I'm concerned about a button battery, that is definitely something we need to get removed sooner versus later, because that can cause some erosion in the nasal septum and can cause some problems. So some of these things could probably wait to be seen if we need to by specialists, but that button battery is one that definitely doesn't need to wait. One thing that may help us facilitate removal is using our topical nasal constrictors again, the little Afrin, little oxymetazoline, and let it sit there, and that can vasoconstrict those areas. If you have access to it, medical grade cocaine is also very helpful because it gives us really good vasoconstriction, but also gives us a little bit of anesthetic effect. We may make it easier if we're up there having the instrument and get those objects out. I want to try to get this out without causing further injury, so definitely in the patient who's not cooperative and our children, then we may need to consider the use of procedural sedation. Because definitely if I can just sedate them a little bit, go in, get that out without causing further injury, that's definitely a big benefit versus the harm. There are a couple tools out there. One of this is this having the caretaker do the puff of air in their mouth. That sometimes helps. They've got a little object in their nose. Have mom or dad get a good seal around their mouth. As you occlude the good air, have mom or dad blow, and that will sometimes get whatever it is either closer to the edge or may actually allow it to be removed. Or if they don't want to do that, use an ambu bag. Get a good seal if a kid will let you, occlude the good air and blow in their mouth, and that may cause whatever's there to come out. Biggest thing, wear a face shield and stand clear. Because when nerds come flying out or rabbit pellets come flying out, it is not fun. I didn't think about that real well, and mom did not like her new hairdo. But it works. But sometimes just getting that stuff to come out may be very helpful and very easily. There are several tools out there. I mentioned earlier, like the alligator forceps. We have the nice little ENT suction that sometimes works. There's actually several balloon devices, and here's one of them. This is the Fogarty balloon. There's another one called the CATS distractor. But what it is simply a little catheter with a balloon on the end of it. And then I insert that, get it past the foreign object, and when I inflate it, now I've got a nice bulb, and I can use that to pull this out. And that sometimes works really well, especially objects that I can't grab with forceps or something, like a crayon. Those, you can't, there's no way to grab them. They just start melting and tearing apart. But if I can get the person to hold still enough, slide that little catheter past it, inflate, then pull out, works really well to remove objects from the nose. Sometimes even in the ears sometimes, but definitely that balloon device here is really good to use those, especially objects that's hard to grab. Beads are hard to grab, unless you just kind of get a hole in the center to grab a hold of those. So epistaxis. Occasionally see these people, the most common cause is going to be trauma. Usually it's direct digital trauma by the patient because they're checking out things up there. But definitely think about trauma, think about infection, think about foreign objects. Those are usually the most common causes of epistaxis. It's almost always anterior, maybe erosion there or damage there of the mucosa there over Kesselbach's plexus. If I can't find the site, if I'm up in there looking, I can't find the origin, then it may be a posterior bleed, but luckily most of these are usually anterior. If I'm worried about other problems, look for other sources of hemorrhage. Am I seeing petechiae? Am I seeing purpura? Is this patient got other risk factors? They're on anticoagulants or antiplatelets. Those can definitely be problematic. Other things to consider are NSAIDs can all have a little antiplatelet effect, some worse than others. And think about herbals as well. Your G herbals, garlic, ginseng, ginkgo, ginger, all those have some antiplatelet properties. Garlic's probably the biggest one. That's one of the reasons people take it. Helps with blood pressure, cholesterol, and is a little antiplatelet. So if they're coming in, they're bleeding, and they're not only in medications, don't forget to ask about those herbals because those sometimes are really helpful. Most of these patients don't require any lab testing, but there's occasionally a patient who's really anticoagulated very well, and they do drop their H&H and may require sometimes some transfusion. Ice packs don't work. Used to, put a little ice pack on the back of their neck. That'll help. Doesn't help. The best thing, like any other hemorrhage, is direct pressure. Grab the nose, have them grab the nose, and they need to hold it. It may take 10, 15, 20 minutes to get hemostasis. If this patient is anticoagulated or antiplatelet agents on board, it may take a little bit longer. But for most of these patients, direct pressure will work. If we need to, go ahead and put in that topical vasoconstrictor. I work with some ENTs, they're like, go ahead and just spray it up in there always, no matter, so you can go ahead and be working while they're holding direct pressure. And usually there's just a little vessel that's eroded away, that tends to help dramatically. If I think I want to do some instrumentation or if I want to do some packing, and you have it, medical grade cocaine is really helpful. So it gives us both that vasoconstriction but also the anesthetic effect, and it works really well. Things like tranexamic acid or topical thrombin are also very helpful. You used to have to do a lot of cautery and actually go over there with our servo nitrate sticks and burn those little areas, but now we usually get some pretty good relief with these topical things that may be helpful and prevent more of those invasive things, or the patient doesn't smell that wonderful smell of burning mucus as you're trying to cauterize it. As I mentioned, if you can't find the site, if I can't get it to stop with direct pressure, then I'm more concerned this might be posterior. And those patients almost always require some type of tamponade device or some type of packing. And we may have to do those also for anterior patients, but most of those usually with direct pressure, with some topical vasoconstrictors, we can usually get pretty good control. But if it's posterior, it almost always is going to require some type of device. So if I had to do some packing, I've got several examples here. We've got the Rhino rockets, we've got the balloon devices. These can all be very beneficial. Most will recommend that if we're using a non-plastic device, like not one of these balloon devices, go ahead and coat it with topical Neosporin or bacitracin, and that may help prevent the development of some type of strep or staph infection, which occasionally is associated with these devices. The manufacturers will recommend that if you're using a balloon device, not use a petroleum-based substance. You need to use water-based lubricant, and those do tend to need a little bit of lubrication to get them up in there, and they tend to work pretty well. And a lot of times, if we can get the bleeding to stop, this patient's going to go home, and they're going to follow it with ENT if it's anterior. If it's a posterior bleed, those patients probably should be admitted for the risk of other complications that we'll see with that. But definitely think about your risk. Is this patient at risk for airway problems? If this patient continues to bleed, we have to worry about hypovolemia. Dislodgement of those are pretty rare, but just things to consider. Our biggest concern usually in our older patients is the risk for bradyarrhythmias, especially if I had to put in a posterior packing or a posterior balloon tamponade device. That patient would probably benefit from being admitted for observation and have them managed between medicine and or ENT. One of the community hospitals I worked at before, medicine won't admit them unless ENT's in-house, and usually they don't need anything from ENT, but that's some of the challenge we sometimes run into. But definitely if it's a posterior bleed, definitely if you had to do those balloon tamponade devices, especially in your older patients, those have a higher risk for complications. We probably want to get those observed if at all possible. Otherwise, they go home, they follow up in 24, 48 hours, they remove the packing and usually do fine. So our nasal fracture is our most common facial fracture. And for a lot of people, it's just going to be a clinical diagnosis. Now, if I've got concerns for mid-face trauma or something else, then yeah, imaging is probably going to be beneficial. But for some of these patients, I may not require any imaging. They've got a little distortion there, they've got some edema, maybe some bleeding, and there's not much to do for that. Most ENT won't reduce these unless it's really early, or they're going to wait days and let the edema go down first. But it is our most common facial fracture. As I mentioned earlier with looking at a basilar skull fracture in the tympanic membranes, here let's look at the nasal septum. Make sure you document the presence or the absence of that septal hematoma. If I have a septal hematoma, just like earlier we talked about the auricular hematoma, that needs to be addressed, because if not, it can cause some problems as well. If I have a lot of drainage from the nose, especially if I'm worried about that basal skull fracture, then definitely think about the need for other advanced imaging depending on the mechanism. And if I'm really concerned this might be a basal skull fracture, then maybe we should go ahead and do the halo test, or that ring test that I talked about earlier. If it's purely clear, then do your glucose check. But most of those people are probably going to go ahead and get more imaging anyway if the trauma is visible enough and the mechanism is high risk. So as you can see here in the spindle picture, that is your septal hematoma. And if that is not recognized and that is not drained, very similar to the auricular hematoma we talked about earlier, that can cause some significant deformity. That blood is going to be very destructive to the cartilage. It will destroy the nasal septum just like it can the cartilage of the ear, and going to cause a deformity. And what actually happens is they get a nice saddlebag deformity of the nose, and now this guy's got the 2-for-1 special. He's also got the cauliflower ear. So definitely, anytime we've got a traumatic nosebleed, look for that septal hematoma. If I can't see it for good, make sure you suction that area out. Get them to blow their nose and look for those. If it's there, it's got to be drained, because I want to prevent that from reaccumulating. And this is where we come in with either doing our topical cocaine or even doing a facial nerve block if you can. And we're going to drain that and simply go up in there and aspirate out the blood. And then we're going to pack both sides, because I want to prevent this from reaccumulating. And that will hopefully prevent that from reaccumulating, and that will prevent this tissue destruction as you see here in this image. If I can't keep it from reaccumulating, then I'm probably going to have some problems with that. And just like the ear earlier, usually want to bring them back 24, 48 hours, have them seen by ENT preferably, to take that packing in and look at it. And if it's reaccumulated again, then they need to have that reassessed, and probably then that's when we're going to actually do an IND and drain it out. But those patients will do really well with doing either bilateral nasal packing or a tamponade device on each side to compress it. And probably most will go ahead and recommend that we go ahead and put them on some type of antimicrobial agent, because likely it is an open fracture if they actually have that septal hematoma. So probably a short course of amoxicillin or amoxicillin clavulanate would be well. And one thing to go back to, if we're talking about doing the epistaxis, and I do need to cauterize that, I shouldn't cauterize on both sides of the septum. If I've got bilateral nosebleeds, which occasionally happens, I can cauterize on one side but not both of the septum. Otherwise, I'm worried about perforation. And our last thing is our dental problems. Very common almost every day, somebody comes in with a toothache. And we know that our dental care could be a lot better in this country, especially in some areas more than others. Our periapical abscess is the most common. So they've got a little pus formation right there at the top of the tooth. Usually it's pretty easy to identify. They can tell you exactly which tooth hurts. If they really can't, take a little tongue blade and just kind of percuss, and you'll find the tooth that really gives them the most pain. And that area may be easy to drain and then get them in to see a dental provider. But if they've got widespread disease, that patient may have more than just a periapical and could have a periodontal abscess. And luckily I work at an academic hospital. We have MaxFace services available 24/7. At my community place, we don't. And that sometimes becomes a problem, because these people probably just need IV antibiotics and watching them, but sometimes medication services won't do that. But get them to where they can have follow-up. If we can IND it, let's get that pus out. It really helps with their pain and also tends to facilitate resolution. Clindamycin is a good agent here to use, metronidazole as well, because they're going to cover our anaerobes. And typically they have a lot of pus there that usually is an anaerobic organism. So as you can see here, this guy has this nice little abscess right there above the tooth. Imaging usually isn't necessary, but if you have a chance to get it, or you might sometimes pick this up on just some plain films, but you can see some destruction there above the tooth where we've got some of this pus formation. If I've got an avulsed tooth, they've actually knocked that tooth out of socket. If it's an adult tooth, I want to try to get it back in place as quickly as possible. I have roughly 60 minutes. So as you can see here in this picture, there's a little periodontal ligament. And that's the structure that's really important for holding that tooth there in place. And if it's been more than 60 minutes, or if that ligament gets damaged, that tooth will not be reimplantable successfully without doing probably a root canal. But if I can get that back in the socket as soon as possible, great. If it's a baby tooth, who cares? If it's in a child, I'm really not sure, was this adult tooth, is this a baby tooth? Look at the socket. Usually in most baby teeth, the socket's going to be pretty well closed, or you actually may see the tooth underneath it pushing through it. And typically, if it's an adult tooth, when you look in the socket, it's empty because that tooth should be there. If possible, I'm just going to put it right back in its place, give them some gauze to bite down on, and that usually seats it pretty well if it's avulsed. If I can't put it back in the socket, especially if I'm worried about foreign body ingestion or something, then let's try to put it in something to keep it cool and preserve it, whether that's going to be cool milk or cool water or even some of those preservatives like Hank's solution. But try to keep it as moist as possible. And ideally, we want to get them to a dental provider as soon as possible to get that successfully reimplanted. If it's a fracture, so we use the Ellis classification system. If it's a class 1 fracture, an Ellis 1, that just involves the enamel, that's probably the ones we see the most of. Those are purely cosmetic. They can see a dental provider whenever. An Ellis 2, now it's down into the dentin. And the dentin's pretty hard stuff as well. It's not as hard as enamel, but it's pretty hard. And that ideally we want to cover with something and get them to a dental provider within 24 hours. And if they have a class 3 or an Ellis 3 fracture, that now is down into the pulp. And that usually is exposed, the nerve root, the vessels, and that usually is very painful. And ideally, that person needs to see a dental provider as soon as possible to salvage that tooth. They actually make stuff called dental foil that you can wrap around this tooth, and that's usually pretty protective. That nerve is exposed, it is very painful, like anything else, and it's very throbbing. We'll go ahead and cover with antimicrobial agents, but try to get them to see a dental provider as soon as possible. If it's just a type 1 fracture, that's cosmetic. They can see them whenever. There is an object out there called the dental box, which is really helpful, especially if you're in a place that doesn't have dental services. Pretty inexpensive. A lot of people use it. It's available, order off the internet, but gives you a lot of the things you need to do this, whether it's just stabilization of these fractures. If you don't have these services available, you can use suture, dental floss, other cool things as you can see here, just to kind of stabilize these fractures until they can get in to see somebody. But definitely if I've got significant dental fractures, infection's a risk, and then always make sure that I don't have mandible or maxilla fractures that go along with that. But definitely if they have fractures through the teeth and the gum line, that's a pathway for microorganisms. Counting teeth. I can't remember this. If you can remember that 8 and 9 and 24 and 25 are in the middle, that will help you out a lot. This is a diagram I have to look up frequently if it doesn't pull up to tell whoever, like, hey, it's tooth number 7 or it's tooth number 4. But if you can tell them the dental number, they're happy versus trying to go, oh, it's a lateral incisor versus it's a premolar. Just give them a number, and they're usually pretty happy with that. And the last thing is that person that comes in with an isolated toothache, one thing we can offer them is a periosteal block. So to have to give them something else, offer them a little periosteal block. And what you simply do is just pull up some lidocaine or Marcaine and inject about 1 ml right there above the tooth as you see here, beveled side right there above the tooth, and inject that anesthetic, and usually gives them several hours of relief. And when people come in asking for a block, I'm like, oh, they really want to get some relief here. And if you're able to, actually do a facial block if you need to. That really gives them some good relief. But some of these patients, all they want is just a little bit of relief of this. And if they have an infection, we want to treat that. Because one thing we have to worry about, that untreated dental infections can lead to other problems like Ludwig's angina, which we'll cover later. But definitely there's some great resources out there. If you don't have a dental provider, usually your larger hospitals will have those available. Some of this stuff can be outpatient, and stuff definitely may benefit from treatment now versus later. All right, thank you very much.
Okay. Thank you. Yeah. All right, guys, we're getting toward the end of the afternoon. We're going to keep going with some cervical spine disorders, most benign, some not. And today we're going to talk about C-spine injuries, but we're not going to talk about the C-spine injuries that you see in the major trauma areas. We're not talking about the intubated patients. We're not talking about the multi-system blunt trauma patient that's going and getting pan scanned. We're talking about the ones that we tend to see in our fast track. Who sees these types of patients in their fast track? C-spine, people come in with C-collars. The patients that we're going to be talking about and that we're going to be focusing on are these sort of patients that don't really have a whole lot of other things, but we're going to try to figure out, A, which of these patients actually need to be immobilized? Is there evidence that they should be immobilized in the first place? 2, if they are immobilized in a C-collar, which of these patients can get cleared, and 3, which of the patients need to be imaged. So we're going to talk about all those and sort of an evidence-based approach to all that. So let's start with cervical spine immobilization. Who remembers the days where we had these long backboards, the hard, long backboards? Who's still seeing those where they're practicing? Patients are still coming in those hard backboards. So are those benign, not benign? They're not benign. They cause a lot of pain. Have you ever tried to sit in one of those things? Man, they hurt. The whole point of that is to try to help immobilize the spine and keep you in one position. But if you sit on one of those things, after a few minutes, you're just like, oh man, this doesn't feel good. People develop pressure ulcers. People that don't have any back pain, you put them on those backboards for about 30 minutes, and sure enough, by the time you're examining them, they're going to be having back pain, which leads to increased imaging. Patients who may not have needed any X-rays or CTs all of a sudden are getting X-rays and CTs. And so in 2014, the American College of Surgeons and emergency physician folks got together and basically said, we don't really need these the backboards to immobilize. There's not a whole lot of evidence behind it, and it's causing a lot of harm. And now we're asking the same question of C-collars, and there's a lot of controversy surrounding this. Like, do these C-collars actually help prevent the thing that we're hoping they prevent, which is for the patients to not move their spine or not move their neck? And when if you've ever worn one of these C-collars, you can tell that you can move your neck fairly well. And we actually have some fluoroscopic studies. I know they did one at our shop at LA County where they had the residents try these things on and they had them move around, and sure enough, a lot of the residents both were able to be mobile and developed pain that lasted 1 or 2 days. Of course, they were putting them on the backboards as well, but people were developing pain that lasted 1 or 2 days out. So I'm not here saying that we shouldn't be using C-collars at all. I'm just saying that there isn't great evidence for them. I'm not also saying that the absence of evidence doesn't mean that we shouldn't be using them, but there is some significant movement that can occur within these collars. So I think the more important discussion is the patients are going to be coming in with cervical collars, and when they do come in, how can we get them cleared as fast as possible? How do we quickly identify who can be cleared and get them out of that C-collar, especially the ones that don't need it? And if we're going to be doing these C-spine clearances, really the 2 gold standard rules, the clinical decision tools that we should all be using, are either the Nexus criteria that were developed by Jerry Hoffman and his folks over at UCLA in a multi-center trial. This is back in the 90s, or the Canadian C-spine rule that was developed by Ian Steele and his group of researchers. If you're familiar with him, he's worked on a lot of decision tools and rules up in Canada. Both of these rules have really good test characteristics. But if we're going to apply them, it's also really, really important to know some of their limitations. So we'll dissect each of them and unpack each of them individually. Nexus, the cervical X-ray criteria. This was developed not to decide who we should image, but it was to identify patients that were at low enough risk that we could clear and not image. And so we'll go through each of these criteria individually. Who's used Nexus before? Feel comfortable? Okay, so a fair number of people. No posterior midline cervical spine tenderness is the first thing. So palpating along their posterior C-spine. No evidence of intoxication, which can be fairly subjective. Clinical sobriety. I have certain uncles that they could have a lot of drinks and you wouldn't know that they're intoxicated. But is it clinical sobriety or is it the lab number that we're looking at? So really either of those 2 should prevent you from clearing. A normal level of alertness, so somebody can't be altered. No focal neurologic deficits. It's really important in these patients to do a full motor and sensory exam. And then no painful distracting injuries. Now what the heck does that mean? Painful distracting injuries. And we'll talk a little bit about that in the next slide. So if you meet all of these low-risk criteria, that means that you are able to be cleared and do not need to go on to further imaging. Now let's read some of the fine print. Pain on palpation of the posterior midline neck, fairly self-explanatory. Intoxication, some room for interpretation, but generally I have a low threshold for not clearing someone while they're still intoxicated, either clinically or by lab numbers. Altered, self-explanatory. Focal neurodeficit, self-explanatory. Let's focus a little bit on painful distracting injuries. The Nexus investigators admittedly had said that this should be up to clinician discretion. And there is a lot of subjectivity to this. You have certain patients that'll come in and they'll have a finger sprain, and that will be distracting for them. And other people that have, a huge laceration through half their arm and are just sitting there being okay. So definitely long bone fractures, I think we can all agree, open fractures, large lacerations, things like that. But everything else is up to clinician judgment. So just know that that is a slight limitation and that we don't have a definitive definition on what that means. The Canadian C-spine rule now, what I love about Nexus is its simplicity. There's 5 criteria, and if those 5 criteria are met, no imaging. The Canadian C-spine rule, you almost need to go plug it into MedCalc or some app or something to make sure you've hit everything right. But the 3 things that are major criteria for so first of all, you need to have some form of neck pain to enter this algorithm. So you have neck pain after trauma, you enter this, and now if you're either at or over 65, you have a dangerous mechanism, which is defined in that box at the bottom right there, or there's numbness or neurologic problems in the extremities. All of that necessitates both spinal immobilization and likely you'd be pursuing imaging. Now, one of the interesting things is in Nexus, there is no talk about mechanism, and there is no criteria on age. Subsequent studies have looked at Nexus, particularly in this age group over 65 years old. And they weren't able to find the same sensitivities that the original Nexus investigators had found, which was negative predictive value of up to close to 100%. And when you apply the Nexus rules to the greater than 65-year-old population, the sensitivities tend to drop below 90%. So which one should we be using? Should we be using Nexus? Should we be using the Canadian C-spine rules? Should we be using some combination of the two? This is a little survey on where people are using Nexus in Canada versus America, and no surprise, Nexus is more widely adopted in America. Canadian C-spine rules are more widely adopted in Canada. My personal practice, and based on the things that I've seen missed, I use Nexus, and I do incorporate a little bit of the age and dangerous mechanism. If I have somebody who got thrown off a horse, torpedoed down with their head first, and they're telling me they don't have neck pain, I'm scanning that person. And some of these people that are age 67, 68, 69, 70, some of these brittle necks, they take a fall, and even if it's ground level, I've seen a couple of those missed as well. This is all anecdotal. And there's no great study that's been done that's shown like the combination of these 2 rules, right? So I think you are pretty well protected if you use Nexus or the Canadian C-spine rules. Just understand the limitations and consider having a little bit more suspicion in the older populations or people with really bad mechanisms, especially like axial loads, diving injuries and whatnot. This is a C-spine clearance protocol at one of the local hospitals, I believe in Canada, that was inserted in here. You can take a look and see how that compares to your spinal pathways. I'm going to focus a little bit on the pediatric C-spine. Can you apply Nexus to the pediatric C-spine? Can you apply the Canadian C-spine rules to pediatrics? So I'll tell you this, the Canadian C-spine rules were not, the kids were excluded from that study, so Canadian C-spine rules should not be used for kids. Nexus, actually, they enrolled about 34,000 patients in their original derivation validation studies. And of those 34,000, they did enroll kids, but only about 2% were less than 8 years old. And there were almost no patients that were less than 2 years old. So I would be very weary of applying Nexus to any child less than 2 years of age. Possibly in the 2-year to 8-year-old range. I think that we can more safely apply Nexus to the 8 to 9-year-old and above range. So where does that leave us? A lot of studies have been done looking at sort of risk factors for pediatrics. And what are the things that are positively predictive of a child having a C-spine injury? Do children tend to get bad C-spine injuries is the first question. They don't. It's a pretty rare thing for a child to get a C-spine injury. Less than 1% of all C-spine blunt traumas will result in a clinically significant C-spine injury in a child. So there, in and of itself, we know that it's a rare entity, but of course none of us want to miss a C-spine injury in a child. And so the P. Karn group and other investigators have looked at this, and I'm just going to share with you some of the high-risk features that may prompt you to go ahead and image a pediatric C-spine. Neurologic deficits, altered mental status, you're imaging the head anyway, you should probably be imaging the C-spine. Those are all scenarios where the neck should probably be imaged. The other things that have been found to be positively associated are high-speed MVAs, particularly in patients that are unrestrained. These car seats are remarkable. I have yet to see a child that's been properly restrained in a car seat in an MVA that wasn't a crazy MVA, you know, something that was going 80 miles per hour and flew off a cliff, in a child to have a bad C-spine injury. So a well-restrained pediatric patient in a MVA is probably safe unless that MVA was so bad, you know, there were fatalities, people were injected, and that kind of thing. The other sort of mechanisms that have been positively associated are axial loading, like diving mechanisms, things like that, or patients that are at high risk, such as Down syndrome, ankylosing spondylitis. Those types of patients that have baseline pathology in their neck are at higher risk of having cervical spine injuries. And then a patient who just has so much pain that they're literally having torticollis. It's hard to imagine not imaging a child's neck where their neck is just stuck in one direction and they can't move it at all. So again, the studies aren't as well validated in kids. We don't have big Nexus 34,000 patient registries or like we had for Canadian C-spine, but there are some positively predictive things for kids to prompt you to consider imaging. Now, what type of imaging do we get for children? We can start with X-rays, plain films. You can imagine we're going to be talking about plain films in adults. Plain films in children, it's really hard to get the odontoid view. AP lateral fine, but the open mouth odontoid view in like a 1-year-old is going to be pretty tough. So X-rays are an okay place to start. And then the question becomes, what do you do next if the X-rays are negative? In general, if you have access to an MRI where you're working, that tends to be, and you can get the kid sedated enough or cooperative enough to go to the MRI, that tends to be a pretty good progression of imaging. Get the X-rays. If you're still concerned, you can follow up with MRI. The question becomes, what do we do when do we CT these kids? Do we not CT these kids? And we were just having a couple conversation amongst the group here and some of you providers about doing limited radiation CT scans in kids. Where do kids get the majority of their C-spine injuries? Up high or down low? Up high. The children have large heads, their fulcrum is pretty high, so the majority of C-spine injuries in children are at the C1, C2 level. And so some places, it became in vogue for a little while for certain places to image only a limited part of the children's necks, which would be sort of like a limited C1, C2, maybe C3 scan to avoid radiating a child's thyroid. We have stopped doing that when we decide now to get a CT scan of the neck, because it does miss some lower C-spine injuries. We just end up doing the whole CT of the whole C-spine. But for me, if I have the option, I try to go X-ray and then to MRI in these children and try to skip the CT altogether for children. CT versus plain cervical X-ray. This is still an issue of debate now amongst adults. What test is better for identifying clinically significant C-spine fractures? Obviously, it's the CT. The CT has better resolution. It's going to pick things up better. When you talk to our trauma surgeons over at LA County, they have just stopped asking for cervical spine X-rays. It's CT pretty much most of the time. But is that the right thing? Is it not the right thing? This is a question of much debate. The X-rays are less sensitive. For me, the one time I'm using X-rays, cervical spine X-rays, is somebody that I have a very, very low suspicion, but they happen to screen positive for something on, on the Nexus criteria or something. They have a little bit of like pain in their midline cervical, but like the mechanism was so minor that I can't clear them, but I'm just going to get the X-ray and clear them that way rather than expose them to an entire CT scan. That's the time that I use it. Now, what are the downsides of X-rays? The downsides, when I was a resident, we were getting X-rays of the C-spines all the time. And so we were pretty good at reading them. And they got done pretty well, and it's kind of tech dependent too. Has anyone ever ordered a cervical C-spine X-ray and then had to send them back because it wasn't adequate and then send them back again? Why does that happen? Especially on the lateral, you need to be able to see all the way down to the C7-T1 junction. And then you'll see people getting swimmer's views on those laterals to make sure that you are able to image that properly. And so if you get an inadequate film, say you're only able to see to C7 or to the top of C7, those are the cases that are missed. In some of the big San Diego trauma registries, the patients that were missed the most were patients who were either intoxicated or had inadequate films of their cervical spine. So if you're going to use cervical spine X-rays, you have to make absolutely sure that the quality of the films are perfect. Okay? And we'll talk a little bit more about that. Here's some images here. The better resolution is the CT, where you can see in the black and white image. The more blue hueish image, you can see the X-ray of the C-spine. So sort of an approach, if we're going to order the X-rays of the C-spine, we have to have an approach. Another time that you might be getting more X-rays is if it's a resource issue. There are places where you have to ship people out to get CAT scans, and so that might necessitate getting plain films anyway. So the anterior contour line, which is in the front of the vertebra, then you have the posterior contour line at the back of the vertebra, and then finally you have that laminospinal line, which oftentimes you'll see misplaced. It's not the most posterior aspect of the spinous process, it's the most proximal aspect of the spinous process, and all of those lines should align pretty well. After you've aligned all of the bones, now we got to make sure all those views are appropriate. And so like we were talking about having an adequate lateral, so you can see the lateral film here that extends all the way down to C7-T1. You see the AP. What you want to see on the AP film, you're kind of looking at the owl's eyes. You want to see two eyes and sort of the spinous process right there in the middle. And then at the bottom there, you have the open mouth odontoid view. And we'll dive in a little bit more into the odontoid view in a couple slides. Another thing you have to be wary about when you're getting X-rays of the C-spine is the soft tissue anatomy. It's not enough to just look at the bones and the lines, but we also have to look at the soft tissue anatomy. In adults, the mantra is at C2, you should only have 6 millimeters of prevertebral space apparent, and at C6, you can have up to 22 millimeters of prevertebral space present. If it's more than that at C2 or it's more than that at C6, that is indicative of a ligamentous or soft tissue injury that should prompt you to do more advanced imaging. The other thing that's mentioned here is the atlanto-dens interval, 5 millimeters in peds and 3 millimeters in adults. Why in the world would that be? That peds have a bigger interval even though they're smaller people? Well, their bones aren't completely formed yet. And what the atlanto-dens interval is, that atlas is C1, and the axis is C2 that has the dens. So it's the space that you can see right in front on a lateral film. You can see right between C1 and C2, there should be a space of no more than 3 millimeters in adults and 5 millimeters in peds. Finally, the odontoid assessment that we were talking about. Basically, what you need in the odontoid view is pure symmetry. When you're looking at this is C2 and the dens coming up into C1. You can see that you want to have the lateral masses lined up perfectly, so you want to see perfect symmetry there. And then you want to see the spaces between C1 and C2 being symmetric. And then on the lateral aspect, you want to see where the dens is coming up, good symmetry on both sides. If you don't have good symmetry on either side, that is a concern and is concerning for the need to get further advanced imaging. Now, say you do a full neuro exam and you start to find some abnormalities, then that, of course, you would want to get either a CT plus minus an MRI, but we got to know how to do a good neuro exam of the cervical spine. So when we're doing this full neuro exam and neuro assessment, we want to make sure that we're checking for all the nerve roots, C5, C6, C7, C8, T1. So C5, the motor, we're going to go through the motor exam. C5 is the deltoid, C6, bicep, C7, tricep, C8 and T1 have to do with the fingers, so flexion of the fingers and then finger abduction. That's all listed here really nicely in this chart. And then the reflexes are denoted here. You guys remember C3, 4, 5? Those are cervical plexus to keep the diaphragm alive. So if you have a severe C-spine injury, you can have diaphragmatic problems. S2, 3, 4 for fun, keeps the feces off the floor. We're not talking about the C-spine, but there is no real C8 reflex. But if you're going to do reflexes of the cervical spine, basically the biceps are C5, C6, and the triceps are C7. And then there is no real reflex for C8. And then finally, you have the sensory innervation here, which you can reference anytime just to make sure that you've done a good, adequate cervical spine sensory exam on your patients. How about whiplash, cervical strain or cervical sprain? These are patients that have neck pain and have potentially gone through the entire protocol. Say you've imaged them, you've gotten the CT is completely negative, and they're still having pain in their neck. This is most likely whiplash. I'll give the caveat, if someone is having excruciating pain where they can't move their neck whatsoever, or there's still residual neurodeficits after you've done a CT and the CT is negative, I would pursue an MRI. But if you have somebody that has just basic pain, not something that's excruciating, you're going to be diagnosing them most likely with whiplash. And the question is, what do we do for these patients? You can send them home with a soft collar. I would let the patients know that the pain they're having today after the MVA is probably the best it's going to be in the next 2-3 days, unfortunately. In 2 or 3 days, the pain usually gets a lot worse. So it's a good idea to get them loaded on NSAIDs, like have them take NSAIDs around the clock for the next 2-3 days, unless there's a contraindication, to make sure that, and you can give them creams, CBD oil, whatever you want. Some of these, if they come back and they're in really, really bad pain or they're stuck in one position, sometimes a little bit of Valium also helps. But these patients can go home and with good follow-up. How about seatbelt signs of the neck? Is there any correlation between having ecchymosis around your neck and the need to further image? So we were talking about cervical spine bony injuries, which is why we get CTs of the C-spine. But what about vascular injuries? There's a whole body of literature evaluating whether or not somebody has blunt cerebrovascular injury, and are there any criteria or anything to help guide us about like which patients need to get CTAs in these cases. Now, if you see this patient here on the bottom who has ecchymosis along the lateral neck and also has that red mark in front of their neck, which is the worst lesion? What lesion should concern you more? Not because of its color, but its location. Right here, this is where you have your voice box, this is your larynx. When you get these big anterior seatbelt signs, this tends to be more concerning. Now, when you look at the guidelines, have you guys ever heard the East and West trauma guidelines? Well, they're great guidelines to look at if you ever have any questions about what to do in trauma in areas that have limited evidence. But in looking for blunt cerebrovascular injury, there's a set of criteria called the Denver criteria that outline all the reasons that you would need to get a CT angiogram in somebody with blunt cerebrovascular injury. And they're actually pretty explicit about the seatbelt sign, that unless the seatbelt sign in the neck is associated with significant swelling or neurologic deficits, that a seatbelt sign isolated in and of itself does not necessitate getting a CTA on every single patient that has this. So those are good guidelines to cite and look at to help you with your clinical decision making if you are going to avoid CTAing these. If the mechanism is really bad and you're seeing these seatbelt signs, nobody's ever going to fault you for getting a CTA, but there is at least a little bit of guidance from the folks in the East and West trauma guidelines. Cervical rib syndrome, I'm not going to go through this in detail. We just talked about this in the shoulder talk. We did the thoracic outlet syndrome. We talked about the East sign and the Addison sign. So I'm going to skip ahead to cervical disc disease. This is something that you're going to be seeing quite a bit of in patients who have osteoporosis and come in talking about chronic neck pain that may start to slowly progress into muscle wasting and muscle weakness or nerve weakness. In general, in the emergency department, these patients do not need to be MRI'd. But if you have somebody who's having rapidly progressive symptoms, or obviously bowel incontinence, bladder incontinence, or something concerning, or severe muscle weakness that has come on acutely, those patients I would MRI. Otherwise, usually an outpatient referral with pain medications. Cervical stenosis pretty much falls under the same umbrella. This is a degenerative disease that tends to start pushing along the cervical spine. And oftentimes will need referral to neurosurgery. But again, unless the symptoms are rapidly progressive or causing neurologic deficits, usually the MRI does not need to be done in the emergency department. Next up, we have cervical facet syndrome, which is an arthritic syndrome involving the facets. This can actually lead to a lot of cervicogenic type of headaches. So you might get a combination of headaches and neck pain from these cervical facet patients. If you get, and I'm sure everybody has had some of this, where you get somebody saying, oh, my pain is really back here, sort of in the neck, and it's going all the way up and around. And I've tried Tylenol, I've tried Motrin, and it's not really working. One thing that can be helpful in the emergency department is doing these injections, cervical facet injections. There's two general locations that you might be doing these. One is at the level of the occipital nerve, right down at the base of the occiput. You feel the grooves. You can do it by ultrasound guidance, identify where the occipital nerve is, inject about a cc of lidocaine. Some people use steroids in conjunction with that. And then that tends to cross down the fascial plane, and people can get pretty good relief. The other place where you could do it is around C6, C7. And you can look up videos on this. C6, C7, you can do lidocaine injections there. Larry Mellick, if any of you have seen any of his videos, he works over in Georgia. He did a little study on this, doing injections at the level of C6, C7 level, and people had pretty good results. So you get these cervicogenic headache patients that just aren't getting relief in other ways. You might try a injection in the emergency department. We do it in our shop. Tends to work pretty well for a lot of patients. But Rick Pescatori, who has been up here today and I think is speaking tomorrow, does a lot of pain clinic work and would have a lot more expertise in doing this if you have some questions for him. And then lastly, the stinger or the burner. This is the patient that comes to you on a Friday night, high school football player, helmet still on, got hit and experienced severe pain or numbness in one arm. That is a stinger. The way these usually present is somebody has like an axial load or something on their neck or some sort of traction, and then they get a transient neurologic deficit in that arm, some numbness or motor weakness, and it tends to go away pretty quickly. However, if you get somebody who's coming in with bilateral symptoms, that is not just a stinger or a burner. Those, to me, require a little bit more workup and should probably get MRI'd. Patients with persistent symptoms, that could be a disc herniation, that should also be explored further. So very transient symptoms goes away. You can observe for a while and make sure things are getting better. No contact, have them follow up with their PMDD to get cleared to go back to sports or whatever. But they don't need emergent MRI. Bilateral symptoms or symptoms that have not gone away, I would have a little bit more. I would be a bit more aggressive in imaging. All right, and that concludes our segment on C-spines. Thank you.
Thank you, sir. Thank you. All right, I'm back. You guys are doing great, by the way. This is the afternoon of the third day. Usually by this time, everybody's, their heads are down, or what you hear is none and none and none and none. So you guys are doing really great. So thanks for hanging in there. I know I'm the only thing I'm keeping you from is your afternoon break. And this is one of the non-clinical lectures that we're having, and I'm really excited about talking about the clinician collaboration in the emergency department. I'm also excited because it's not often that we get to talk to a room full of docs and PAs and NPs, and actually I'm probably speaking to the choir because it's been my experience, certainly in the last decade, that the three groups have collaborated very well in a team-based atmosphere. But we're going to talk a little bit about that. The collaboration in the emergency room environment is fairly unique because usually physicians are always in the department, are always available. At least that's been my experience in the last decade or so. If you go back 20, 30 years, I worked, anybody ever been to Globe, Arizona? It's a little town in the middle of Arizona that's tied to the mines. We had a little hospital there, and it was staffed with nurses and a PA, and the collaborating physician was actually in the little town. So if you needed the physician, you had to call him in. That rarely happens these days. So we're very fortunate as part of our team, that physicians are always available for us. And the other thing that's interesting, and by the way, that's not always true in other specialties, many times. So I think it's very special for us. The other issue is that PAs and NPs may work with different physicians every shift, getting basically to know the practice styles of many physicians and other folks might be challenging. And the other thing that's important is that departments may have varying policies regarding whether PAs or NPs see selected categories of patients. And all patients, or which patients need to be seen by a physician. I don't see that as much anymore. It used to be that before anybody that came in with a headache, chest pain, a few of the abdominal pain, had to be seen by a physician before they're discharged. I think many of those issues have been resolved, and what we're seeing now is really a lot more team-based care. So how about PAs in emergency medicine? So first of all, I have to fix the slide. There's a typo. The very first one, so fix your slide, where it says 104,459 certified PAs. The 0 and the 4 are transposed. There are actually 140,459 certified PAs in the country. Right now, 267 PA programs, and those programs are continuing to skyrocket up. There are about 40 programs in the queue for accreditation over the next 5 years. Because of that, the number of PAs who graduate each year is getting really close to about 10,000, so 10,000 new grads. Almost 13,000 of those PAs are working in emergency medicine, which has been a big increase since 2015. The median age of PAs in emergency medicine is 38. Almost 60% of the emergency medicine PAs are male, and the specialty exam that's available, it's optional, it's an emergency medicine certificate of added qualification offered by the NCCPA. Oh, by the way, once you publish data, it's inaccurate, right? So these numbers change every day. In terms of NPs, 290,000 currently licensed NPs in the country, over 400 NP programs. Between 7,500 and 9,000 NPs are working in emergency medicine, and the ENP certification is available for those folks. The average age of emergency medicine NP is 47, and 90% of them are women. So let's talk a little bit about collaboration. We've used a lot of terms over the years. Collaboration is one that we sort of fall into, but as you know, as the PAs know, many states now are still using the term supervision, although some states are now changing that to collaboration, or actually changing it to lesser forms of direct interaction. But a successful team really requires trust, communication, evidence-based practice, and feedback and experience. It's been my experience, certainly in emergency medicine, that we've been very fortunate to have those kind of individuals. We'll talk more about that in a minute. The interesting thing is that state laws vary regarding the extent of practice, the level of supervision for PAs and NPs, as well as hospital and physician groups who may independently set their own standards that may be even higher than that in the states. So the onus really is on us to make sure that we understand those different characteristics of state law and laws and hospital bylaws. So here's a great article from a number of years ago. It was a small study, but it's looked at the staffing and the, quote, supervision of PAs and NPs. I'm not going to go through it all, but you can review that. It starts off with the patient type, with the ESI 1 all the way down to 5, and the observation unit and triage. and it looked at, which percentage of those were seen by the PA or the NP, and you can see as you go down that the percentage goes up when you get down to 3 or 4 or 5. Also looks at the supervision requirement, and again, remember that this changes from state to state, but in terms of how much time does a physician actually spend in the practice, in actual supervision or collaboration of the PA or NP, or which patients were actually seen by the PA or NP and not the physician. It's a great thing. It's a very small study. I'm hoping that sometime we'll be able to get some better studies and looking at the actual collaboration that goes on in the emergency department. Another thing from the same study, this is 2018 by the way, looks at the percentage of EDs in which various procedures are performed independently by at least one PA or NP on the staff. That doesn't surprise me. I mean, there are PAs and NPs that feel very, very qualified perhaps to do very complicated suturing, some that do not. But if you look at this, you get the N there and then the percentage. So obviously, almost 100% of PAs, there's somebody on the staff, that NP or PA, that is known for laceration repair, incision and drainage, and splinting without reduction. You can go all the way down, even at the bottom with 2% in terms of thoracentesis. So again, it was an interesting study to look at, give us a sense of what our colleagues are doing out there. Okay, if you look at this from the same study, you're looking at the employed PAs and NPs by the setting, and you see there PA, NP, and then PA and NP in terms of rural, suburban, and urban. And you see that if you're looking at PAs and NPs, mostly 59%, in urban areas. But again, we're seeing both PAs and NPs in almost every area of emergency medicine throughout the country. So what are some of the characteristics of effective team practice? And about 8 years ago, the NCCPA, the National Commission on the Certification of PAs, did a study, went out to 50 practices. Now, this was really based on PA physician practice, but the characteristics are for everyone. And you look, and they found out what was the most effective things they found where the team worked. And they're these. So, and it makes a lot of sense. Shared goals, having the same goals, and years ago, my preceptor, when I was first out of PA school, he said to me, Randy, there's one rule you should remember. I said, what's that? Because don't forget it's about the patient. And so having those shared goals of taking care of patients is extremely important. Clearly defined roles, and this gets to what we were talking about, what the state statutes say about scope of practice, what the hospital policies say, and what the ER group says. Shared knowledge and skills. What I really enjoy about working with NP and physician colleagues is finding out, where their skills are, where their knowledge base is, and where that complements me, where I may be a little weaker. That's very important in a team practice. Effective and timely communication, talking to each other. What a great idea. Actually, these are probably good characteristics of a good marriage, don't you think? I should tell my wife that. Anyway, mutual respect, those kind of things are just, an optimistic, can-do attitudes. These are the kind of things in a team practice that makes it work. So important things I wanted to share with you. It's important because some of these things are embedded in state statutes and some in hospital bylaws in terms of how do we collaborate with our physician colleagues. And there are really 3 levels. And as I said, different states have different ways of doing this. But the first one is prospective supervision. And if I say supervision, transpose that with collaboration or team practice. But this is what we should do prior to seeing the patients, prior to working together. There should be some writing and reviewing assessment and treatment guidelines, establishing when and under what circumstances that physician intervention is required. So that's sort of getting some the rules of the game before we're in the game. The second one is concurrent supervision, and we do this all the time, reviewing patients on a real-time basis based on departmental guidelines or ad hoc. And that is, we have a patient, we have a question, we go to our colleague and say, look, This is what I've got. What do you think? I think I'm going to order a CT, or I want to do that. What do you think? That kind of concurrent collaboration is extremely important. And then just as important is the retrospective collaboration, and that's after the fact review of charts. When I was first out of PA school, my first practice was in a rural family practice clinic. It was me and a doc, and for the first 3 years, every day at the end of the day, we would take the charts and sit down and we'd review both of our charts. He would share what he had that day, I'd share what I had, and we talked about how we could have done things better. That retrospective analysis is extremely important. So, but what do we do? Conflict happens. Again, as I said, if we keep in mind that the interests of the patient are upmost, then we'll never go wrong. Physicians need to understand that they are responsible, for their level of care for all patients in the department. I worked at a hospital in Phoenix probably about 15 years ago. I won't say the name, but we knew that it was a big ER practice, and we knew about 5 physicians who said at the very beginning, I don't want to work with PAs and NPs. So, and so if we were working with that physician on that shift, we had to find somebody else or go without any kind of collaboration. I think those days are behind us, I hope. So department policy should mandate that a physician see any patient that's requested by the PA or NP. Again, because of the responsibility and the scope of practice of the physician, they need to be responsible, for interacting and looking at patients if we want them to do that. Another thing that happens is, when should a physician write a note? Say you ask a physician to see a patient, and this changes from, again, state to state and policy to policy. But you should talk about what the responsibility of the physician is if they also see the patient. Because again, and I know you talked yesterday, I think with Dr. Schufelt about how to avoid lawsuits, and how do you do that. One of the big things is documentation and who sees the patient. So I think if you should have an understanding what the responsibility of both clinicians is in taking care of that patient. Otherwise, you get it in the middle of he said, she said, and lawyers love that. I've unfortunately had an opportunity to be expert witness in many cases, and found out that one of the big problems is communication between providers that see patients together. So, important thing. Okay. Also, in our day and age now, we have different generations working together. You look at this, and you look, whether you're an NP or a PA or a doc, you're in one of these categories. Now, I don't think we have any Gen 2020s in here. If you are, you're a child prodigy, and good for you. But if you look at millennials, 77 through 97, how many of you in here are millennials? There should be a bunch of you. Yeah, so there's a bunch of millennials. If you look at Gen Xers, there's, let's see, I'll get this, 65 to 76. How many Gen Xers in here? A few of you, okay. Boomers, I'm a boomer, that's 46 to 64. Very good. Traditionalists, that's 1900 to 1945. If you can raise your hand, please do it. Okay, well, you sort of get the idea here that we come from different generations, we manage things differently. So, if you're a boomer working with a millennial, or a Gen Xer, working with a boomer, we have different ways of doing things, and it's important that we understand that and we learn to work with one another. Okay, other things that's important to know, and this sort of goes without saying, but you should familiarize with the statutes and the regulations that govern the scope of practice in your state. Now, that makes sense to me. Some states, by the way, require the doc or the NP or the PA to sign a form that they've actually read the statutes. And I'm on the regulatory board in Arizona, and I talked to the docs on the board, and these are guys who are in the know. And I said, have you actually read the statutes? They said, not really. So we have some responsibility to know what the statutes say. And particularly if there's some supervision or collaboration rules or statutes in that state. And then we need to be prepared to present those statutes, rules, and regulations to the physician or the administrative people, to make sure that they know that. One of the issues we find out on the regulatory board is that a lot of clinicians rely on administrators to take care of things for them. It's up to you to make sure when I get my license renewed. It's up to you to know when I should have how many charts should be reviewed by the physician. It's up to you to know, I can go on. And what we find out is things fall through the cracks, but ultimately the responsibility falls on us. And that's when you stand before the regulatory board and you say, not my fault. And they say, that's okay, but it's your responsibility. So I think it's important to know that. Also, review IRS guidelines for employee status versus independent contractor status. There's a lot of checklists that the IRS has that tells you whether you're an independent contractor or whether you're an employee. And again, we need to know where we stand with that, because when the IRS comes after you, it's not fun. So, important things to know. Okay, what about liability insurance? Now, I believe Dr. Schufelt talked about it yesterday, but it's important, again, to find out what type of liability insurance is offered, whether you've got occurrence-based or claims-made, as well as what the limits of liability is in terms of $2 million, $3 million, things like that. And you have to decide which one works better for you. Now, I'll have to say, there's many places where the practice buys insurance, liability insurance, as an add-on for you. I'm talking mostly NPs and PAs now. They buy some add-on insurance called vicarious liability. And what happens is that they pay some extra money for that, and then if the PA or NP is involved in the lawsuit, then it's covered, but the limits of liability are shared. That $2 million, $3 million is shared, not by each provider, but by both providers. So you have to be a little careful. The second thing that's important is if you have malpractice insurance, that you look at the cover sheet and make sure that your name's on it, that it's actually a malpractice policy that covers you. And then determine whether occurrence. Remember, occurrence is a little bit more expensive, but what happens is it follows you. So say you work here and you have occurrence insurance, and then you've moved over here, yet something happened here, but because you have occurrence insurance, you're covered. If you have claims-based insurance, you do something here and you leave, that no longer covers you for that area. So you have to have what's called tail insurance, and that can be really expensive. So you need to find out if you have claims made, find out if your employer will cover the amount of the premiums for the tail insurance to cover you, so that it covers you over here for things that you did over here. So the other thing that's critical, particularly for this discussion we're having here, is that in looking at malpractice cases that I've done over the last 25 years, inadequate collaboration is now becoming one of the most biggest complaints in medical malpractice cases involving PAs and NPs. So, and usually when I say inadequate, most of the cases that we've looked at have actually been absent collaboration. And whose responsibility is that? Well, if you're a member of the team, the whole team is responsible for that kind of collaboration. What we don't want to do is to do everything right, but have things go wrong and then show that we weren't talking with one another as part of the healthcare team. Okay, this is a graph from a MedPro group from a couple of years ago, looking at the frequency and financial severity within specialties. And if you look there, I think on your right, your left, you look at emergency medicine. So the light blue is the total dollars paid, and the dark blue is the claim volume. And so emergency medicine is a fairly large component of that. The other one is radiology. The other one is pediatrics, like that. And you can look at the other ones. So, certainly in emergency medicine, we're in that category where we tend to have higher liability. And remember, we all know that you can do everything right and there's a bad outcome. But more and more issues of malpractice are occurring. I've also noticed in the last 5 years that in cases where I've seen, and most of the time when the plaintiff's attorneys file a malpractice suit, they sue the physician and the PA, or the physician and the NP, or all three, I've found a couple of cases now where somewhere down the road after discovery, they've broken them off and they've taken the physician out of the case, and the PA or NP has now stayed in the case by themselves, and having to, and if hopefully they've had their own malpractice insurance that will cover them, because that way they get their own attorney, and they're the prime responsibility of that attorney. We can talk more about that. Then the last thing before we head off to a break is make sure that you use the resources out there. The PAs, there's great resources with APA and SIMPA, and the NP resources with AANP and AENP. If you're not a member, you should have access to see the resources that they have to support you in your practice in emergency medicine. So that was a lot of information in a short period of time, but I want to make sure you have a few minutes for a break, and we'll see you back after the break. Thank you. 15-minute break. Thank you.
Because we're almost done with the day. So an exciting and fun topic, elbows and forearms. I mean, how much more exciting can you get, right? But we'll talk about some of these common injuries. Some of these, most of these are traumatic injuries, but some common things we see also that are not traumatic, like our overuse syndromes. So we talk about our anatomy of these joints. Just think about the importance of these ligaments and these supporting structures. So here in the elbow itself, the ulnar collateral ligament is really important for stability of this joint. It's what really stabilizes that joint and allows us to have good fluid movement. So if a patient has an injury or we're worried about an injury to the UCL, that can definitely cause some instability to that joint and cause it to be weak and not have a lot of adequate movement. We talk about the base there at the distal forearm, there at the wrist. We have this membrane here that connects these, and one of the things you'll hear when we talk about lower legs, if we haven't already, is that we have this membrane that connects anytime we have the paired bones. So we're talking about the forearm or the lower leg. Anytime those paired bones are there, they're connected in at least two places. And so definitely if I have an injury to one area, I'm more likely to have an injury to another area as well. The forearm itself, we used to talk about these deep versus superficial structures or even having different compartments there that play a role with either flexion or extension. And it's not as common, but since we got multiple layers here of muscle and fascia, this area is at high risk for compartment syndrome also. So anytime I have these complicated fractures, I've got tissue trauma, I've got edema, I've got bleeding, definitely have to have that suspicion this person may be at risk for compartment syndrome. We think about that a lot, mostly with the leg, but definitely the forearm can be a source as well. So we talk about general orthopedic things, and you've heard this before, and you'll hear this again, but anytime we're talking about joint problems, I always make sure we assess the joint above and below, and especially we're talking about imaging, that's really important as well. And we're talking about those paired bones, whether we're talking about the forearm or the lower leg. If I've got these paired bones, making sure I see all of those joints. Because if I have an injury to one, I'm more likely to have an injury to the other. Really good rules for any type of orthopedic problem is get a good assessment of their neurovascular status before and after any manipulation, and definitely before we discharge those home. Because if they have a decreased pulse or they have some decreased movement, I would like to know that it's there before I started manipulation versus afterwards. So making sure we get that good assessment before and after and document that very well. If we're doing some immobilization, have we taken precaution to prevent further injury? Have I addressed any skin injuries that's underneath that? Have I done adequate padding? Do I do good education of the patient of understanding of how to take care of this splint or this cast properly? For most things that we do, we're going to use splints initially to allow for swelling, and that reduces the risk for things like compartment syndrome. But making sure we do really good education of the patient or whomever the responsible person is going to be to making sure they take care of this properly. And definitely, anytime I'm concerned about some type of neurovascular problem, let's get our experts involved sooner versus later. Whether we can assess this with physical assessment or maybe using Doppler, or we're having to go to advanced imaging like CTA, get an idea of those and address these sooner versus later. So the elbow, commonly injured areas, so that a lot with falls, blunt trauma, but who needs an x-ray of this? And one thing they've looked at is, can we kind of reduce the number of imaging and hopefully reduce length of stay as well? But if I've got an injury to the elbow, there to the olecranon, and somebody can lock that in full extension, and that doesn't give them severe pain, and they're able to do that, most of those patients probably do not need any imaging of the elbow, of the olecranon, or that proximal area there, the radius. So something maybe to use in practice to kind of get an idea, where are they point tenderness at? Is it right there over the olecranon, or is it somewhere else there in the joint space? But if they can lock that in full extension, most of those patients probably do not need any imaging and supportive care. Look at our fat pads. We talk about fat pads a lot with our pediatric patients, but even sometimes these can help us with adults as well. So anterior fat pads we'll sometimes see, and those can be small and be normal, but posterior fat pads, we always consider those to be abnormal. And we'll look at some images of these in just a moment, but definitely if I'm seeing a large fat pad or I'm seeing that posterior fat pad, I'm really concerned about some type of occult fracture. Maybe some type of very small fracture that I can't see well in imaging, but definitely if we were to re-image them later or get advanced imaging, those do show up. So as we can see here, I've got a nice normal anterior fat pad. It's just a little bit there outside that joint, but it's not huge. But if I look on the other side, I've got the cell sign. I've got that big anterior fat pad sticking out, but also that posterior fat pad. And even though this may be difficult to see, if you look, I do have a very subtle fracture there. But if you're seeing those large anterior or you're seeing any posterior, think about this person may have a fracture that I can't see. Get another view. And usually if we're ever in concern and you don't have the resources, you're never wrong to immobilize someone and then have them come back for re-imaging with you or somewhere else in a couple of days, as long as we do good education and we talk about the risks and benefits of that immobilization. So radial head fractures, those are definitely common in our adults. We see those a lot, especially with our Fuchs injuries. So that fallen, outstretched hand, we see a lot of distal fractures with that, but also a lot of proximal fractures as well. These definitely can be problematic, and especially if I'm seeing large fat pads, whether it's the big anterior or even a small posterior fat pad, that's really concerned that I have a fracture there. So get a good assessment. Where are they tender at? How's their range of motion? And one thing we have to worry about with any of these joints where I have a large vascular bundle flow through is, do they have risk for neurovascular injury? How's their sensation? How's their movement? Most of these can be managed minorly. Now, if they have a very large fracture, this is based on the Mason classification system, probably a class 1 or a class 2. Those require nothing but supportive care. But if they have a pretty unstable class 3 or up to a class 4, those almost always require orthopedic intervention and probably open reduction and internal fixation. If you have the access, share these images with your orthopedist, get their opinion, and then set that patient up for care, whether it's going to be just split and immobilized there in the ED. Some of these may just require just a sling and nothing else if it's a class 1. But again, looking at your imaging, what do I see? Get a different view. There's all these wonderful memes of looking at stuff in different views, but for most of these joints, we want those 2 or 3 views, because what I see this way may look totally different if I look this way or a little bit oblique. In kids especially, if you're not really certain, think about the importance of comparison views. I get that left elbow, I don't know if that's normal or not, then let's get a right elbow. Risk of radiation is pretty low with plain films, and definitely sometimes those comparison views can be really helpful to say, hey, is this a normal variant for this patient, or is this their normal physiology? We'll talk about the growth plates here in a moment, but those can sometimes also get confusing for some people, especially if we haven't looked at a lot of pediatric films. Our supracondylar fractures, those are the most common there in our kids. Those are also really associated with a lot of our Fuchs-type injuries. We also see this a lot with a lot of playground injuries, monkey bars, swings, and they cause that blunt trauma-type injury. One thing that we can help us with these is actually doing our anterior humeral line test. And we can see here, if we line up this x-ray and we're looking at, if we line up the anterior humeral line, it should go through the middle third of the capitellum. So this tells me I've got nice normal anatomy, nothing here has been displaced. So that really helps me look for those occult injuries. So let's put that over an x-ray. Anterior line goes straight through the middle of the capitellum. There's no displacement there. It gives me that nice clean 90 degrees. Doubtful there's anything there that I can't see that's occult. But let's see what happens when we actually see this and an injury and look there. There's my humeral line, and it does not go through the middle third. It actually goes to the anterior third. And this one pretty easy stands out because it's displaced, but also got that huge posterior fat pad as well. So look for those. Sometimes those fractures can be very subtle, but we look for other things that tell us that, like the fat pad, or hey, that doesn't have that nice normal 90-degree turn that it's supposed to have. So it's kind of a table to kind of help you with these elbow injuries, pediatric versus adult things to consider. As I mentioned, fat pads may be helpful or may not. All posterior fat pads are abnormal. We don't see them that much in adults, but sometimes it's occasionally there, and you're like, oh, look, there's a pretty little fat pad sticking out. But I can look closer, and now that most of us have electronic, we can really magnify these images, and then get down there and say, well, there it is, or reverse your contrast and be able to look for those. But if in doubt, talk to your experts. Get that overread. I love being able to have my overreads every day. If I don't have that, I'm in a low-resource area. Most of these patients are going to be totally appropriate to immobilize them, whether that's a splint and a sling, and then have them follow back up for recheck, or maybe bring them back and re-image them in another week, and that's when you'll start seeing changes from that healing. Epicondylar fracture is also very common there in our pediatric patients. This uses the Gartland classification system. Usually the more minor the injury is, usually less severe treatment, but if they get up to the class 3, class 4, those almost require operative intervention as well. These definitely may involve some Salter-Harris type injuries we'll talk about in just a moment. They're involved in the growth plate. The big thing about these is we don't usually see fat pad signs. So I can look at the bones. What do I see? How is their movement? And definitely if I'm in doubt and this person has pain with range of motion, or especially if they have point tenderness in one specific area, look at that really closely. If I am concerned, always appropriate for them to follow up for repeat imaging in a week or two, or at least to have good follow-up care. So are growth plates. And our mnemonic here is Crito. And if we haven't looked at a lot of pediatric films, these can sometimes be confusing. I know when I started out and I'm looking like, oh, look at all, oh, wait, no, that's not a fracture. So typically if it's nice and smooth and it looks very even, those tend to be our growth plates. Most of your fractures are going to have some irregularity to them, whether it's some jaggedness or some offset to that center of that line, but look for those. And typically here by Crito, we start closing from age 1 all the way up. But this is when the comparison views may be also very helpful. If I have that, get an x-ray of both those extremities and look at them. Do they look almost identical? Then that's probably their growth plate. Or sometimes it's a normal variant that we hear about and it's not actually a fracture. But what do we see on clinical exam? How is their range of motion? Do they have full range of motion with a little bit of pain? Okay. Or they have very limited range of motion because they have so much pain. And those are definitely the ones that I'm more concerned about. We talk about dislocations. We talked about shoulder dislocations earlier. P's is my mnemonic here. Elbows are almost posterior and shoulders are almost always anterior. So posterior elbow, anterior shoulder, P's. But we see these a lot with those Fuchs type injuries as well. They fall in that outstretched hand. They get that blunt trauma that forces that out of its space. Very painful, limited range of motion. Just like with shoulders, talk about knees and stuff later, we have to worry about that risk for neurovascular injury. Elbows do have a high risk for injury of the brachial artery because when we displace that structure, move it out of its normal joint space, we definitely can tear or put more tension on those vessels. On these, they're usually pretty easy to reduce. There's still the debate, do I image them before, or I image them after? I do both. Most are going to probably reduce these and then image them later just to make sure there's no occult fracture. If I'm really concerned about a fracture initially, that might be a reason I might want to image before I reduce it. Otherwise, let's reduce it sooner versus later to reduce that risk of neurovascular injury. And then let's just image it later after the reduction for resolution of that, plus make sure there's no fracture underlying structures. Most of these patients with a simple dislocation, all they need is a sling for a couple of days. They don't need any more mobilization. Because most of these people, once I get them reduced, I'm going to limit their movement for a day or two, but then really start doing some normal range of motion activities just to strengthen that area and keep it from being at high risk for further injury. Olecranon bursitis, one of our overuse things that we'll sometimes see. These usually are not associated with anything penetrating to that joint space or to that olecranon sac itself, but occasionally we'll run into that. But this is seen a lot with people that do a lot of work and they're down on their elbows, so carpet layers. People do a lot of manual labor and they're moving around on their elbows. Students, sometimes they spend a lot of time on their stomach studying and reading, but they got irritation there in that area. This guy here has a nice little bursitis going on. Just that bursal sac gets inflamed. Maybe it's very swollen, very tender. If it's very red or very hot to the touch, then I'm more concerned about this could be infectious. So can I get a history? Was there concern they might have a penetration injury? They were crawling around and felt something like it stuck them there. Then we'll sometimes find a foreign body there. But for the most part, imaging here isn't helpful. Sometimes if you do image them, you might see that little calcium deposit there as that sac has become just constantly inflamed and has a little calcification to it. But treatment here usually is just very supportive. We can try NSAIDs, we might have to go to steroids, but most of these require nothing else than supportive care. If we are concerned about infection, if it's really red, it's really swollen, really tender, this might benefit from actually doing a gram stain, actually anesthetizing that area, drawing out some bursal fluid and sending it off for culture just to see if it is. Typically, it's our usual pathogens, our skin stuff, so staph and strep. Occasionally, we're now seeing some more things with MRSA as well. But typically treat those pathogens if we're worried about that. These might benefit from injection of a local anesthetic plus or minus some corticosteroids. But there's no infection, it's purely supportive care. Looking at a couple of the studies that actually doing the anti-inflammatory injection with some corticosteroids may help improvement, but overall there's really no change in course. So those can be kind of painful. So depending on your practice, depending on your patients, they may or may not benefit from that, but using their supportive oral therapies just as well. So we can see here this nice non-inflamed there on your right versus that red inflamed that we see there on the left. And there's just that x-ray image showing that little calcification. Usually, unless I'm really worried about some type of foreign object getting stuck up in there, there's really no need for imaging. But if you definitely had that history that makes you concerning, go and look for that. Maybe they have a little tack or a little something that got stuck up in that area, and that's what's caused the inflammation and, sometimes the infection. So our nursemaids, definitely our most common subluxation we run into. The old adage, typically the kid got pulled up by the arm and it caused a slight little dislocation there of the radial head. It kind of slips out of that space. This is very common, 1, 2, 3-year-olds. Usually by age 5, that ligament's more strong and more sturdy, and this is less likely to happen. Classic presentation is the kid comes in, they're neglecting that arm, they're not using it, they have pain with movement, pain with any type of range of motion with it. Treatment is usually very simple, usually does not require any imaging unless I'm worried about something else. So try to get a good history. Did something grab that kid by the arm? Did someone grab it? Or they actually have blunt trauma and actually fell on it? Educate the parents. And in some scenarios, if we have to reduce this, the parents might be open to learning how to reduce it the next time on their own. But usually after about age 4, by age 5, their incidence is dramatically reduced. But just a little slight subluxation there of the radial head. That ligament gets stuck and gets caught out of place. Usually by age 5, it's nice and sturdy and strong and holds it right there in the right spot. For years, we would do that classic supination and flexion. That was pretty painful, but it worked. The whole goal there is to kind of hold your finger or your thumb right there over the radial head and feel for that click as you rotate. And probably looking at most of the studies now and probably for most of our practice, the hyperpronation technique as you see here tends to be as effective or more effective and probably is less painful. So to stabilize the joint, stabilize the radial head with your fingers or thumb and hold it, and then take their hand and hyperprognate it as you're supporting it, and you'll usually feel that click. And that usually results in almost improvement in their symptoms, and almost quickly they start using it. Most kids within 5 minutes are going to be using that arm very freely and back to normal. If you don't feel that click, then you may not have got that reduced. Try again. Typically, we won't do any imaging unless we don't get that click, or they don't start using that pretty spontaneously, or the history doesn't support a nursemaid. Maybe they had direct trauma to that area. So some other specific fractures we run into, these are pretty rare, the Monteggi fracture and the Galeazzi fracture. These involve a fracture and a dislocation. So MUGGER is our acronym here. These almost always require surgical intervention since they have a fracture and a dislocation. They're usually blunt force trauma. Probably less than 5% of our forearm injuries involve one of these two. But definitely if you see one of these, you've got the fracture and the dislocation, they have a higher incidence of a neurovascular injury as well. So I want to get orthopedics involved as soon as possible. If I need to reduce that dislocation, let's reduce it and let's immobilize it to prevent the risk of further neurovascular injury. But if you run across one of these, high risk injury there, and again, this is that paired bone phenomenon. So if I see one injury, always look for the second injury because a lot of them will have both. Colles fracture, definitely some of our common forearm fractures we see. Again, almost always that Fuchs injury. To be a true Colles fracture, I've got to have fracture both of the distal radius and the ulnar styloid. So again, look for both those injuries. If there's one injury, there's commonly going to be two. Look both proximally and distal to make sure I've ruled those out. Occasionally we'll see just a radial fracture or just an ulnar fracture. But to be a classic textbook Colles, I've got to have both those fractures there. These usually reduce very well and usually recover very well. These can be done with procedural sedation. Sometimes these work really well with hematoma blocks if you're able to do those. And you don't have to do procedural sedation. You just got to have time and equipment. But if I can go in there and do a hematoma block, inject that fracture site with some lidocaine or marcaine, let it set up very well, this patient may require nothing else, and we can reduce it pretty easily. So a Colles versus a Smith's. So that Colles fracture I mentioned, that's typically that outstretched hand, where a Smith's fracture is different. That's falling backwards on a flexed hand. And that tends to have a very similar mechanism, but a different injury pattern. So just get the history. What did actually happen? Did they fall and go straight forward? Or is it one of those where they landed backwards? And that's not a Colles, that's a reverse Colles, or sometimes referred to as a Smith's. So what do we see distally? Where's their range of motion? What's their movement? What's their sensation? How are those distal pulses? Again, if I see one injury, always look for the other one, because a lot of times if they have one injury, they'll have two. If they've got a significant interarticular fracture, that's definitely something we want to make sure orthopedics involved. If it's got a base fracture there at the end plates, we want to get ortho involved sooner versus later. We want to definitely make sure they have good resolution and good healing for those kids so it doesn't impair bone growth. If they're on that Salter-Harris frequency, what is it? And make sure orthopedics knows, hey, this actually is a Salter-Harris 1 or 2, so they have close follow-up. So where are we at with that growth plate? Is it nice just that right there, just a little bit of a slip, or is it straight, or is it above, or is it low, or is it through both, or is it that ram type injury? So whether it's a wrist, a forearm, it's the other joints, what's that classification? I have to look these up. I don't remember them. So most of the time, radiologists are really good at telling me what it is, but ortho wants to know what that is, especially if you're having to describe it to them versus giving them that picture. Most of us now have easy access to our digital, so we can look at it. Sometimes they want you to text it to them. That may or may not be HIPAA compliant based on your hospital policies. But how do they describe it? Where is it in that fracture? But definitely if it involves this joint, involves this growth plate, that needs closer follow-up and observations. We make sure we get proper healing so it doesn't impair bone growth with that kid. So our most common here is the Salter-Harris 2. As you can see, it's right there above the epiphysis, where that ram-type injury has more of that crush-type jamming injury, and then definitely that lower one there below the epiphysis. But all these are concerning for impairment of bone growth if it involves that growth plate. And then lastly are overuse syndromes. So if I've got this typical pain there with the lateral or the medial epicondylitis, usually from overgrowth, overuse, we're talking about tenderness or golfer's elbow. Usually they have that point tenderness, but also they have pain with certain movements or range of motion. And then whether they're rotating in or they're rotating out. Most of these patients, rest is really all they need. We can try anti-inflammatories. There are some devices, as you can see here, these splints that kind of put some compression on that. What we really need this patient to understand is this is from whatever activity they're doing. If they can modify how they do that activity, that tends to reduce the incidence of these problems. And then lastly, Dequervan's tenosynovitis. Get some pain and tenderness right here around the radial base. This sees a lot, especially with pregnancy, because of water gain that we'll sometimes see. And the classic thing is we'll do the Finkelstein test. We want them to do some ulnar deviation, as you see here in this picture. And they do that ulnar deviation. It gives them increased pain. And if you can, feel and palpate over that area. And a lot of times as they do that ulnar deviation, you'll feel some crepitus. And that's just inflammation there of that tendon sheath. This can be supported usually with some immobilization devices, but definitely may be beneficial for rest and some NSAIDs as well. See it a lot, as I mentioned, in pregnancy. That usually goes away after delivery, but definitely this is just some of our common overuse syndromes. If patients can understand why they have it, they can modify their activities. That tends to reduce the incidence and hopefully the severity. But definitely they have more of these problems. Trying to get them in to see hand or whatever specially manages those may be able to do some other options. All right, thank you very much.
Am I on? Okay. All right, in the home stretch. So actually this is my favorite lecture is one on asthma, and we have about 30 minutes to talk about asthma and chronic obstructive pulmonary disease, which we could probably spend 6 hours on. So we're gonna go fast and furious about some important characteristics both of asthma and COPD. So the good thing about asthma, in my mind, is it's one of those conditions where, for the most part, somebody comes into the emergency center with having an exacerbation of their asthma. Usually we can do something about it. And there's a good chance that by the time that they leave, they're breathing better and they've got the treatment they need for some long-term treatment of their asthma. That's pretty good stuff. Although asthma continues to be a really significant issue, not only in this country but around the world. It says here in the U.S. alone, exacerbations of asthma lead to at least 1.7 million emergency department visits and 200,000 hospitalizations back in 2016. And it costs a society a huge amount of money in taking care of these asthma exacerbations. 5 times that of an office-based visit. And so in this context, the U.S. government has identified improving asthma care reducing asthma-related ED visits and reducing hospitalizations as a key health policy objective for obvious reasons. So the definition of asthma is a chronic inflammatory disorder associated with a variable airflow obstruction and hyperresponsiveness. The exacerbation refers to severe episodes of worsening disease characterized by cough, shortness of breath, wheezing, and chest tightness. The pathophysiology is important to know. There are really two components of asthma. The early component, which happens within seconds, within minutes, when bronchospasm occurs, sympathetic and cholinergic control, usually because of a trigger. What's the most common trigger for asthma? One might say smoking. Well, that could be. But the most common trigger that we find for asthma is actually a virus. And so that causes the initial trigger. It occurs within minutes, and we get the bronchospasm and those symptoms. And then we get the second phase of that, which is the late phase, can occur from hours to days. And that's where we get the inflammation in the bronchi, the hyperresponsiveness, the microvascular leakage, the airway edema, the tenacious secretions, the mucus plugging, things that just plug up the bronchi and makes it very, very difficult for the patient to breathe. So that's the pathophysiology. Intervention, the best strategy, is early recognition. Well, the best strategy is appropriate education and appropriate care for early intervention. But early recognition of that is before the attack becomes severe and potentially life-threatening is it. So the goals of acute therapy for that initial component of asthma is reversal of bronchospasm and reversal of inflammation. And the goal of chronic therapy is to modulate the immune response to that. So getting a good history, and we know these things don't happen lockstep. Somebody walks into the emergency room having a great deal of discomfort, breathing problems. We don't do like we do with a number of patients where you sit down and take a history and then do a physical exam. These things occur at the same time. So you may be getting vital signs and hooking up a small volume nebulizer at the same time you're talking to the patient, or in the case of kids, talking to the parent, about how the presentation and getting a good history in terms of the duration of the episode, how long it's been going on, the use of steroids in the past and beta agonists. We'll talk about that in a minute. Other types of associated symptoms, whether they got a fever, pain. We're trying to determine not only the trigger, but if there's any concomitant diseases going on. History of hospitalization, intubation, and ED visits are critical. We'll show a graph in a minute on that. And the age at the onset of asthma and other potentially complicating illnesses, particularly heart disease and diabetes. So we're getting that history with that patient coming into the emergency center, depending on what level of discomfort that they're at. So it's important also to know what the risk factors for death are from asthma. And I'm not going to read this whole list, but this table really shows them. And it has a lot to do with what's happened, in the past year. Have they had a number of exacerbations? Have they had to have epinephrine? Have they been hospitalized? How many, canisters, of the albuterol have they had to use? The rescue medication, getting a good social history and the comorbidities. These are important things because the risk factors, if these are in the information that we get from the patient, this increases the risk for death in the emergency room. So we need to know that information. Also looking at the differential diagnosis in this slide in terms of making sure both in children and adults that we've gone through the differential to make sure that we're not missing anything that's masked by by asthma. For instance, what we're seeing a lot more in the last 10 years is a condition called vocal cord dysfunction. Anybody seen vocal cord dysfunction? It mimics asthma, and it's a dysfunction of the vocal cord, that actually the vocal cord starts closing when they breathe in. So it's a dysfunction, and it mimics asthma. And the only way that you can actually determine that from asthma is actually doing a spirometry test, and you get a different loop if you have vocal cord dysfunction. So one of those things, and there's some great literature out there now in terms of causes and treatment for vocal cord dysfunction. We could spend a lot of time just on that. The examination is important. Again, examining for and documenting things in the medical record. Speech pattern, are they able to speak in full sentences? The describing the wheezes and the movement, the inspiratory to expiratory ratio. Determining if they have what's called a silent chest. That's where there's no movement. They've got so much, so we're into the second stage of asthma where you're getting those tenacious secretions. If you've ever seen I've seen it a lot in adolescents, where they're bent over and they just can't breathe, get in or out, and you actually listen to the lungs and you can't hear anything. Why? Because we're not getting any air movement, and that's serious. So, it could be a very severe episode. I'll talk in a minute. I hope I remember to talk about some things to do for that. The respiratory rate is important. Looking at the retractions, the use of accessory muscles, those are things to document. Now, if the patient comes in, we're seeing diaphoresis, cyanosis, or a decreased mental status, this means we're further down the road than we want to be. This indicates severe disease, and we're going to have to take some more immediate steps than we would otherwise. So we have to document that. So evaluation, obviously, the pulse ox now is almost like another vital sign. Everywhere you go, you walk in, I don't care if it's your family practice clinic or wherever, first thing they do besides your blood pressure and your pulse is they put the pulse ox on, and that's good. That's going to give you a sense, of the oximetry. The other thing that's really important is measurement of pulmonary function. Well, how do you do that? In the best of all worlds, you have a spirometer machine in your emergency center, and someone that knows how to use it and run it. That may or may not be the case in your emergency center, but the best way is to be able to document, the FEV1 or the peak flow, and you can do that with just a peak flow meter. If you have those, just the meter, have them blow in, and you can look at the green, yellow, and red areas. But it's important to when you can, is to get a baseline of where they're at in terms of that FEV1 or the peak flow, and that's going to determine your response to your therapy. So rarely are we going to be considering blood gases unless they're coming in and having the cyanosis and things we talked about a minute ago. Chest X-rays are rarely useful unless once you're doing an exam you hear a lot of rales, or there's a fever or things or absent breath sounds. Those kind of things are important to do. Otherwise, it's rarely done. Labs are rarely useful. So what does that mean? That means the most important thing that's going to determine our treatment of this patient is serial measurements of their pulse ox and their pulmonary function. So those are important things to do. And again, if it's just a peak flow meter, you can still gauge where they are now, where they are after a small volume nebulizer treatment, and another one down an hour. So it's important to gauge that to determine if they're getting better, even if it's slow, or if they're not. So here are the classifications for asthma severity, and it shows you the signs and symptoms and the peak flow or the FEV1 and the course, usually from mild to moderate to severe to life-threatening. If you get an FEV1 of 70 or higher, that's a mild asthma severity, and a good sign that we can actually get something done and get them treated and breathing better before they get out. And you can see the rest. So it's really important that you figure out, how to monitor that PEF or the FEV1. Okay. Other types of general asthma treatment. If they're hypoxic, obviously we got to give them oxygen. If the mild to moderate exacerbations can be treated with an inhaled and oral medications, we need to do that early on. Severe patients are going to need more definitive care, including IV access, monitoring, things like that. The NHLBI recommends all patients receive serial measurements of lung function to assess treatment effect. So if you remember anything we talked about in this lecture, this is an important component, is to determine, besides looking at the patient, what they look like, what the color of their skin is, and the symptoms they're having, being able to do that serial measurement is extremely important. Okay. The initial treatment, usually those short-acting inhaled beta agonists, albuterol is the most common, is the first-line therapy for all patients. Nebulized albuterol, you 2.5 to 5 milligrams, put it in the small volume nebulizer, and start doing the SVM treatment. Number of ways in doing that: you can do serial treatments depending on how the patient's doing, and we've actually seen patients that had to be on continuous SVN for moderate and severely ill patients. But usually intermittent, every 20 minutes, over 1 to 4 hours if the patient's having some mild symptoms. So once again, determining the pulse ox and the serial FEV1 or PEF between those is going to give you an idea of what to do. Okay. Interesting note, let's say you don't have a small volume nebulizer, but everybody does. But, handheld nebulizers are really equivalent to the metered dose inhaler plus a spacer. So if you just have the metered dose inhaler and a spacer, and remember the spacer is that cardboard cone, or it can be a plastic thing, and when the patients do the albuterol treatment, it helps make sure it gets the albuterol to where it's supposed to be. 4 to 8 puffs every 20 minutes for 3 doses, is pretty compatible to using the small volume nebulizer. It's more cost effective, more rapid onset, and fewer side effects than nebulizers. And it allows assessment of inhaler technique, which is hugely important, particularly with kids. But I believe that most of us probably use a small volume nebulizer because it's handy and it's something we use a lot. Anticholinergic treatment. This is synergistic with the beta agonists in acute asthma with no added side effects, which is really good. Don't use it as a first line of choice, but it should be used if the patient's not getting any better. And it's also associated with lower admission rates and greater improvement in FEV1. And the most common drug is the ipratropium bromide, 0.5 milligrams every 20 minutes for 3 doses. You can add it in the small volume nebulizer. So you take that and the albuterol, you can actually put it in together. Or you can use the 4 to 8 puffs of the MDI and spacer instead in mild cases if you want to. Other types of beta agonists, levalbuterol, it's more expensive. There's not a lot of data on it, although we do have some anecdotal data that it works maybe a little bit better in children, where it's obviously used more commonly. The use of epinephrine, there's the dosage there, and even to the point of terbutaline, again, based on your serial evaluation of the patient. Okay, what about systemic corticosteroids in asthma? Many feel, and I agree, that it's really underutilized. We do know that it reduces the rate of relapse and may decrease the need for admission. So we recommend early use. Sometimes within the first hour of admission to the ER is a critical component. And most of these are done orally, and we find that oral is just as effective as parenterally. And the specific kind of steroid is really not important. So we're talking about, prednisone, the equivalent of prednisone at discharge is equally effective. Now there's some discussion about, we used to taper it all the time, particularly with kids. We find out that tapering it in the short period of time that we're using this is really not necessary. So you can use 1 to 2 milligrams per kilogram for 3 to 5 days in kids, 5 to 7 days in adults, up to 3 to 10 days, rather than the tapering that we used to do. Not necessary. These kinds of doses work just as well. Inhaled steroids cause vasoconstriction. They decrease the inflammation that we talked about. This should be started at either during or at discharge in the emergency department in most asthmatics. Again, current evidence shows it's equal to replacing systemic steroids with inhaled steroids. So the only problem with these is they can be fairly expensive. It can be up to $200 per inhaler. So we need to know that if the patient can actually afford them or have access to them. And there are a lot of resources out there to help pay for these kinds of metered dose inhalers. Here's a graph on the low, medium, and high doses of inhaled steroids. I won't go over those, there are lots of them. And you can look at the dosages for low, medium, high in adults and children. Okay, what about magnesium? Magnesium is indicated in patients with impending respiratory failure. These are the folks we talked about a few minutes ago about who were cyanotic, who had diaphoresis or had reduced mental issues. And this is after perhaps maybe an hour of treatment. And there's the dose there. The short half-life is less than 30 minutes. And it does appear to decrease admission rates in severe asthmatics. So it's something that should be part of your regimen in looking at what's the next thing to treat the patient with, depending on how they're doing. Things not to do. The methylxanthines, aminophylline. Remember in the 70s and 80s, we were using aminophylline like water for asthmatics. We find out it's a weak bronchodilator. It has a narrow therapeutic range, and there's a high adverse effect profile. What about antibiotics? Not a lot of evidence out there to support that unless we can figure something out that we have a high indication that there might be a secondary infection, which could have been the trigger for the asthma. Also, aggressive hydration, not a lot of proven benefit to that. So hydrating the patient unless we figure out that there's some reason that they're dehydrated. Mucolytics, not valuable. And certainly sedation, the last thing that you want to do is give the patient something that's going to sedate them and perhaps enhance their respiratory depression. Okay, what about what to do? So discharge, you can discharge the patient if the pulmonary function, and again, that's either the spirometer, the FEV1, or the meter dose, the handheld thing. If it returns to 70% of baseline and they're able to walk without significant shortness of breath. So if they've gotten back to that 70% or higher from where they were before, that's great. And we've monitored them for a while. So again, oral steroids starting and also the inhaled steroids immediately. It's important. Most patients who have asthma and have seen either their primary care doc or their asthma doc have been taught the importance of the rescue medication versus the controller medication, and they need to know the difference. That the rescue medication is something that they take if they can't breathe, like the albuterol, they can't breathe. It's something to do now to rescue what they're doing, but the controller medication is something they need to take further down the road for that second phase of the asthma that we talked about. And so that's important. So if they're not doing well, if they're 50 to 69% of predicted with mild to moderate symptoms, then maybe we got to watch them for a little while longer. Maybe we got to consider putting them in an observation unit and monitor their pulse ox, their SPN, and things like that. Discharge medications we've already talked about. Depending on the severity, they should go home with steroids, both the oral steroids and the inhaled steroids. And there's a couple of kinds there. And also they need to have that rescue short-acting beta adrenergic medication. Wow, that was a lot of stuff about asthma in half the time. Well, let's go on to chronic obstructive pulmonary disease. I wish I could tell you that we have much success with COPD as we have with asthma. It's not true. What's the most common cause and trigger of COPD? Smoking. Yeah, huge thing. COPD is the third leading cause of death in the U.S., and it's predicted to rise from the fifth to the third leading cause in the world of death by 2030. So it's a severe problem, and we know what causes it. Unfortunately, once it starts, we have a hard time slowing it down, and we'll talk more about that here. So the definition of COPD, it's preventable, it's treatable, but it's characterized by persistent respiratory symptoms and limitation of airflow. It's due to airway and alveolar abnormalities caused by significant exposure to noxious particles or gases, i.e. cigarettes, tobacco, those things. And the exacerbations of COPD and the comorbidities contribute to the overall severity in all of these patients. And the best website out there is the Global Initiative for Chronic Obstructive Lung Disease, and they just came out with some new guidelines just in the last year. So we've talked about this. There's a huge burden in this country and around the world in terms of health and cost to society. So the mechanisms underlying airflow limitations in COPD, small airway disease initially, that's the inflammation, that's the fibrosis, that's the luminal plugs and the resistance in the airway. And the parenchymal destruction is the second part, loss of alveolar attachments and the decrease of that elastic recoil. And that's sort of the last thing that occurs, and they can't get that stretch to breathe. So in terms of diagnosis and initial assessment, COPD should be considered in any patient who comes in with dyspnea, chronic cough, or sputum production, and a history to the kinds of exposures we just talked about. My guess is that most of the time somebody comes in with these symptoms, they already know they have COPD. So you're already dealing with a known diagnosis, and you have to determine what's the cause of the exacerbation. Again, you need to do that pulse ox. Again, spirometry is really required to make the diagnosis of COPD, and looking at the presence of post-bronchodilator FEV1. And that confirms the presence of persistent airway inflammation. And what that means is once somebody comes in having difficulty breathing and you've got an SPN treatment, and then you do that spirometry to find out where they're at even after the bronchial dilator. And so the goal is to determine the level of airflow limitation in terms of what's going on and why it's going on. Okay, so the chronic disease, COPD is a triad of chronic diseases, but you need to find out what else is going on, which is usually the case. Usually COPD does not present itself in a vacuum. So there may be cardiovascular disease, any of these things on this list, and they should be actively sought out to figure out what's going on. These are complicated patients that deserve our attention to decide, what's the cause, what's causing the exacerbation, what can we do in the short term and the long term. Getting a good history, extremely important. Their exposure risk factors, their past medical history, family history. Again, the history of exacerbations or previous hospitalizations is extremely important to document. Comorbidities, the impact that this has on the patient's life. And they'll usually be able to tell you, but if they don't tell you, the spouse will tell you, that they can't walk more than 20 yards without having some difficulty breathing, or that, they haven't been able to go to work. In fact, they have been unable to work for 10 years because of this. That impact is important to note. And also finding out the social and the family support that's available to the patient, because they need a lot of this. And then what do we do to reduce risk factors, especially smoking cessation? A huge issue, and it's something that's usually important to do, very, very difficult to get a patient to quit smoking. How many stories have you heard about a COPD patient, that was being seen in the ER, but you couldn't find them because they had to go out and have a smoke before they came back in. Those things are very difficult to do. So, again, we talked about this. Patients present with dyspnea, chronic cough, chronic sputum production. They may have fever, so we've got to look to see if there's anything going on in the lungs in terms of pneumonia. Chest pain, looking at coronary syndrome, and getting the examination, those vital signs, especially the respiratory rate, the lung sounds, and it may vary between times that you listen to it. Again, if they're diaphoretic or if they have signs of cyanosis, this is a bad sign, and we may need to be doing much more in the ER than we're currently doing. So something we learned in school in terms of the patients with right-sided heart failure due to COPD have polycythemia, which causes the cyanosis in that picture there. Others with right-sided heart failure and polycythemia have the pink puffer, the small heart with hyperinflation, that picture that you see there, very common. The assessment, I think I've oversaid it now, spirometry is required to make the diagnosis. Again, the presence of post-bronchial dilator, FEV1, confirms the presence of airflow limitation. And it's important, Not required during an exacerbation. Again, somebody comes in with an exacerbation, they can't breathe. We got to do all the things that we do to take care of their ability to breathe, and then start doing the spirometry, post-bronchial dilator, to find out what's going on. So manage that exacerbation first. In this case, getting a chest x-ray may not be a bad idea to include alternative diagnosis. EKG for coexisting cardiac problems. Blood gases might be important, to check for hypercarbia, and of course the pulse ox to know what the baseline is and what the changes are in the pulse ox over the time that you're caring for the patient. Okay, here's the goal therapy at each stage of COPD. Great graph to have. Shows you the mild, moderate, severe, and very severe. And if you look right above that, you'll see what you're seeing there is the serial evaluations of the spirometry. There it gives you an idea of how they fall in each category. And then below that, looking at when particular medications need to be added. Here's an example of common maintenance medications in COPD. Lots of them there. That there's a lot out there to be utilized, and it's a good graph to have for your records, as well as looking at the limitations of inhalers used in the treatment of COPD. There's a list of the kind of inhalers there. Lots of them out there to be utilized. Okay, so lastly, how do we deal with the patient that comes in that just has that exacerbation? Again, systemic corticosteroids are our friend. I have to tell you that many times I've seen a COPD patient that comes in that's already on prednisone. So we have to decide, how much prednisone they're on. Are we going to have to increase the amount of prednisone? So whatever we have to do to improve that lung function. Antibiotics, again, if indicated, it's not uncommon for a patient who comes in with COPD to have an infection, so early intervention, would be very useful. Again, the methylxanthines, not recommended. Oxygen, again, to titrate to improve the patient's hypoxemia, and watch closely for CO2 retention. At some point, depending on how they're doing, we may have to look at non-invasive ventilation, which is the preferred initial mode for ventilation. Again, pharmacologically, bronchial dilators, they should have had that anyway coming in, but they may not have. Corticosteroids, antibiotics. Some controversy about the use of antibiotics, but certainly I think it's important, and there's no reason that we can't use some of the inexpensive antibiotics. The trimethoprim, sulfamethoxazole, the clarithromycin, the doxycycline, trying to decide, what organism is out there that we're treating. The more expensive quinolones may be used, like Levaquin. They're usually used better for things like Pseudomonas or other anaerobes. But you need to make sure that you've looked at the May 2016 black box regarding quinolones, and they have which is the FDA's strongest warning, and they talk about perhaps look at the lesser drugs for treatment early rather than jumping to the fluoroquinolones, just because of side effects and other issues that's listed here on the black box. Disposition, if they're not getting better, they're going to have to go in the hospital, and this again is determined on marked increase in the baseline symptoms and the FEV1 and the pulse ox, just not getting response to treatment. You can discharge the patient if with inhaled long-acting beta agonists, oral and inhaled corticosteroids and antibiotics if indicated. Before they go, make sure you've done a full review of clinical and laboratory data, check the maintenance therapy, reassess their inhaler technique, and ensure understanding of the withdrawal of acute medications like steroids too soon, and provide management for comorbidities. If those things, and the numbers are coming up, then you're able to discharge them back to their primary care doc or their internal medicine doc or their pulmonologist, whoever they're seeing. Okay, that's it. Lots of information on those two things, important things. And I'll turn it over to Martha.
Thanks. All right, guys, this is the last talk of the day, and it's going to be really fun. It's a brand new talk. We're going to have, oh, you want me? Sorry. I'm always in trouble. Spacebar, right? Okay. All right. It's not pausing, Dave. Is it a range thing? I can come down on the floor. It's good now? Great. Okay, so we're going to talk about procedures. And if you want to see some of the procedures that are featured in this, we usually do a live demonstration during this time, but we decided to mix it up a little bit. We have hundreds of procedures that I've filmed between myself and Jim Roberts, my dad. Actually, we work on a textbook together. You can just go to proceduralpause.com and it'll redirect you to the EM News site where we have a ton of videos archived. In addition, you can go to the proceduralist.org. Yep, it's going. And you can check out some of our videos there. That's associated with our podcast that we do, the Two View. And we'll put this video up in your account so you'll have access to it and all the links. So again, that's our link to our podcast that I do with Sharma. And it's available on all those different avenues so that you can listen to it. A lot of our faculty makes appearances. And this is my contact information if any of you ever have any questions and want to reach out. This is the book. Any procedure you could possibly want to do, you can check out in Clinical Procedures in Emergency Medicine. And the 8th edition is going to come out soon. We just started working on that. So what we tell patients, I'm just going to give you a few shots. I'm just going to give you a few shots, no big deal. Just a couple, maybe some in your finger webs. Patients be like, oh, hell no, right? I torture my dogs throughout this entire video. So procedures can be super rewarding, right? There's a lot of things we can do to help people. Check that out, oh my gosh, right? Subungual hematoma that we evacuated. See that again. Boop. Love making that noise in the ER, right? Or how about this next one? Oh man, that guy's ankle, a mess. Not anymore. Fixed it, check, right? Put that ankle right back in there. Oh, that is just lovely. And what about this? A little liquid cocaine in there, numb up the ear. That's actually Jim's ear. And he forgot about that earbud that was in there last month. There it is. He used it again, by the way. And, ooh, these can be so satisfying, thumb reductions. Just get that right, and goes right back in, right? These are so satisfying. But you know what? Sometimes things don't work out, all right? Sometimes it's always not all peaches and cream and easy and like, all right, discharge, get you out the door. Yeah, sometimes it doesn't go so well. Happens to me all the time, right? The crucial part. And as you can see, our pulley here, which is going to pull that right over. Rip the skin. So much for that. Not going to work.
Rip the skin. Rip the skin right off. Where are you going to put that? You're going to put that where? Yes, we're actually going to put that in your butt. That's where that needle's going to go. Yeah, that's not happening. Not going to do that today, right? So we always have to be careful with the language that we use for patients. We're not going to say, listen, I think earlier I heard Pescator say, you're just going to shove that up that person's nose, right? You're going to walk in the room and say, you're going to shove that up your nose to make you feel better? That doesn't sound so appealing. So we have to be really careful with the language that we use when we're doing procedures for people. Putting in an earwick. This is a fun one.
Take the earwick that I took out of the package.
A little volume.
I'm going to look at the patient's affected ear. And then I don't have to worry about it going too far in because there's not really much space for it to go. I'm just going to insert the earwick gently into the ear, and sometimes it falls out, but you can just slowly push it in there gently. And I know that feels kind of funny, but in a minute I'm going to show you what we're going to do. Once the earwick has been placed in the canal, we're going to drop our medicine.
It's like magic.
Just going to reposition it, my friend. And it might kind of just sit there for a second. You can have them turn their head if it doesn't work. And could you just tilt your head a little bit to the left side? Great. I'm just going to advance it. Feels kind of itchy, huh?
No, not bad at all.
And I'm just going to add some of the medicine directly over the wick.
Right on
And
top
I've
of the
left
wick.
the wick purposely out for right now. I'm sorry, I know that's dripping down your neck. It wasn't part of the agreement. But I just left the wick outside of the ear here so that you can actually see it expanding in the ear canal. And when it expands like this, that's what holds the medicine in place in the canal so that the patient gets better faster.
Right? Pretty cool, huh?
So gratifying.
It's like a TikTok video. Right?
It has to come up from the pharmacy.
This is my 7-year-old. I think she was 5
That's
at the
Delsum.
time.
Does the cat have a cough? Your next patient is waiting. Oh, you have 2 patients. Oh, there's going to be
Right
a
in the
fight.
face.
You're going to have to do some stitches.
That's really what my triage looks like.
Well, the dog fight that's happening. Are you giving the shot? Did it come up from the pharmacy?
Yep.
Where are you going to give it?
She said, in the face, right? So anytime you're going to, again, do something to a patient and it's going to inflict pain, you got to be as gentle as possible. So let's talk about intramuscular shots. Sharma's away. He's gone, but he's still here, right? So here he is in my video.
Okay, it's time for round 2, and I have a great nurse who explained in an awesome way how to give me my IM injection for my Moderna vaccine. So without showing her face, she's going to talk through how you kind of mark and measure the site and perform the injection. So here we go.
So you may be called upon to give an injection to one of your colleagues during this COVID pandemic. I gave over 5,000 shots at a clinic for COVID-19. And so if you haven't given a shot in a while, this is a quick refresher on how to do it and how to do it correctly.
Okay, so we're going to feel for the Acxiom process right here, okay, and then we go down 3 finger widths, okay, and you can also do a V here, okay, and then you're going to go right into the muscle. Okay, you want it in the muscle. So you're going to wipe it with alcohol, and then I just kind of visualize where I'm going to go.
And we talked beforehand. I've heard of folks doing squeezing of the muscle. Do you recommend that?
No, no.
And
No
why is that? Not to put you on the spot or anything.
Probably because then you'll get an accumulation of the dose there.
And it doesn't go in the
So-
right place, right? You
right.
want it intramuscular.
You want
and
it
you
into
squeeze
the muscle, not into the fat.
Exactly. Yeah,
Yep.
nailed it. Okay.
Okay, and
the
then
angle
you have
there?
a poke. Okay, in fact, I'd pull it, then top to pull taut.
Oh, okay.
Okay, so just give it a poke. Okay, and you do not have to aspirate
Right.
on IMs anymore. Slowly inject it.
I don't think I have any
and pull it
giant
out.
veins coursing through my massive deltoid here. Yeah.
Okay, and then just give it a little bit of pressure.
Okay.
Make sure there's no bleeding.
He got a lollipop after that.
There goes his Band-Aid on.
So now you guys can all do IM shots. You got a good refresher.
We ask people to sit for 15 minutes just to monitor if there's any reactions to the vaccine.
Thank
So
you.
we'll ask you to sit for
15-minute
Well,
wait after
great.
the vaccine.
Thanks.
Thank you.
No chance you're touching me. Not a chance. I have a protected blanket.
Slow me, but this is safe for me.
They feel better that way. Fishhook removal. Now, the following may be disturbing to some, and I will have to tell you at the end, Jim did eat the steak. It will make sense in a minute. These people come, fish hooks all over the body. This is actually in Key West. We do a course down there. That's me and Jim on a boat catching barracuda. And here's a guy with a fish hook with a worm still on it in his ear. So what we did is we just numbed up his ear a little bit, right over where the needle was, and I removed it.
Patients with fish hooks embedded anywhere in the body, oftentimes in the back of the neck or in the hands, come to the emergency department to get them removed. The reason they can't just be pulled out themselves is because they have barbs on them. Here you have 2 barbs,
Right? Some fish hooks have like 10 barbs.
relatively small, but they're facing backward. So once it goes in the skin, trying to pull it back out, the barb gets caught. And you can't tell the size of the barb just by looking at the hook. But this is about the standard size for one of them. Now, when the hook is past the curve, this curve here, you know that it's in the skin, and the barbs are in the soft tissue.
Okay, Jim, so can you show us technique number 1?
One side note, COVID-19 prevented me from seeing my parents for almost 2 years, even Jim. So we did a lot of FaceTime, and we actually did our column for the procedural pause over FaceTime. It was fun, yet extremely annoying. And my mother hadn't had her COVID vaccine shot yet, so everybody was wearing masks.
Yes, here's technique number 1, probably one of the more common presentations. In this particular example, the fish hook is near the end of the finger, for example, but the end is not out all the way. So it's still trying to pull it back out, pushing it that way, it won't work. Now, normally you're wearing gloves and a mask for this, but since this is a demonstration, I won't be wearing it. But you can see you can't pull this out. So what you do with this one is you push it all the way through, then you cut the end off with a pair of pliers or a metal cutter, and then you just pull it back out all the way. This is a soft piece of meat, so it should come out. Okay, so that one, push it all the way through, cut off the ends, pull it back out, and now you have just a puncture wound.
Okay, but what about technique number 2? Can you show us that?
Yes, here's technique number 2. Probably the more common way to present with a fish hook is it's in the middle of the tissue somewhere. So if you see it's down there past the barb, and it won't come back out. Now, one thing you could do, if it's really superficial, is you can make a laceration with a scalpel and then just lift it out. But another way to get it back out is to put a piece of string or a suture around the hook, and I'm going to press down on the hook and pull back on the string. And then what that does is it moves the barb back into the track that it went in, and comes right back out. Now you have another puncture wound.
Okay, finally, can you show us technique number 3?
Yes, this is technique number 3. The final way is just to figure out in your head what you're going to do based on the certain circumstance. And that includes figuring out where it is. Sometimes if you just pull it all the way around, up that way, and cut it off, it'll work. Or if it's in much deeper, you can make a laceration with a scalpel this way and that way, and then just sort of wiggle it around, and it'll come out as you cut down on it. And then you have a little laceration, which you can usually leave open depending on the cosmesis of it, or you can put one stitch in it.
Okay, so now that you've taken the fish hook out, what else do I need to keep in mind?
It depends on what's on the fish hook. If there's a worm on it, for example, you want to make sure you irrigate the tract very well, but very difficult to irrigate this small puncture wound. And I would advise not trying to stick a needle in there and blowing up a lot of saline, because that won't get anything out. So you just want to irrigate the entrance and the exit, and it's usually fine.
What about oral antibiotics? Need to prescribe those?
Usually antibiotics are not required. If it's been in there for a day, or it's really dirty, or maybe there's an organic piece in there, a couple of days worth of cephalosporin would probably be all right. But the vast majority of the time, these are just a clean puncture wound, don't need antibiotics. And if you make a little laceration to get the hook out, don't close it, unless it's really big. You can just leave it open, and it'll heal by itself.
My mom says sorry about her son.
Thanks, Jim.
You got to do what you got to do. All right, so let's move on to our pediatric patients. What do we do for them when they're having problems during procedures? This is every pediatric patient during a procedure. Pretty much every one. Once in a while, I get a good one. Right? Teeth and all. Coughing, sneezing, biting, growling. That's Finley. So here's a fluorescein trick for you. What you need to do is get a fluorescein strip, some normal saline bullets, I'll show you those in a second, a Woods lamp, and some ocular aesthetics. These are the little bullets that you can use. They're great for all kinds of things. The respiratory therapist has them, And you're going to use one of these to put in the fluorescein dye, and we'll show you how that's done. And the purpose of this is so you're not jamming something in a kid's eye that's going to hurt them, because it's irritating for them. So get rid of some of the liquid in the saline bullet. That's what we call those. Like half, right? Just pour it right out on the table. Squirt your friend, whatever. I like to squirt them like right in the pants. Then drop it after you have about, well, she has about maybe like just less than half, right onto the fluorescein dye. And it's gonna, and then as you drop it on, suck it back in. So now you don't have to stick the kid with the fluorescein in their eye and then try and put the anesthetic drops in there, because you've combined also, she's also, excuse me, I forgot to mention, she also combined her anesthetic drops in this so she can stain, dye, and get pain-free all in 1 to 2 drops. So much easier, and you don't have to go after the kid 3 times. Put it all in one and make it easier for yourself. Again, these are your best friends. Great for taking out your contacts. For patients in the ER as a temporary solution for them. No pun intended. Now, some of you have been asking about the slit lamp exam. We're going to run through a 5-minute slit lamp exam, and all of you should be able to leave here, sit down at the slit lamp exam, and be able to do it. It's one of my favorite things to do in the ER. Once you do it and you get good at it and you're happy with your machine, you're going to want to see every eye patient that comes in.
The first thing you're going to do is sit down and make yourself comfortable and be in a comfortable eye level to look through. Second thing you're going to do is turn it on. And the on switches, on all of these, the on switch is usually on the base somewhere.
Get some volume.
Okay. The third thing you're going to do is adjust your intensity. So when I walked up to this machine, the light was off. So if I didn't know that, I would think it's broken. So now I have to turn the light on and adjust the intensity. Okay. Mm-hmm. The next thing you're going to do is adjust your eyepieces. So there's 2 adjustments. The first one is the width, which you just have to set to the correct width for your eyes. And so there's 2 adjustments.
Sorry about that.
The first one is the width, which you just have to set to the correct width for your eyes. And if they're not set to the correct width, then you're not going to get a 3-dimensional view. You're just going to be seeing with one eye, or you'll be seeing a split image. The next thing you need to do is set the diopters. And they should be set to 0 for most people. So usually for people with normal vision, setting the diopters on each eye to 0 is where you want it to be. All right, so now if one eye is slightly out of focus, then you focus with one eye using the table, and then you focus with the other eye adjusting this so that both eyes will be in focus if you have different focal lengths with each of your eyes. But for the most part, you can just leave it at 0.
So you're going to ask the patient now to sit down and get comfy. You got to be comfortable first, because you have to be calm.
The next thing is you have the patient sit. And you want the patient's eye level to be at the level of the black dot. So that's where their eyes need to be when they're sitting. And you get their eyes there by adjusting the chin rest up or down using this.
So tweak that. Every machine's going to be a little bit different.
So then the next step for me is usually I focus the light on their forehead or in between their eyes. You
Focus
don't
in the middle.
Focus it in their eyes, because then you'll blind them. So I focus it. Then I adjust the height of the light using this. And if I want my cobalt blue, I turn that to cobalt blue.
The width of the light, also very important.
Adjust the width using this. And that adjusts the width from almost completely round. So what it's doing really is there's like an aperture in there, and as you dial that, you're closing the aperture and, you know, decreasing the amount of light that can get through the two slits. So totally open, and then super, super skinny.
Now, how do you look at the eye? What's the last step here?
So then the only thing left is operating the table. Actually, there's two things left. Operating the table. So you turn the dial to go up and down. And then you use the joystick, obviously, to move the light around. All right. And then the last thing is the magnification. So this is a ER version that only has 2 magnifications. You know, a lot of these will have a dial where there will be 5 or more magnification settings, and check magnification by turning the light.
I always get a little confused about the other parts.
So this is the microscope arm, and this is the light arm. So most of the time, they're operated together in the same position. But if you need to identify structures on the front and the back of the cornea, or within the anterior chamber, or on the front or the back of the lens, then you separate them. Oops. And the light goes at an angle. And then it gives you, there's a refraction across those surfaces that then gives you 2 images, one of the front of the surface and one of the back of the surface. So if you're at an angle, first of all, you can look at the surface of the eye without blinding the patient because the light's coming in at an angle. So if you're just looking at the cornea, it's useful for that, but it will also show you the front and back of the cornea, and then the front and, you know, the depth of the anterior chamber and the front and back of the lens. The light is generated and travels down through here and then hits a mirror, which then projects the light that way.
Sometimes you need to replace that bulb.
So what happens if you walk in and find it like this? Well, it means that someone turned to this part of it on the top, which gives you a horizontal beam. You'll probably never use that, but you may sit down and find a horizontal beam and not know what to do with that, and this is how you straighten that out again.
It's usually under the table to go up and down. Almost always.
So there's a release lever under here that allows you to adjust the height of the table.
And don't have your patient be sitting in there when you're doing this. That's just rude.
That's it.
Okay, some days are rougher than others, right?
What are you going to do for him?
Give him medicine.
What kind of medicine? He can barely breathe. What are you going to give him? Hurry, his sats are dropping again. What are you going to give him? Amoxicillin? Oh, Lordy. Does it fix everything?
Yeah, pretend it does.
Yeah, that's what I do too.
Right? Kids say the darndest thing. What about the tonopen and tonometry? Working another piece of equipment here. There are a couple different kinds of tonopens. Make sure you get your ocular anesthetic. And this is putting on the condom on the tonometer that we use to protect the tip. Okay? And that rolls down right on top. You can do it in a supine position. I think those were some of Pescator's residents, by the way. And this is the handheld tonopen.
We're going to demonstrate the use of a tonopen.
Now I'm going to fast forward this just a wee bit. Essentially, Dr. Dollard here goes through calibrating the pen, but every pen can be a little bit different. So I want you to try and see your tonopen when you go back into your department and how to calibrate that. Here he is doing a test, though, on
They're not going to pull away. We want them to
Rose
fixate
here.
on an object that's far
And
away.
essentially what he's telling her to do is
Use
to
the
look forward right now.
aesthetic of your choice. So if the eye is anesthetized, and then you're going to come in and do your measurements. Okay? In this particular case, you can actually rest your hand on the cheek of the person. You're going to come in, and you're going to come in, and you're going to depress right on the cornea. So you're not going to indent the cornea. It's really just a touch.
Quick, light, and direct taps. None of the dart throwing. Again, that would be rude.
The point of this is that you want the tip of the transducer flush with the cornea. Obviously, in our model here, her eye is anesthetized, so the pressures that are going to be measured aren't real, but you really are just touching it flush to the cornea. When you do that, you'll hear a very subtle beep. When you're done, you'll see, unfortunately, it just went off. There was a pressure here with a mark down here with 5% that showed that you had 3 readings right there.
Again, you can see just he's doing light taps there. Just light taps. And this is how you should hold the other type of Reinhardt Tano pen. There's lots of ones out there, but you have to hold it properly in order to do the test correctly. And again, quick light taps, quick light taps. If you get an error reading and you've done the test correctly, and you're like, gosh, I really feel like I've done this like the right way, I'm not sure what's happening, then it might be that the pressure is just so high that it is actually a problem. But sometimes, you know, you might just be doing it wrong. So that's why we practice. Where's it going to go? It's going to go right up. We're going to shove it in your nose. Can you imagine what life is like with me and the dogs at home? So we'll end with a cerumen impaction because we're running out of time. There's lots of other procedural videos. But this is a cone-like device that we are able to use to remove the earwax in a much better and easier fashion. This is our ENT specialist doing this. And then later, this is a patient I mentioned before. He had sinus cancer, and he's a very well-known patient at UC Davis, and everybody knows who he is, and he's all these patients have consented to using their images, except that my child, she doesn't consent to anything. But I'm only kidding. She said it was okay too. But you can see he's scooping it out here, not blindly. He has something that is actually helping him. Good lighting.
Is the suction hooked up in here?
We do not, but I can get it for you.
That's okay. I can use this.
And this guy has a lot of chronic impactions in that ear.
Acute bacterial otitis externa. That's what it looks like.
Yeah. Is that a fancy word for snot?
Kinda. It's a fancy word for, usually it's a bacterial infection in the external ear. And it happens when the ear canal, when the natural balance of earwax and bacteria get disturbed. You doing okay?
Uh-huh.
Okay.
He'll clean out his hole and then he'll show me all the goop that comes out of it.
Makes your life so much easier. Very satisfying, huh? And then we pulled out a lot more than that. And then the nasal endoscopy or direct laryngoscopy can be done. There's a couple of ways to do it. You can look with the GlideScope. You can do that and have the patient awake when you're doing that. If they have a very little gag reflex, you can put some numbing anesthetic back there to take a look. In addition, you can have, we've had a couple of patients. This is Dr. Hermes from Fairfax, Virginia, back way in the day when I was training, and he would do this all the time on patients. I mean, there's just a regular blade. So again, this is just the patient that gave us.
Very healthy so far.
What's that dark thing?
He's
where, straight ahead?
Yeah.
That's a booger.
Oh.
Yeah.
And the key for advancing the scope is just to go slow.
Yeah.
Some lidocaine on the end.
This is actually just saline.
Something to help it guide.
Yeah, just some lubrication. So you can see that's the end, like
Can we
that
pull the
is
boogers
this. So I don't have the equipment to do that here, unfortunately. But if we see you back in clinic soon, we'll be able to do that.
Because it looks like
Okay.
he needs a good cleanup.
Yeah. Aaron, let's see epiglottis. Swallow. Good. Now say E. Okay, and sniff in through your nose. Okay. All right, we're going to come out.
Patient tolerated it really well. And then a buddy of mine, Dr. Nick Sawyer, this is a laryngeal mass that he saw in the ER.
Can
It's
you make an A noise, sir? Okay. And make an E noise. Okay, very good. And
Anyway, I think that's all we're going to have time for. The needle's not going to go that deep. Don't worry, Finley. It's only going to go a little bit deep. Yeah, he gets upset about that. Anyway, if you want to see some more of these videos, you can check them out. The rest, I had some hematoma blocks in here that you can check out as well. I do an ankle, I do a wrist. There's some ultrasound videos in there. And additionally, we had a really great tattoo repair if you want to check that out. So all these procedures, lots of clinical pearls that you can learn. Practice, you'll get better. And you know, I wish you luck doing these because they're not always easy, and even I've struggled with quite a few. So thanks, guys, for listening, and now we're going to do our Q&A. Thank you.
Grab ours. Yep. Thank you.
So I think, you know me, I'll talk to you after the Q&A. Let me get my computer.
Campfire yet? Got your geometry going.
I'll talk to you after the Q&A.
Classic fireside position.
Everyone can hear me.
Think I got 6 Have a seat, please.
No, I was going to go to the bathroom next.
So we could walk in front of it. So I was trying to give him room.
Kids say the darndest things, don't they? Okay. So, give me one moment. I couldn't be everywhere at once here. I just have to go to our... Can you guys switch to the afternoon? What is today, day 3? Day 48. The captain is getting upset, and the mateys are restless. Okay. All right, for headlocks with staples, did you say to anesthetize? Oh, always a good question. We don't. Well, that's mean. Just use cold spray. Please let me know if this is wrong.
So I think this came over from the lecture this morning. What I was talking about was especially if I've got a head lag that I'm really having trouble controlling the hemorrhage, throw a couple staples, a couple stitches in there to kind of approximate the wound edges, and go ahead and use a lidocaine-containing solution to anesthetize it will also give us the vasoconstriction. I think we're going to find people that use staples with and without. If it's 1 or 2 staples, I may not anesthetize. I'll offer the patient the option. If it's a kid, I usually try to do a topical like Tech or Lat or Lead or whichever you have to give them that local stuff, but I think everybody has their own preference of anesthetize or not with just staples themselves.
Okay.
Agreed. 1 staple, I don't anesthetize, but
1 staple, fine.
Like, the numbing medicine burns worse.
3.
Okay.
Bam, bam, bam.
Randy, tips to differentiate tinea versus granuloma.
Yeah, thanks. It's actually in the presentation. The tinea lesions are pale in the center, have well marginated erythemic margins with scales, and the granuloma annulare has pale in the middle, but it sort of fades out with no scales. So it's in the presentation.
Okay. If a patient comes in after unsuccessful attempt at completely removing a tick and parts are still visible, is it advisable to attempt to do a complete removal? And what about children who are not as cooperative as adults? Actually, most adults are less cooperative. I mean, I worked in rural medicine, as did Randy, for quite some time. I never went digging for these additional pieces. It really didn't matter. The treatment of Lyme was more important to me, not sticking things in there and trying to rip out these pieces.
Well, the whole idea, obviously, is that the tick needs to be dead.
Well, that too.
And get out as much as you can.
Yeah.
And if sometimes, if you grab it, you have to pull it directly out, because if you don't, if you twist it, you may break off the mouth parts. But then you can go after the mouth parts. But you've done the job already, and the only thing you have to worry about is now you have some foreign bodies there that you may have to deal with.
Yeah, eventually they do come out. I would never make a kid sit there while I took out like the little piece of the antenna that's on that tick, but Randy is 100% correct. Just make sure the full body of the tick is out there for sure. Those bugs are the worst. Okay, how can we drain oral abscess and not refer to dental? Do we have any videos? We do have some videos for that, but maybe we could go through some techniques for what we do here for abscess.
And the main one I talked about in the lecture was like a periapical. If they've just got a small little abscess, you can just take and break that with an 18 gauge or take a scalpel and just IND it and just express the pus. Some of this also falls into, are you credentialed or privileged at your facility to do that? If it's a deeper abscess, I'm definitely getting Max Face involved, and sometimes they'll just come in, grab the ultrasound, look for it, and IND it that way, or have to do it in the OR. But definitely if it's a small area and just periapical, you should be able to do those as long as you're covered with your credentialing or privileging.
Now, let me ask you guys a question for, we're a PA and 2 NPs. Now, if you have an APP with you that wants to do this procedure, do you feel like you need to supervise these procedures for your APPs? Or do you feel like they could say to you, hey, I'm going to go drain this abscess? How would, I feel like we've got a lot of questions, and Randy, you had talked about this a little bit as well. So how would you handle that?
Have they done it before?
You don't know.
Well, then I would ask them if they've done it before.
Okay.
Unless they're not answering for some reason. Yeah, I think they need you need to know that, and you need to feel comfortable they can do it, because ultimately you're still supervising, and if something goes wrong, it was like, well, they never did it before, and now look what happened, kind of thing. So it just seems reasonable to ask that.
Well, you do the same thing with the resident.
Anybody who's going to do something under your watch.
I think it's important to know what you're credentialed for, and I've worked with people like, I really don't know. I'm like, no, you need to know what your credentialing or privileging covers and stuff. And most hospitals, if I'm credentialed for this procedure, I've done it this many times under supervision, so I shouldn't have to. Now, obviously, if I'm working with someone I've not worked with before, we should have that discussion and conversation. But it's definitely important to know your competence and know what you're allowed to do and not do as well. That's your professionalism.
Although in emergency medicine, when you get privileges, there is this set of core competencies which is assumed to be there, like if you did a residency, so they're not going to go down. So fortunately, we can do just about anything.
But for APPs, not necessarily.
Yes, particularly if it's a life-saving thing. You may never have done this procedure before, but what are you going to do? Just say I'm not credentialed? No, you have to do it. So we have a kind of a lot of latitude.
I can tell you our APPs are doing these routinely where we are, the dental abscesses, and they've done a lot, so, and they see a lot of them. So.
Yep. Okay. Any guidance how to find a septal hematoma? This is something I've always been second guessing myself on.
I think a good light source is important, and definitely suction. And usually the picture we showed is a pretty obvious one, but most of them, if there is a septal hematoma, once you get the blood or the mucus cleared out, you can see it's bulging out. It's going to be kind of fluctuant if you're able to tap on it, and then you just need to anesthetize it and drain it, or if that's something you can't do, get ENT or whomever involved and get it packed.
It's also ungodly painful.
Yes.
Right? It won't, it's not subtle.
A facial block, yeah, I mean, they're hurting because it's swollen.
Yeah. If I have any question, and sometimes I do have question, I can't see in there, I just stick my finger in the nose, and you get an idea if they scream and grab the top of the thing. Yeah.
I'm just going to stick my finger up
But that's
there,
that's
right?
the way you do it, and you know you can even do double.
You say, I'm going to gently insert.
gonna gently insert.
Gently palpate the medial septum.
I'm going to flick it on the way. You're so cruel. All right. So next question. Any guidance? That was the cervical spine lecture. Where can I find the trauma guidelines? Now, I think we posted that.
We did. The East guidelines are in there, and then specific to the blunt cervical vascular injury, that section is also posted in there now.
Okay. Next one, ketamine for ketamine use for extreme air trapping and asthma. Any thoughts? Any other ideas for air trapping? Only able to bag the patient 6, breaths a minute due to prolonged exhalation because of air trapping. So ketamine and air trapping.
Yeah, I mean, ketamine has good evidence to support its use. I don't know that it has been targeted to its effect on air trapping. It certainly has been identified to assist with patients that are on non-invasive ventilation. The escalatory pathway for asthma, in my mind, is pretty, relatively straightforward. The sort of things we always think about are albuterol or our ipratropium, if so be it, non-invasive ventilation, magnesium, et cetera, and as you progress up, eventually you enter into the therapeutic utilization of ketamine, enters your therapeutic pathway here. And magnesium we discussed, of course. All too frequently we forget that one of the most profound bronchodilators that we can take advantage of can be brought by specialist consultation, which is sevoflurane. And these patients with unbelievable air trapping, that you have them on you have them intubated, they're on the vent, the alarms are going crazy, you're extremely concerned for barotrauma, you've paralyzed their chest because they're air trapping so much, you're manually decompressing their chest. We've had these patients, right, and this is hell. And these are patients that need to have the largest endotracheal tube you can place in them, but ultimately consulting anesthesia, and this is only something I've had to do a handful of times in my career, but they place the patient on the sevoflurane circuit, and the profound bronchodilation they get is usually solving the problem.
Did you recently see the study about the pain study? Sergey sent it to me for inhaled ketamine.
Yeah, nebulized ketamine. So there's another option, not for use for asthma, of course, but another analgesic option in our repertoire.
Yeah, but the study wasn't that compelling to use ketamine nebulized for pain. They did it for acute and chronic pain treatment.
Yeah.
So
Just nebulize it for everybody.
yeah, I think we should just put all kinds of drugs in the water. All right.
May work for depression.
That's true.
Yeah.
I actually have a friend that went to go do that. He was put in the hospital, and they did short infusions of ketamine for his depression, and he did relatively well.
Yeah, we had a doctor who really got in trouble for that because there was no, it was claimed that the real psychiatrists and the real psychologists were too far away, so that this young woman who lived frequently nearby would come in when she really felt that she needed it. He would give her a little squirt. She'd feel a lot better. She'd go home. Then she came back, and then it happened multiple times, and he thought he was really doing her a favor because getting professional care would have been really very difficult, and he got his hands slapped by the medical board.
She should have just gone and done some ayahuasca. All right. If you missed a class, we do have some of them on ccmelive.org, so you can check that out. The stream wasn't 100%, so I'm sorry about that, but we will work out all the bugs. And we do usually live stream this event, so the next time we have a course, keep an eye out, and you can maybe catch a lecture that you missed before. And then lastly, the medicine that I was putting in the ear, I believe it was saline for purposes of demonstration. However, normally I would use Ciprodex. And who was talking about drops?
I talked about the ears.
Yes, you did. It's all a blur right now.
And so there's several options where it's cortisporinotic, Ciprodex, but some of usually a quinolone or the neomycin mixture with a steroid, whether it's dexamethasone or Cortisporin, works well. They can be expensive. You can always use eye preparations in the ear, just can't put ear preparations in the eye. And sometimes it's actually cheaper to buy eye drops and use those in the ear than it is to buy the ear drops. GoodRx is a great tool, and I recommend it to patients all the time and pull them and go, hey, you can get it here for $12. Or I dispense it in the ER, that way they don't have to go buy it. I know they'll at least have it.
Right. Okay. Does anybody have any questions out there that they want to ask? All right. Well, we'll see you back here tomorrow. And
Meeting adjourned.
I meant to mention that we're starting early tomorrow for Pesky's talk. We've got 7:45, right? Oh, well, you've got to be here.
When I'm prepared at 2 a.m. when I drag myself back from
From the craps table.
7? If I win
7
earlier.
7 a.m. And I will say it is one of the best talks. It's really good. It's really good. All right, we'll see you next time.
All right.